Yes, good morning, students. Let us start today's discussion. So, good morning, namaste from my home language. So, this is a brief introduction about myself because you need to know with whom you are going to sit for next 2 days. So, today we will be discussing regarding respiratory medicine. So we'll be discussing regarding respiratory medicine. So am I audible to everybody? Yes? Audible to everybody? Yes, namaste, namaste. Okay. See, wherever I start medicine, this is the first question majority of students ask me. Sir, medicine is a big ocean, lot of confusion. What is the solution? So this is a common question that I should answer. So this is how I try to simplify medicine for everybody. For example, I am sitting in this room and I am speaking to you. It means there is something normally happening in my body which is making me to speak. So any process that is normally happening in my body, it is called as physiology. So kindly know this, anything right happening in your body, anything normally happening in your body, it is called as physiology. Now whenever I say my normal respiratory rate is somewhere 12 to 15 per minute, my heart rate is somewhere 70 to 80 per minute, don't think why it is normal, because it is God's given gift to your body. So anything right happening in your body, don't worry about it, it is physiology. Whereas anything wrong happening in the body, it is called as pathology. Now for example, there is a foreign body in patient's throat. There is a foreign body in patient's throat. So what is the pathology here? That foreign body. So whenever there is a pathology in your body will try to fight against that. So for example, if this patient is having a foreign body in his throat, how will his body fight against that foreign body? How will his body fight against that foreign body? Yes. So there is something in his throat. How will his body fight against it? Very simple. So it is going to generate increased cough reflex, increased respiratory effort. So if you see the clinical manifestations of this patient, there will be difficulty in breathing and there will be cough. So it means whenever there is something wrong happening in the body, your body will try to fight against it. The manner how it fights will manifest as clinical features. So very simple, anything right happening is physiology. Anything wrong happening is pathology. How your body fights against it will be the clinical features. This is the stage when this patient reaches my clinic for my assistance. I'm going to do clinical examination, and with help of tests called as investigations, I will come to a conclusion. So what are these investigations that I'm going to advise? So whenever I feel that this disease is due to some biochemical abnormality, what is the subject I should be knowing about? Biochemistry. If I feel this disease is due to some microorganism, what is the subject I should be knowing about? Microbiology. If my eyes cannot see what is happening inside the body, I need an imaging system to see inside the body. So what is the subject dealing with this imaging system? Yes, what is the subject dealing with this imaging system? It is nothing but radiology. Now with help of some investigations such as biochemistry, microbiology, radiology, I come to a conclusion called as, so what is that conclusion called as? Diagnosis. So what is meant by diagnosis? Gnosis means identification. That's why in CNS you are having some features called as agnosia. Agnosia means inability to identify. Gnosia, ability to identify. Dia, correctly identify. So to correctly identify what is happening inside the body, I should be knowing about the biochemical, microbiological and radiological, pathological basis of this given disease. Now after diagnosis, what is the next step? Now after diagnosis, what is the next step? Yes, after diagnosis, you should treat, or else nowadays patients will beat. So this is something routinely happening throughout the country. So to escape that beating, you should know the art of treating. So for treating, what is the subject you should be knowing about? What is the subject dealing with all these treatment drugs? It is nothing but pharmacology. It is nothing but pharmacology. So now if you consider medicine as a big field, it is actually made up of all the subjects put together. So in my discussion also, whenever I'm telling you a disease, first I'll tell you what is right happening in the body, what wrong or what problem has occurred in the body. So right is pathology. Sorry, right is physiology, wrong is pathology. How your body fights against it will be clinical features. How are you going to identify and how are you going to finally treat it? So whenever I simplify medicine like this, there will be few students again asking me the same question. Sir, again medicine is made up of so many systems. So how to follow all those systems? So this is how I keep systems in my body together. See, consider your body equivalent to traditional Indian family. So your body equivalent to traditional Indian family. Who will be the members of the family? So father, mother and few children. So don't ask how many, it depends upon their patience and persistence, that is secondary. So in my body, which system is considered as father of your body? So which system is considered as father of the body? So consider your body equivalent to family and there are systems, that is family members. Which system can be considered as the father of the body? See, everywhere I get the same answer, that is CNS, CNS, CNS. But see, what is the function of father in the body? Father in the family, he brings some raw material into the home. Your mother will receive it, she will cook it and feed all the children. So who is bringing the most vital raw material called oxygen into the body? It is respiratory system. So this respiratory system is the BAP of your body, father of your body. And who will receive that oxygen and feed all the children? That is CVS. So CVS will receive that oxygen and feed all the children. So that's why always father and mother are kept together in the body. Then only things will happen. So not those things. For proper functioning of the body, always father and mother should be kept together. Now who is the youngest child in the body? So who will be pampered most in the family? The younger ones. Whenever there is no sufficient oxygen in the body, so where will all the oxygen try to go? Your brain. So CNS is the youngest child in the body. So who are the elder children? See, what is the job of elder children in the family? Whatever mess these young people have created, they should clean it. So who will keep your body clean? Your liver and kidney. So this is my family, introducing you the father of the family or BAP of my body, that is nothing but respiratory system. Before going into medicine, I would like to tell you a famous quote by William Osler, who is considered as father of clinical medicine. So medicine is a science of uncertainty and art of probability. So science of uncertainty and an art of probability. So what does this mean? Science of uncertainty means, so there will be some features. For example, a patient reaches to you with a symptom called as shortness of breath. So for shortness of breath, there will be multiple diagnoses. See, if somebody asks you what is the reason for shortness of breath, so you will tell so many diseases. It can be due to cardiac cause, it can be due to renal cause, it can be due to respiratory cause, it can be due to GIT cause. But what exactly matters is with that given clinical scenario. So in that patient, with that given clinical scenario, so what is the most probable diagnosis you should identify? Most probable diagnosis you should identify. If you can understand the definition of medicine as given by the great William Osler, it is very easy to understand the medicine. So there is a single symptom which can have multiple diagnoses. Your expertise lies in not identifying all those multiple diagnoses. Your expertise lies in in that given clinical scenario, in that given patient, what is the most probable diagnosis responsible for shortness of breath? There will be multiple causes for shortness of breath, but in that given patient, what is the most probable diagnosis? There lies your art and expertise. So there lies your art and expertise. Now this will be the scenario of lot of medicos in this 1 or 2 years of your preparation. So you will be having lot of stress, worries, responsibilities regarding your career. This is slightly westernized version. Now putting this into Indian style or Desi style, this is actual position of medico. So this is the student. He will already be facing so many exams like this, and his parents will be asking him, when will you settle down, when will you settle down? And most important part will be the relationships. So the medicine is such a long duration. There will be so many relationships which will come and go, and breakups are something very commonly happening in this lifetime. So just wait for your chance to share your experience. And most irritating part in your career will be facing your neighbors. So facing your neighbors, they are just like crocodiles, alligators. So way back in 2011, actually, when I was giving my pre-PG exam, my neighbor used to come and ask my mother the same persistent question. Arey, your boy joined in 2005. Now it is 2011. Is he still studying and doing some sort of smuggling? See, there is something common between us and smugglers. What is that? Both of us work more during the night, whatever it is. So ultimately, you have to face all these insults. Then only you will get those desired results. Now coming to recent NEET PG trends. So what is happening in the recent NEET PG last year? So more of case scenario based bulky questions. So previously the questions were direct. They used to ask, what is the most common cause of this disease? What is the most common presentation? What is the investigation of choice? Now they have completely scrapped all those questions. So everything will be case scenario based bulky questions. And in that bulky question, there will be so many parameters. So they will be giving his blood pressure, investigations, radiology, they will be giving his echo, everything. But you should focus on what is important. So your talent lies in focusing on what is important. So in this picture, actually this fellow is focusing on her. This is not important. You should focus on this. This is important. If we focus on those distractions, his life will be gone after the second day. So that's why focus on what is important. So there will be a lot of distractions in the options. So don't focus on them. Focus on what is important. And understanding and applying the concept is the key. So you should not only understand the concept, you should know how to apply it in the given clinical scenario. So time management is also very, very important. So before I start, this is one thing I need everybody to know. So never let down yourself thinking that I'm an average or an ordinary student and I cannot do extraordinary things. So this actually happens with many of us during our MBBS career. We feel that we have not studied anything properly. Even I too feel the same today also. Even if I start studying from my final year or from my internship, you feel that you cannot achieve what is required. But the truth is, the difference between ordinary and extraordinary is only that little bit of extra effort, So we are going to put this extra effort now. So put that little extra effort needed to achieve those exceptional outcomes. So in these 2 days, we all will come together to put that little extra effort to convert ourselves from ordinary to extraordinary. So we shall all walk confident rather running confused. So we shall all walk confident rather running confused. So very important diseases, I'll tell you what is normally happening, what abnormality has happened. So how will you identify and how will you treat it? So whatever doubts you are having, I'll give you sufficient time in the break. We will discuss in detail. So all your doubts we'll discuss in detail. in the break. Kindly follow the lecture. So first topic is surfactant. See, even though surfactant is discussed well in pediatric population, only if you understand the functions of surfactant, you can understand few diseases in adult respiratory medicine. So surfactant is dipalmitoyl phosphatidylcholine. So all these were previously asked one-liners. So surfactant is predominantly made up of dipalmitoyl phosphatidylcholine, and it is produced by type 2 pneumocytes. So if they ask you what are the cells predominantly producing surfactant, it is type 2 pneumocytes. So again, this is a very important question, type 2 pneumocytes, because now in the COVID pandemic, these virus are infecting the type 2 pneumocytes by binding to ACE2 receptors, and it is removed by pulmonary alveolar macrophages. So very simple concepts. So what is surfactant? Predominantly made up of dipalmitoyl phosphatidylcholine. So where it is produced by type 2 pneumocytes. So many are asking, I have already attended the class. See, the concepts will be the same, but there will be some additions because in 6 months lot of things have changed. So you can just, no need to write anything, you can just follow, or you can later watch the recorded version, no issue. So produced by type 2 pneumocytes and removed by pulmonary alveolar macrophages. So what are the functions of surfactant? It decreases the surface tension and maintains alveolar stability. So it decreases surface tension and it will maintain alveolar stability, and also maintains a property of lung called as compliance. So what is meant by compliance? Compliance means stretchability. So compliance means stretchability. So what is this compliance? So we have a separate physiological basis of the disease today. There I'll tell you in detail. So now you should know, in your alveoli there is a substance called as surfactant which decreases the surface tension. It maintains alveolar stability and a property of lung called as compliance. So this surfactant production starts at 20 weeks. So it starts at 20 weeks. Highest at 35 weeks. So any baby born less than 35 weeks can develop a disease called as RDS. So what is meant by RDS? So RDS means respiratory distress syndrome. So RDS means respiratory distress syndrome. Because this is happening very early after birth, it is called as neonatal respiratory distress syndrome. Also called as, just write down, I will tell you in detail. Also called as hyaline membrane disease. Also called as hyaline membrane disease. Also called as hyaline membrane disease. So surfactant production starts at 20 weeks. It is highest at 35 weeks. Any patient born less than 35 weeks can develop a dangerous condition called as neonatal respiratory distress syndrome, also called as hyaline membrane disease. Now let us see what is normally happening first. First I'll tell you what is normally happening. So these are your alveoli, for example. So normally your alveoli, during inspiration they will open. During expiration they will close, but not completely, because there is a substance called as surfactant which keeps it open even at end expiration. So if you take a balloon, which is also an expandable structure, see balloon, if you take an ordinary balloon, if you blow some air into it, it will open. So if you release its neck, it will close. Whereas your alveoli, during inspiration it will expand. During expiration it will close, but not completely. So unlike a balloon, so why your alveolus is stable even at expiration without completely closing? Because there is a substance called as surfactant. Now what is happening in this disease? The surfactant production is decreased. So whenever there is no surfactant, your alveolus, just like a balloon, will completely close. So your alveolus at expiration, just like a balloon, will completely close. So whenever your alveolus is closing, during the next inspiration, to open this closed alveoli, should the baby generate more respiratory effort or less respiratory effort? So to open this collapsed alveoli, so baby has to generate more respiratory effort. So whenever the respiratory effort is increasing, there will be increased work of breathing. So whenever somebody is taking more and more respiration, will they be relaxed or will they be in distress? They will be in distress. So that's why this disease is called as respiratory distress syndrome, and it is happening early in life. It is called as neonatal respiratory distress syndrome. And point to be noted, this baby is premature. So in the baby's body, the energy resources will also be less. So there is respiratory distress and less energy resources. Baby will soon go into hypoxemia. So whenever there is hypoxemia, less oxygen in the body, majority of blood vessels in the body will undergo vasodilatation, except one circulation, that is pulmonary circulation. Because in the pulmonary vessels, there is a special feature. It has hypoxia sensitive potassium channel. So this is a special feature of pulmonary circulation. So whenever there is less oxygen, these potassium channels will react, resulting in pulmonary vasoconstriction. So where is this pulmonary artery located? It is located on the right side of the heart. So whenever the vessel constricts like this, the pressure in the right heart increases. Now when the pressure in right heart increases, what is going to happen? So this baby is already born premature. So in them, there can be a patent foramen ovale. So there is increased pressure in the right heart and there is a hole. So what will happen? Blood starts moving from right to left. So what is the nature of blood on the right side? It is deoxygenated. When it goes into the left side, mixes with the oxygenated blood and goes into the circulation, what is going to happen? Mixed blood will result in bluish discoloration of the baby. So this phenomena is called as cyanosis. And moreover, because of continuous hypoxemia, there will be damage to alveolar cells. And all these damaged alveolar cells will form a fibrous layer. When you see under microscope, will appear very pink. So this pinkish layer of dead cells seen under microscope, it is called as hyaline membranes. So I hope you have understood why there is respiratory distress, why there is hypoxemia, why there is cyanosis and formation of hyaline membranes. So whatever we have discussed up to now, let us put it into a flowchart. So very important flowchart, pathophysiology of surfactant deficiency. So normally at expiration, so in a normal baby at expiration, your alveoli will be completely open like this. So why they are completely open? Because there is a substance called as surfactant inside. There is a substance called as surfactant inside. So whenever there is surfactant deficiency, so whenever there is surfactant deficiency, just like a balloon, your alveoli will close completely. So alveoli collapsed. So whatever I have discussed up to now, I am putting into a flowchart. So alveoli will be collapsed like this. Now tell me, to open this collapsed alveoli, so to open the collapsed alveoli, now the baby has to put more respiratory effort. So there will be increased work of breathing. So WOB means work of breathing. So increased work of breathing. WOB means increased work of breathing. So whenever somebody is putting more effort into respiration, they will develop respiratory distress. As simple as this. Now this baby is born premature. So in the body, there will be less energy resources. So because of that, baby will soon go into hypoxemia. Hypoxemia. So whenever there is hypoxemia, because of special feature of pulmonary circulation, that is potassium channels, hypoxia sensitive potassium channels, there will be a phenomena called as pulmonary vasoconstriction. Pulmonary vasoconstriction. So where is the pulmonary artery located? On right side of the heart. So that will result in increased right heart pressures. Applying some simple physics. Now the pressure in the right heart has increased and this baby is born premature. So there is a patent foramen ovale. So through this hole, now blood from right heart moves into the left heart. So this phenomena is called as a right to left shunt. Now because of mixing of good blood and bad blood, baby will turn into blue. What is this phenomena called as? It is called as cyanosis. Because of continuous hypoxemia, there will be damage to alveolar cells. There will be damage to alveolar cells. And all these damaged cells will form a fibrous layer. All this damaged cell will form a fibrous layer. And this fibrous layer, when you see under microscope, will appear pink. So what is this pinkish membrane? Also called as a hyaline membrane. Hyaline membranes. So all these damaged alveolar cells will appear excess pink. This is called as hyaline membranes. So key points that you should know is why there is respiratory distress. So why there is a hypoxemia. So why there is cyanosis and why there is formation of hyaline membranes. So this is the pathophysiology of surfactant deficiency. Now a simple clinical question. Whenever a patient with chest pain reaches your hospital, what will be the next investigation generally? So what will you advise patient with chest pain? So generally you will advise an ECG. In the same way, whenever a patient reaches with some respiratory discomfort or breathing discomfort, what is the next investigation that you generally advise? So breathing discomfort, if there is some breathing discomfort, so you generally advise a chest x-ray, a simple chest x-ray. For majority of respiratory disorders, you advise a simple chest x-ray. Now how to approach to a disease on chest x-ray, I will tell you. See, let it be any physiology or pathology on a chest x-ray, it will manifest in only two colors. So what are the two colors that you can see on a radiology film? Say you feel that radiologist's life is very colorful. Actually their life is very boring because they have to see only two colors generally. One is black, other is white. See what normally appears black on chest x-ray. What normally appears black on chest x-ray? Anything containing air. So your lungs, because they are containing air, they have to appear black. Now what appears white on chest x-ray? So what appears white on chest x-ray? Yes, instead of telling it as a heart, diaphragm, bones, simple logic. Anything containing air will appear black. Anything containing less air or no air should appear white. Air black, less air or no air should appear white. So if you take in a normal individual, why is your heart white? Because it is filled with blood, no air. Why is your diaphragm white? It is a muscle, no air. Why are your ribs white? It is a bone, no air. So simple logic, anything containing air will appear black. Anything containing less air or no air will appear white. Now how to approach to a disease on a chest x-ray? So there are 4 important steps. So first one is, will the given disease cause a whitish abnormality or blackish abnormality? So a given disease cause a whitish abnormality or blackish abnormality. So second thing is, so this abnormality, whether it is localized or more diffuse. So whether it is localized or more diffuse. And third step is, what is the specific pattern of the abnormality? And fourth is, you should correlate clinically with the given condition that we physicians will do. So important steps, what will be the color of abnormality of the disease? Whitish abnormality or blackish abnormality? What is the extent of the abnormality? Is it localized or diffuse? And what is the specific pattern of that abnormality? Now let us see in this condition called as hyaline membrane disease. Now with this pathophysiology, now tell me what will be the color of abnormality. So what will be the color of abnormality on the chest X-ray? What will be the color of abnormality on the chest X-ray? Yes. So it will be white, because normally your alveoli are filled with air. So now they are getting closed, no air. So it will be a whitish abnormality. Now second thing, extent of abnormality. Will it be localized or will it be diffuse? See, whenever surfactant deficiency happens, it will happen throughout the lungs. So bilaterally. So it will be bilateral whitish opacities. So you will see bilateral whitish opacities. And what is the specific pattern of the abnormality? So initially your alveoli are tiny structures. So whenever they close, you will see bilateral whitish dots. So this whitish dots is called as granular pattern. So first important is bilateral granular pattern. So after some time it will become still more white. So this phenomena is called as ground glass opacity. Still white, this is called as consolidation. Completely white, this is called as white outline. So granular pattern, ground glass opacity, consolidation and white outline are nothing but increased degree of whiteness with respect to severity of the disease. So write down the radiology in this disease. So radiology in the disease, initially you will notice bilateral whitish dots. So bilateral granular pattern. Bilateral granular pattern. Then still more white. Bilateral ground glass opacity called as GGO. Then bilateral consolidation. Then bilateral white outline. So bilateral white outline. So out of this, which can be considered as more severe disease? Bilateral white outline, because completely the lung is now not having air. So these are the radiological manifestations. So now coming to treatment. So in mild to moderate cases, so don't worry about these radiological images, these patterns. When we discuss various respiratory diseases, I will show everything. What is ground glass, what is consolidation, what is granular pattern, what is white outline. So in mild to moderate disease, we usually give oxygen plus CPAP. So what is meant by CPAP? It is continuous positive airway pressure. So how this CPAP works? When we discuss obstructive sleep apnea, I will let you know in detail. In severe cases, these patients may require invasive mechanical ventilation. Invasive mechanical ventilation. Along with that, what is the problem here? Surfactant deficiency. So we are going to do surfactant replacement. So how it is done, it would have been discussed in your pediatrics. So in mild to moderate cases, so we can give oxygen plus CPAP. In severe cases, the baby might require invasive mechanical ventilation. Along with that, surfactant replacement. So this is again discussed in your pediatrics, just for you to understand the function of surfactant and what happens if surfactant becomes less, because there are few adult diseases that you should know later on based on surfactant. That's why I have discussed. Now let us see one case scenario. So case 1, so yesterday I have put those questions in the club. So again, after the class, I'll put all these images in the club, don't worry. So case 1, so there is a preterm baby with tachypnea. So preterm baby with tachypnea within 4 hours after birth. Within 4 hours after birth, chest x-ray is shown. See, neonates, will we do chest x-ray? We generally do if there is a problem in that neonate. So what else you want to do? Yes. So don't worry, in pediatrics it will be done in detail. Surfactant deficiency is most important topic. So preterm baby with tachypnea and cyanosis within 4 hours of birth, chest x-ray is shown. So what do you notice in chest x-ray? I want you to tell me. So can you see in this chest x-ray bilaterally the lung fields are not appearing white, are not appearing black, they are appearing white. If you keenly see, you can see some whitish dots. So this whitish dots is nothing but bilateral granular pattern. So we have a baby, preterm baby, tachypnea, cyanosis, and chest x-ray is showing a bilateral granular pattern, So what will be the diagnosis? So diagnosis is nothing but neonatal respiratory distress syndrome. So the points are preterm, tachypnea, cyanosis immediately after birth, and you are having x-ray showing bilateral granular pattern. So sometimes they may modify the question like this. They will give you the clinical scenario and they'll ask you, if at all a lung biopsy is taken from this baby's lung. So we generally will not do lung biopsy. It is just an autopsy finding. If at all a lung biopsy is taken from this baby's lung, what do you see under microscope? So what do you see under microscope? So you see pinkish areas. Called as hyaline membranes. So in that biopsy, if at all it was taken, okay, this is normal pink. So all these are normal pinkish areas. Can you see excess pink here? Yes, excess pink. So what are all these excess pinkish areas called as? What are they called as? Hyaline membranes. So these are called as hyaline membranes. So now we have discussed regarding surfactant deficiency. What is the physiology? What is the pathology? What is the radiology? And finally the treatment aspects. Even though this is a disease that you see only in pediatric population, but why are we discussing in adult respiratory medicine here? Because there is a disease with similar presentation happening in adults. So what is that disease called as? So disease with similar presentation happening in adults. It is the famous ARDS. Acute respiratory distress syndrome. It is acute respiratory distress syndrome. Only if you understand the functions of surfactant, you can understand ARDS better. So somebody is asking what is the treatment for severe case. I have told you, invasive mechanical ventilation plus surfactant replacement. So it is given here, invasive mechanical ventilation with surfactant replacement. So this will be discussed very well in pediatrics. Now we have understood surfactant deficiency disorder. Now my question is there any disorder happening in adults due to surfactant excess? Any disease happening in adults due to surfactant excess? See, anything excess is also not good. So such surfactant excess disorder happening in adults. What is the name of that disorder? Pulmonary alveolar proteinosis. So we have discussed up to surfactant deficiency. Now let us see surfactant excess disorder, pulmonary alveolar proteinosis. Here the defect is surfactant clearance impairment. Normally, what are the cells that produce surfactant? Simple, type 2 pneumocyte. What generally clears the surfactant or removes the surfactant? Pulmonary alveolar macrophages. Now the problem here is there is clearance impairment. So what is the issue? Your macrophages are not functioning properly. So etiology can be divided into two forms. we have a primary form, which is most common form, and there is secondary form. So this primary form is due to autoantibodies against granulocyte, macrophage, colony stimulating factor. So written as GMCSF. So this granulocyte macrophage colony stimulating factor is responsible for proper formation of alveolar macrophages. So whenever there are autoantibodies, this factor cannot function properly. Alveolar macrophages are not formed properly, so surfactant will not be cleared properly. Secondary form is due to acute silicosis. So whenever there is a huge exposure to silica within short duration, it is called acute silicosis. So what is the relationship between silica and alveolar macrophages? So actually silica when inhaled will be toxic to alveolar macrophages. So silica is actually toxic to alveolar macrophages. So whenever huge amounts of silica go into the lung, it will destroy the alveolar macrophages, damages the alveolar macrophages, not allowing the surfactant clearance. Now with this background, if at all somebody is exposed to silica for chronic duration, chronic silicosis, what is the infection that can happen in their lungs? So in chronic silicosis, so what is the infection that can happen in their lungs? It is nothing but tuberculosis. So that's why this entity are called as silicotuberculosis. See, why tuberculosis? What is the first line of defense in the lungs against TB bacilli? Alveolar macrophages. Now silica particles are not allowing alveolar macrophages to function properly. So TB bacilli defense mechanism, against the TB bacilli the defense mechanism is down. So they proliferate easily and will be responsible for tuberculosis. So in the question, if they mention acute silicosis, so think about alveolar proteinosis. If they mention about chronic silicosis, think about tuberculosis. Now coming to the pathophysiology. So consider this is the alveolus, normally filled with air, but now it is getting filled with excess surfactant. So alveoli are getting filled with excess surfactant. Now whenever alveoli is getting filled with excess surfactant, now there will be oxygen not going into the alveoli into the blood. So there will be decreased transfer of oxygen. So if there is no such barrier, oxygen can easily go into the blood. Now oxygen is not going into the blood, so that will result in hypoxemia. So see this peculiar feature. Surfactant deficiency was causing hypoxemia. Surfactant excess will also cause hypoxemia. Now for diagnosis, it is based on a triad. So there are three important features. So point to be remembered is surfactant is a whitish colored substance. So if they ask you what is the color of surfactant, it is white. So for diagnosis, now if I put my bronchoscope into the lung and take some fluid from the lung, what is this sample called as bronchoalveolar lavage? So this lung is filled with whitish fluid. So if I put a bronchoscope and take that fluid, what will be the color of the bronchoalveolar lavage? It will be white. So bronchoalveolar lavage will be milky white. and if you subject it to special staining, it will be PAS positive. It will be PAS positive. So PAS is a special stain called as periodic acid skiff stain. Because of contents of surfactant, the ball will be PAS positive. And if at all a CT chest was taken, there is a classical pattern called as crazy paving pattern. There is a classical pattern called as crazy paving pattern. So if at all a CT chest is taken, you see a classical pattern called as crazy paving pattern. Now coming to the treatment part. So if they ask you, what is the treatment of choice? Now the lung is filled with excess surfactant, not allowing oxygen to go into the blood. Patient is having hypoxemia. So effective treatment will be putting a bronchoscope into the lung and sucking out all the excess surfactant. So this phenomena is called as a whole lung lavage. So treatment of choice in this condition is whole lung lavage. So what is crazy about this crazy paving pattern? I'll show you in the next slide. Don't worry. If they ask you the treatment of choice, it is whole lung lavage. So BAL means bronchoalveolar lavage. BAL means bronchoalveolar lavage. So can't we see on this chest X-ray? Chest X-ray you'll only see a whitish densities. You cannot see the precise crazy paving pattern. See, if at all you are able to see everything on chest X-ray, there will be no need of CT chest. See, it is all what you call hierarchy of investigations. So chest X-ray will give you a rough idea. CT scan will help you to see very well. See, if everything can be seen under microscope, what is the use for a light microscope? What is the use for electron microscope? So always whenever I am discussing investigations, I have an open mind. So think that because it is not able to be seen on chest X-ray, we are going for CT chest. Okay. See, the question is one good question. So will it not form after lavage? So definitely it will form after lavage. So what you do, recurrence is common. See, if it is a secondary form, once you decrease exposure to silica, the disease will not happen. But if it is a primary form, after few months, again surfactant will reaccumulate. Even in recurrences also, as of now, only available treatment is whole lung lavage. So what is the reason for hypoxemia in pulmonary alveolar proteinosis? Very simple. So there is alveolus where oxygen used to go easily into the blood. Now there is a fluid called as surfactant which will not allow oxygen to go into the blood. So a barrier was filled. So clinical features, Shishikant B, clinical features of hypoxemia. See, what will happen when less oxygen is there in your body? So you will have shortness of breath. Yes? Yes or no? So when there is hypoxemia, you will have shortness of breath. See, this is a stain, bronchoalveolar lavage. If you stain with a special stain called as PAS, it will be positive. So PAS positive. See, it can also happen in neonates, it can happen in children, but what we are discussing here is adults. In adults, these are the causes. So explain silicotuberculosis in chronic silicosis. So chronic silicosis, silica particles are toxic to alveolar macrophages. Alveolar macrophages are first line of defense against TB bacilli. So whenever your alveolar macrophages are not functioning, TB bacilli will grow easily. So is there any medical treatment? There is no medical treatment. So why can't we do surfactant replacement here also? Soham Malik, I think you have understood the concept wrong here. The problem is surfactant excess. Already there is a patient with poisoning. Will you infuse more poison in his body? No. You will just do Ryle's tube removal. This is also the same thing. More fluid in the lungs, that is surfactant is more. You put a bronchoscope and remove it. I am telling it in a very, very easy and raw language so that you can understand. Okay. So generally, yes, crazy paving pattern. Will chronic silicosis cause PAP? No. In chronic silicosis, it will not cause PAP. Yes. Next is the images. So this is the milky white bronchoalveolar lavage. So milky white bronchoalveolar lavage. See, whatever I have said is, if you think for 2 minutes, you will understand this. So I have told you in a clear language. So there is, so I'll just tell you in a very raw language then. So lung is filled with a whitish colored fluid. So how do you remove that whitish colored fluid effectively? Put a tube in the lung. That tube is called as bronchoscope, and whatever you take out from the bronchoscope, that substance is called as bronchoalveolar lavage. So can't we give immunosuppressants? They have tried immunosuppressants, but it was not working. So why milky white color of surfactant? See, blood is red, surfactant is white. So why blood is only red? Why can't it be black? Why can't it be green? Please ask God. Even I don't know. Okay. So I think you are all asking philosophical questions. Why is surfactant white? Why is blood red? Why is sputum green? Why is sputum yellow? So those are something generally happening. Okay, so this is milky white bronchoalveolar lavage. So milky white bronchoalveolar lavage. So now coming to the classical CT chest finding. Classical CT chest finding. So before that, let us see this image. Before that, let us see this image. See, whenever you go to a park and if you see pavement where generally people walk, there you can see polygonal shaped stones arranged in an irregular manner. Polygonal shaped stones arranged in an irregular manner. So this is a pavement. This is called as a pavement pattern or paving pattern. And because stones are arranged in an irregular manner, anything irregular, it is called as crazy. So first of all, know why the term crazy paving pattern came into existence. So crazy paving pattern means, so crazy paving, so stones are arranged, polygonal shaped stones in a pavement were arranged in an irregular manner. So this you can see on majority of pavements. So because they were arranged in an irregular manner, it was called as crazy. This is pavement. It is called as crazy paving pattern. It is called as crazy paving pattern. Now coming to the CT chest. So the person who has first identified the CT chest of a patient with pulmonary alveolar proteinosis was very much obsessed with parks. He felt that lung architecture was also looking like polygonal shaped structures arranged in an irregular manner. See, try to find out similarity between these two images. So medicine is, you should have some creativity and imagination. So it will be not like a Xerox copy. So don't tell me, sir, here it is of different color, here it is of different color. Why did he think like that? See, it is imagination and creativity. He felt that even lung architecture was looking like polygonal shaped stones arranged in an irregular manner. So it was similar to this pattern. So it was called as crazy paving pattern. Crazy paving pattern. So this phenomena is crazy paving pattern. Crazy paving pattern. So now the question, why is it appearing white? So majority of the lung fields are appearing white. Majority of the lung fields are appearing white. What is the reason? Because normally alveoli are filled with air, but here instead of air, it is filled with surfactant. So anything filled with any fluid, or instead of air, anything having less air or no air will appear white. So if they ask you the radiological features, bilateral whitish areas, and the specific pattern is crazy paving pattern. So why did the name come? Because your lung architecture was looking like polygonal shaped stones arranged in an irregular pattern. So this is called as crazy paving pattern. Now let us see some case. A 39-year-old stone crusher. So we know the famous stone crusher from Avengers. So presented with progressive dyspnea on exertion for 5 months. So he had long-standing cough, whitish sputum. See, whitish sputum, but no fever, chills, weight loss. The patient undergoes bronchoscopy. I have done a bronchoscopy with bronchoalveolar lavage. So the effluent was milky white. So it was milky white. And the cytopathology shows PAS positive areas. So PAS positive macrophages. So what is the diagnosis? Yes. So we do bronchoalveolar lavage and CT in all hypoxemia cases. When it is not explained, we can do. Yes. So Thanos ultimately destroys all the stones. So he can be called as a stone crusher. Initially stone collector, later stone crusher. You should follow the whole movie completely. Yes. So what will be the diagnosis? So he had progressive dyspnea, bronchoscopy, whitish fluid. So it is a direct question. So it can be pulmonary alveolar proteinosis. Now let us exclude other options. So why it is not tuberculosis? See, even though in silicosis tuberculosis appear, so stone crusher is exposure to silica. So silica exposure, stone crusher is exposure to silica. So his occupation is silicosis. He can develop tuberculosis, but there is no fever, chills, weight loss, night sweats. So the clinical features of tuberculosis are not there. So is it a community acquired pneumonia? So community acquired pneumonia, again there will be fever. And it will not be for 5 months. So pneumonia generally it happens within days to weeks. So why it is not just silicosis? See here the risk factor is silicosis, but the present manifestation in the patient is pulmonary alveolar proteinosis. So somebody must have ticked it as silicosis. I'll tell you an example. So there was a patient who is obese. So because of obesity, he developed a chest pain and ECG was showing myocardial infarction. Now will you write diagnosis as obesity or myocardial infarction? So you will write diagnosis as myocardial infarction. There obesity is a risk factor. In the same way here, silicosis is the risk factor and the manifestation that has developed in the patient is pulmonary alveolar proteinosis. So what is the age of onset in this disease? It depends upon the exposure. So if it is a secondary form, if he is exposed to silica for 2 or 3 years, continuously high loads, it can occur. So D is the better answer here. Now coming to some basic Weibel's lung model. So according to Weibel, your airways starts from large central airway. So large central airway is your trachea. See here there is exposure, stone crusher. Stones will have silica. He is exposed to silica there. So will whole lung lavage be done repeatedly? Yes. So you can do it today. Again you take a CT chest or you assess the patient clinical scenario. If he is having hypoxemia, again you can repeat it. So Weibel's lung model, your large trachea finally gives rise to tiny structures called as alveoli. So there are about 23 generations of airways. 23 generations of airways. So let us see some important divisions. So large central airway. So this is the trachea. So important divisions of your airway for better understanding. So trachea will give rise to a principal bronchus. Principal bronchus. And from the principal bronchus, you will have next structure called as lobar bronchus. So I think this is clear. Right lung has 3 lobes. Left lung has only 2 lobes. So you must be clear. Right, there are 3 lobes. Left, there are only 2 lobes. So from the lobar bronchus, there will be next division called as segmental bronchus. Segmental bronchus. So segmental bronchus. So from lobar bronchus, it will become segmental bronchus. See, for silica exposure, acute is generally 1 to 2 years. So chronic means 5 to 15 years. So don't take that 5 months something as chronic. So acute and chronic differs from different diseases. Don't take a single symptom and say here it is acute, there it is chronic. So principal bronchus, lobar bronchus, segmental bronchus. Principal bronchus, lobar bronchus, segmental bronchus. After that there will be so many divisions, later giving rise to a terminal bronchiole. So there will be subsegmental bronchi, many divisions, but we'll only discuss clinically important relevant branches, terminal bronchiole. So from the terminal bronchiole, next we have respiratory bronchiole. From the terminal bronchiole, next we have respiratory bronchiole. So from the respiratory bronchiole, we have ultimate structures called as alveolar duct and alveolar sac. They are called as alveoli. So this is how a large central airway called as trachea finally gives rise to tiny structures called as alveoli. Large central airway called as trachea finally gives rise to tiny structures called as alveoli. So there are few questions that were asked previously. So let us see them. Up to what level in this division, up to what level is considered as, up to what level is considered as dead space, and which part is called as functional unit. Functional unit, also called as ventilatory unit, also called as acinus. So these are some frequently asked questions. Now what is meant by dead space? I think most of you must be knowing this definition. What is meant by dead space? So dead space is area of ventilation but no perfusion. Area of ventilation but no perfusion. So in my lung, up to terminal bronchiole. So up to this area. So up to terminal bronchiole. So this is something normally happening. Up to terminal bronchiole, there will be ventilation but no perfusion. So this area is called as dead space. Up to terminal bronchiole, there will be ventilation but no perfusion. It is called as dead space. Now beyond that, gaseous exchange starts, and most importantly happens in alveoli. So this area, distal to terminal bronchiole, this area distal to terminal bronchiole, where the major function of lungs called as ventilation happens, it is called as acinus. So why it is called functional unit or ventilatory unit? Because the major function of the lung is ventilation. It doesn't happen up to terminal bronchiole, it happens distal to terminal bronchiole. So this area is called as functional unit, ventilatory unit, acinus. So I am not worried about the anatomy and physiology. What I am worried about is how it is helpful for me in learning medicine. See how it is helpful for me in learning medicine, because there is a condition called as emphysema. There is a condition called as emphysema. Now how will this knowledge help me in treating a patient with emphysema? So emphysema, what is the definition of emphysema? It is destruction distal to terminal bronchiole. It is destruction distal to terminal bronchiole. So what is present distal to terminal bronchiole? Acinus. So in emphysema, preferentially the gas exchange areas are getting destroyed. So whenever the gas exchange areas are getting destroyed, will there be proper gaseous exchange? No, there will be impaired gaseous exchange. So in a patient with emphysema, if he is presenting with impaired gaseous exchange, what I should know? So in these patients, there is destruction of acinus. So that's why gaseous exchange will not be happening. There will be no proper gaseous exchange. That's why you must have learnt in your pathology the types of emphysema. What are types of emphysema? Yes, centri-acinar emphysema, pan-acinar emphysema, distal acinar emphysema. Because acinus is involved, it was classified based on the area of acinus involved. So emphysema is a very important disease clinically, COPD. there will be destruction of acinus, so there will be impaired gaseous exchange. So they're asking me the definition of dead space. So dead space means there is ventilation but no perfusion. There is ventilation but no perfusion. So there will be ventilation but no sufficient perfusion. So there is nothing to confuse because that is the definition of dead space anywhere. So this is regarding the Weibel's lung model and why in emphysema there is impaired gaseous exchange, because the gas exchange areas are destroyed. Now because gas exchange is not happening properly, always the patient will try to take more and more breath, so he will be having shortness of breath and tachypnea. Now coming to aspiration versus bronchiectasis. So BXIS means bronchiectasis. So with respect to the lung anatomy, how will aspiration and bronchiectasis differ? So they'll ask you in which side of the lung aspiration commonly occurs and in which side of the lung bronchiectasis commonly occurs. So what is 23 generations? Great grandfather, grandfather, father, his child and his child. So this is the generation of a family. In the same way, generation of airways, trachea, it starts there, principal bronchus, lobar bronchus, segmental bronchus, terminal bronchiole, respiratory bronchiole, alveoli. Like that there are 23 generations of airways. Like that there are 23 generations of airways. See, kindly concentrate, everything is simple. You are asking very questions that can you understand by common sense. See, what I feel is medicine is only based on common science, common sense, not rocket science. So kindly remember it. So you should know the common science happening in the disease. You try to think with some common sense, you will get the answer. Medicine is not at all rocket science. Okay. Aspiration versus bronchiectasis. So the lobar involvement or predilection to this side. So this is large central airway, trachea. So trachea. So from the trachea you have a right main bronchus and left main bronchus. Right main bronchus and left main bronchus. So now they'll ask you on which side aspiration is more common, on which side bronchiectasis is more common. Now if you see right main bronchus, anatomically it is short when compared to left. It is stout and it is bit straight. So because of that, any fragment or substance reaching the trachea, so what will be its tendency? Its tendency will be to fall more onto the right side. So because of this anatomical difference, there is more chances of aspiration. There is more chances of aspiration on the right. So right side, there is more chances of aspiration. Now coming to left main bronchus, this is narrow, angulated. So because of the narrow angulated anatomy, there will be less drainage of secretions. So if at all some secretions are formed, there will be less drainage of secretions. Less drainage of secretions. Now, if you see here, for example, if anything reaches the right side, some secretions or anything reaches the right side, it is very easy to come in, and if patient has a very good cough reflex, he can easily throw it out also. But what happens on left side, if some infection or some secretions unfortunately creeps onto the left side, see here, if it is creeping in, so it will be very difficult for the patient to cough out secretions from the left into outside. So because of that, of less drainage of secretions. So whenever there is less drainage, there will be stasis of secretions. There will be stasis of secretions. So when secretions are getting static there, what will happen? There will be immediately formation of some infection. So infections. That infections can result in inflammatory damage. So inflammatory damage. Because of that inflammatory damage, there will be destruction and ultimately dilatation of bronchi. So destruction and dilatation of bronchi. So what is this phenomena of destruction and dilatation of bronchi called as? It is called as bronchiectasis. So point to remember, on the left side, what is going to happen? Secretions will pull up easily. So when secretions are staying there, so there will be infections, inflammatory damage, destruction, dilatation of bronchi, ultimately leading to bronchiectasis. So if they ask you, commonly, where does aspiration happen? Right side. So where does bronchiectasis happen? Left side. So on the left side, bronchiectasis is more common. On the right side, aspiration is more common. Now if they ask you, bronchiectasis is now common on the left side. Is it more common in the upper lobes or lower lobes? See, if at all something is in upper lobe, it can be easily sent out when compared to lower lobes. So because lower lobes are very deep inside, so what happens now? More common in lower lobes. So bronchiectasis is common in left side. So in that left side, it is more common in lower lobes. So these are the important points that you should know. So when they ask you about bronchiectasis, it can happen on both sides, but more commonly on the left lower areas, and aspiration generally on the right side. So now with this background, next question is, depending on the patient's position, they will say that patient is sitting like this and he has aspirated, or patient is in supine position and he has aspirated. So what will be the precise bronchopulmonary segment involved? So see why dilatation occurs. When I discuss bronchiectasis in detail, I'll tell you there, don't worry. Okay. So the next question is, you know that aspiration is frequently happening on the right. So we have understood aspiration is on the right. Now on the right side, based on patient's position, what is the bronchopulmonary segment involved? So bronchopulmonary segments and aspiration pneumonia. So bronchopulmonary segments and aspiration pneumonia. So these are the questions. First note down the questions. Most common segment involved in aspiration pneumonia overall. Supine position, sitting or standing position. So most common segments involved in aspiration pneumonia overall, supine position. See, aspiration on the right side, according to patient's position, it will change. So that I am discussing now. So most common segment involved in aspiration overall, supine position, sitting or standing position. Now first of all, let us see in whom aspiration frequently occurs. Now my question is, there is a patient with good neuromuscular reflexes, another patient with deranged neuromuscular reflexes, in whom aspiration frequently occurs. So those with impaired neuromuscular reflexes, because their nerves and muscles are not functioning properly, their cough reflex will not be proper, so they can aspirate the contents of oral cavity into the lung. Now if at all these patients' nerves and muscles are not functioning properly, will they be actively moving or will they be bedridden? They will be bedridden. And a patient who is bedridden, what is the most common position that he will be placed in? A bedridden patient, generally supine position. Now tell me whether these statements are true or false. Aspiration pneumonia commonly occurs in bedridden patients. True statement or false statement? Aspiration pneumonia frequently occurs in bedridden patients. True. And bedridden patients are generally placed in supine position. Is it true or false? True. So the answer for both overall and supine position will be the same, because aspiration pneumonia frequently occurs in bedridden patients who will be in supine position. Aspiration pneumonia frequently occurs in bedridden patients who will be in supine position. So now, to understand the precise segment involved, you should know the anatomy of right lower lobe first. So if you see the lung, so in the right lower lobe, there are about 5 bronchopulmonary segments. In the right lower lobe, there are about 5 bronchopulmonary segments. So we have a medial segment, a superior segment, anterior segment, lateral segment, and posterior segment. So in the right lower lobe, there are 5 bronchopulmonary segments. I am trying to show it here. Okay, so you have a medial segment. So this everything is the superior segment, anterior segment, lateral segment, and beneath it posteriorly is the posterior segment. Okay, so now whenever somebody is sitting and standing and aspirating, so by gravity, whenever you throw an object into the ground, it will reach the most dependent part. So that is rules of gravity set by Newton. So don't ask me what is gravity now. So if a patient is sitting like this and aspirating, so he was eating something and suddenly it got aspirated into his body, into his lung. So which is the most dependent segment in sitting or standing position? This part. So what is the segment here? Right lower lobe posterior segment. So when he sits or stands, by gravity, this posterior part is dependent portion and it is the lowermost portion. So it will reach here. So the answer for right lower lobe, the sitting or standing position is right lower lobe posterior segment. So the answer for sitting or standing position is right lower lobe posterior segment. Now the answer for overall or supine position. So overall or supine position. Now if the patient is sitting or standing like this, this is the dependent part. So when he lies down like this, even if you lie down, so the area adjacent to the scapula will be closer to the ground. See, whichever area is closer to the ground, that is the most dependent area. So if you stand like this, the posterior segment is closest to the ground. So it is right lower lobe posterior segment. Now if you lie down like this, the area adjacent to the scapula will be closer to the ground and that will be most involved. So what is the area adjacent to the scapula? It is right lower lobe superior segment. See, if you touch your scapula, everybody touch your scapula. So adjacent to the scapula, you have right lower lobe superior segment. So just above it, you also have right upper lobe posterior segment. So that is the anatomy, right upper lobe posterior segment. So very simple. I'll just show you here. So this is right lower lobe posterior segment. So this is superior segment. If patient is standing like this, it reaches here. So right lower lobe posterior segment. If he lies down like this, because of anatomy of your scapula and lung, so this part is more dependent. So right lower lobe superior segment, and some portion can also go into right upper lobe posterior segment. So very simple. You just touch your lungs. So the lowest part is posterior segment. So if you sit or stand, if somebody aspirates, it will reach there. So if you lie down in supine position, area beside the scapula will be touching the ground more. So that area is right lower lobe superior segment predominantly, and some part can also go into right upper lobe posterior segment. So this is something you should remember. Just a minute. So keep this in mind. So in sitting or standing position, it is posterior segment. So if they ask you, I'll give you also a mnemonic. In supine position, it is superior segment. So keep this in mind. In supine position, it is superior segment. And frequently, these aspirated substances can be foreign bodies. So foreign bodies, radiologically, they can be divided into two types. If you can clearly see the opacity on the chest X-ray, they are called radio opaque foreign bodies. So sometimes you cannot see the opacity on the chest X-ray. They are called as properly, they are called as radiolucent foreign bodies. Now can you tell me the example for radio opaque foreign bodies? Radio opaque foreign bodies. Can you tell me radio opaque foreign bodies? Yes, generally metals, coins, all those are radio opaque. Along with the teeth. Teeth when aspirated can also become radio opaque. Radiolucent, if metals are radiolucent, if metals are radio opaque, plastic. So plastic is radiolucent. Wood is also radiolucent. And food particles are also radiolucent. So metals, coins, teeth, radio opaque. Wood, plastic and food particles will be radiolucent. Now I'll give you an example. Tell me what has happened. There was a 45-year-old female. She recently had a dental implant. Next day morning when she woke up, there was no dental implant in her oral cavity. She came running to my clinic. I have taken a chest X-ray. So what must have happened in that patient? Yes? What must have happened in the patient? So she had a dental implant recently. Now when she woke up in the morning, there is no dental implant in her oral cavity. She came to my clinic. I have taken a chest X-ray. So in this chest X-ray, can you see an opacity similar to the dental implant? Yes. Can you see an opacity similar to the dental implant? Yes. So what must have happened during her sleep? That dental implant must have dislodged and must have gone into her lung. So she has aspirated. So the advantage with radio opaque foreign bodies is, you know where exactly the foreign body is present. You can put your bronchoscope and remove it easily. Now the problem is, whenever there is a radiolucent foreign body, you will have some diagnostic dilemma. Now how to solve the diagnostic dilemma, I'll tell you with help of a clinical scenario. So this was also one of my patients. His wife was out of town and he had a big alcohol party at home. So this generally happens to us middle-aged males. So after having that alcohol party, he suddenly developed some respiratory discomfort. He was brought to our emergency department. So immediately I have taken a chest X-ray. So this was the chest X-ray. So whenever there is an alcohol party, always suspect aspiration. So alcohol party, he has aspirated. Then he was brought to my emergency department. I have taken a chest X-ray. You can observe in this chest X-ray, this is right lung, this is left lung. So left lung is black, completely filled with air and it is completely expanded. Whereas right lung, you can see it is showing some homogeneous whitish density in the lower part, mid and lower zones. So this homogeneous whitish density, it is called as collapse. So once again, I will show you collapse in clinical findings. There you will find all the X-rays. So this homogeneous white, it is collapse. So you can notice aspiration and collapse on chest X-ray. So whenever you find these two in combination, what must have happened? See what must have happened? He must have aspirated. So in that aspiration, whenever the foreign body is large enough, it will go into the bronchus, it will occlude the bronchus. So whenever it occludes the bronchus, the air will not go into the bronchus. After some time, the area beneath the bronchus will be completely devoid of air. Any airless lung field on chest X-ray, airless lung field on chest X-ray, it is called as collapse. You can see the clear difference. This area was having air. It was having air, so it was black. So this is completely devoid of air, absent air. So what must have happened? The foreign body must have occluded the bronchus completely, not allowing any air into the area. So that results in collapse. So whenever you find such history in the question, history of aspiration and chest x-ray is showing collapse. So what should be your suspicion? Your suspicion should be a foreign body in the lung. A foreign body in the lung. See why it is not effusion. Effusion generally will have a meniscoid fluid level. So effusion will have a meniscoid fluid level like this, and effusion will also push the mediastinum to opposite side. So I told you again we'll have discussion on collapse, consolidation, all those x-rays. You'll get a good idea there. So foreign body. So whenever there is foreign body, what is the best investigation? So when you are suspecting a foreign body, what will be the best investigation? So best investigation, scope is the only hope. So what is that scope that I do? Bronchoscopy. Bronchoscopy. So why bronchoscopy is considered as best? Why bronchoscopy is considered as best? So because it will not only visualize the foreign body, it will not only visualize the foreign body, it will also retrieve the foreign body. It will not only visualize the foreign body, it will retrieve the foreign body. See, in effusion, you will have a meniscoid fluid level high up in the axilla. Effusion will be like this. And moreover, effusion can cause push of mediastinum to opposite side. So here there is no meniscoid fluid level. And most importantly, history. History is important. Aspiration, you are having a whitish density, most probably it will be foreign body. So by bronchoscopy can visualize the foreign body and also retrieve the foreign body. In this patient also, immediately I have done a bronchoscopy. This is what I could notice. So you can see myself doing bronchoscopy. So within the bronchus, I could notice a fragment like this. So after some time, I could remove it by piecemeal. So can anybody tell what exactly this foreign body is? Yes, can anybody tell me what exactly is this foreign body? Yes. So this is an aspirated chicken liver piece. So this patient was so much drunk. Instead of putting it into his stomach, he has put it into his lungs. So what is the moral of this story? Drink responsibly. Don't aspirate and waste alcohol. Drink responsibly. Don't aspirate and waste alcohol. So this fellow didn't know how to drink properly. He has aspirated and created all of this mess. So, but this is not what you should remember for your exam. So what you should clearly know for your exam, when a clinical scenario is showing aspiration, collapse on chest x-ray, suspicion is foreign body, best investigation is bronchoscopy. So they can build up so many clinical scenarios on this. Now let me test your knowledge, whatever you have learnt up to now. So this is a third case. There was a bedridden patient. There was a bedridden patient on liquid diet. And she developed aspiration pneumonia resulting in lung abscess. Aspiration pneumonia resulting in lung abscess. Which of the following bronchopulmonary segment is most likely affected? So I have given you brief idea regarding bronchopulmonary segments, and also I have given you idea regarding what are the segments involved. By putting this together, you should tell me. Yes, now to tell even chicken dinner, it is very difficult because there is no PUBG. So why I have removed piecemeal? So it is a chicken liver piece. When I was taking it with a bronchoscopy forceps, it was used to come like parts. So that's why I have to take it in multiple entries. Yes. Winner chicken dinner, it is not possible now. So don't worry, we have Fauji now. Yes, what is the answer here? So bedridden patient on liquid diet. So it means there is aspiration pneumonia happening resulting in lung abscess. They are asking aspiration in supine position. In supine position. So if it is in supine position, I told you in supine it should be superior segment. So it should be superior segment. So it should be right lower lobe superior segment. So if it is not given in the option, next best answer is right upper lobe posterior segment. So out of this, it is not lower lobe, it is not lower lobe of left side. So left you can remove. Now we are left with posterior segment of right upper lobe, posterior segment of right lower lobe. So right lower lobe, it is usually in standing or sitting. So in supine, right lower lobe superior segment or right upper lobe posterior. So answer is option A. So posterior segment of right upper lobe. So simple concepts. Now what is this symptom? In respiratory medicine, blood in sputum. What is this called? Blood in sputum. So blood in sputum, what is this? This is hemoptysis. Now let us discuss regarding hemoptysis. So my lung has dual blood supply. So lung is having dual blood supply. So one is from high pressure circulation. High pressure systemic circulation. One source. From the systemic circulation, you have bronchial artery. So bronchial artery. Next is low pressure pulmonary circulation. That is pulmonary artery. So hemoptysis can happen from anywhere because lung has dual blood supply. Just I'll write it again so that you will understand better. So my lung has dual blood supply. High pressure systemic circulation, that is bronchial artery. Next is low pressure pulmonary circulation, that is pulmonary artery. Now let us see some important questions. So first question, what is most common source of hemoptysis? Now there is a high pressure circulation and low pressure circulation. Which has more tendency to rupture? Which has more tendency to rupture? Your answer should be high pressure circulation, that is nothing but bronchial artery. So there is a high pressure circulation and low pressure circulation. Which has more tendency to rupture? High pressure circulation, that is bronchial artery. So whenever it ruptures, see what is, somebody is telling that pulmonary vein. See what is the job of pulmonary vein? It will not carry the blood to the lung. See, whatever carries the blood to the lung are called arteries. Veins are what carries blood from the organ to the heart. So this is something basic. Okay. So blood supply, what supplies the blood to the lung? It is bronchial artery, pulmonary artery. Bronchial artery has a high pressure. So it is easy to rupture whenever there is a disease. So whenever it ruptures, which circulation is difficult to control? Those rupturing with high pressures or low pressures. Again, if it ruptures with high pressure, it will be difficult to control. So blood loss will be more, resulting in massive hemoptysis. So if they ask you the answer for most common source and most common source for massive hemoptysis, single best answer is bronchial artery. Single best answer is bronchial artery. Sony, you are asking a question that again you can solve with your common sense. So there is a bronchus and beneath it there is some air. So now you have completely cut off the air supply to the bronchus. After some time all that air will go into the blood. So where will the air stay there? All the air will be consumed by the blood circulation. Have you stopped the blood circulation to that part? You only stopped air going into that part. Okay. So these are some basic questions. Just before asking a question, think for 1 minute, you will get the answer, because I told you medicine is made up of common sense, not rocket science. Okay. So most common source of hemoptysis, most common source of massive hemoptysis is bronchial artery. Now the next question, most common cause of hemoptysis in India. So in India, what is the answer? Most common cause of hemoptysis in India. So everybody say it loud and type it proud. This is our national disease. What is that national disease of India? Just like national animal, national bird, we have a national disease for us. That is very good, very good. Type it, type it, type it. TB, 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 tuberculosis. So most common cause of hemoptysis in India, our national pride and national pride, that is tuberculosis. Then most common cause of hemoptysis worldwide. So previously they were thinking it as chronic bronchitis. Later they thought malignancy. But recent studies have revealed in worldwide also it is tuberculosis. The simplest reason is nowadays we Indians are worldwide. So it will be our national responsibility to share our national pride with everybody, and so we are spreading it with great love, the disease called as tuberculosis. So in India, tuberculosis, worldwide also tuberculosis. So most common cause of massive hemoptysis, recent studies have shown it was due to bronchiectasis. Bronchiectasis. Now, what is the new definition of massive hemoptysis? So, when do you call it as massive hemoptysis? So, whenever there is more than 100 to 150 ml of blood getting expectorated per episode, or more than 400 to 600 ml per day. So this is the recent definition. So different books have different values. I have selected the suitable range. So in one episode, if the patient is expectorating more than 100 to 150 ml per episode, or throughout the day more than 400 to 600 ml per day. So if this is the amount of blood getting expectorated from his lung, so this is considered as massive hemoptysis. Now, what is the most common cause of death in massive hemoptysis and most important in management of massive hemoptysis? Yes. Most common cause of death in massive hemoptysis. So, why will a patient die in massive hemoptysis? It is actually not due to blood loss, volume loss and shock. So, before that something can happen. So, whenever there is massive hemoptysis, there will be lot of blood accumulating in the lung. So that blood will reach into the trachea. So whenever blood is out of blood vessel, it has tendency to clot. It has tendency to clot. So for example, if at all somebody tightly holds your neck, for how much time you can survive? Not more than few minutes. Now a clot will tightly hold the trachea, not allowing any air. So patient will die of asphyxiation before dying of volume loss. See, for volume loss and shock to happen, it will take 5 to 10 minutes. But this asphyxiation can immediately kill the patient. So most common cause of death in massive hemoptysis is asphyxiation from blood clot. Asphyxiation due to blood clot. Asphyxiation due to blood clot. Asphyxiation due to blood clot. So most important in management of hemoptysis will be airway management, airway maintenance. So you should make sure his airway is free from blood clots. So most important in management of massive hemoptysis, if they ask you, is it airway or circulation? See, both are important, but most important out of these two is you should make sure his airway is free from blood clots, because if blood clots accumulate in the large central airway like trachea, patient will die immediately. Now coming to the algorithm. See, BXIS is short form of bronchiectasis. So algorithm, whenever a patient with hemoptysis reaches to my hospital, I first would like to know from my duty doctor whether it is a massive hemoptysis or non-massive hemoptysis. So if it is non-massive, I can relax for a while and see the patient. But if it is massive, I should immediately rush to the spot, because massive hemoptysis can immediately kill the patient. So after seeing the patient, now I am going to assess whether the patient is stable or unstable. Whether the patient is stable or unstable. I'll just show you the previous slide. So when do you call a patient unstable? So whenever his saturation is not good, his sensorium is not good, his blood pressure is not good. See, as a duty doctor, when you see vitals, so you'll see blood pressure, his sensorium, his saturation. So anything is not good, anything is not good. So that will indicate patient is unstable. See, most important in management of massive hemoptysis, it is airway maintenance. You should make sure his airway is free from blood clots. Okay. So if the patient is unstable, so immediately you should stabilize the patient and you should go for rigid bronchoscopy. So you must be knowing there are two types of bronchoscopies. One is rigid and other is flexible. Now what is the advantage of rigid, especially in massive hemoptysis unstable patients? So rigid bronchoscope has a big suction channel. Rigid bronchoscope has a big suction channel. Okay, rigid bronchoscope has a big suction channel. So what is the advantage of big suction channel? So you can put it into the throat and easily suck out all the blood clots very rapidly. If there is a big suction channel, you can rapidly suck out the clots and save the life of the patient. So stable, if the patient is stable, you can take a CT chest. See what exactly is happening in the patient's lung, and later you can go for a fiber optic bronchoscopy. So FOB is flexible bronchoscope, also called as fiber optic bronchoscopy. FOB means fiber optic bronchoscopy, another name for flexible bronchoscopy. Now if it is non-massive hemoptysis, so I can advise my duty doctor to take a chest x-ray meanwhile. So once the chest x-ray film has reached it, so I am going to see whether it is a normal chest x-ray or there is some abnormality in chest x-ray. So I will see whether the chest x-ray is normal or chest x-ray is abnormal. Chest x-ray is normal or chest x-ray abnormal. See how will a rigid thing go into your alveoli. So Urvik province, you are asking, will rigid bronchoscopy leads to alveolar damage? See, the diameter of your alveoli is 100 times less than the area that I am saying. Your rigid bronchoscope will be here. So I am just putting it into the up to the trachea or into the main bronchus and removing structure. How will it cause alveolar rupture then? Yes. So generally it will not cause alveolar rupture. It can cause tracheal tears. It can cause bronchial tears. So non-massive hemoptysis, chest x-ray normal, chest x-ray abnormal. So if the chest x-ray is normal, now I should see whether this patient belongs to a low risk group or high risk group. A low risk group or high risk group. So even though, see, any scopy can be done only on a stable patient. The point here is, if you don't do scopy, here also I told you na, unstable, stabilized patient, then do bronchoscopy. So it is not like you got the patient into the hospital, get scope, put it into his throat. Unstable, stabilized patient, rigid bronchoscopy. So it is in the algorithm. What is the doubt? Yes? See, again I told you rigid bronchoscope has a big suction channel. So what is the advantage of a big suction channel? It can easily suck out the clots faster. Flexible is smaller suction channel. It will take more time to suck out the clots. Meanwhile, patient may not survive. Okay. So chest x-rays, Low risk and high risk. So even though most common cause of hemoptysis tuberculosis, but if they ask you most dangerous cause, it should be malignancy. So why I am calling it as malignancy dangerous? If I miss tuberculosis today and identify after a few weeks, the treatment will be the same, ATT. But if I miss malignancy and identify after a few weeks, if it goes into metastasis, then it will be very difficult and high mortality. So who are the patients at high risk of developing malignancy? High risk patient or smokers. And age, elderly age, increased age. Previously, the risk factor for malignancy was more than 60 years. Now, because of environmental pollution, now it has come down to 40 years. So tomorrow what will happen, nobody knows. Then coming to low risk patients, non-smokers, young, young. So now how to proceed further? So high risk and low risk with chest X-ray normal. So if it is an young patient, I should find out whether it was a single episode or recurrent hemoptysis. So it is happening frequently. So if it is a single episode, I generally reassure. And I prescribe an antibiotic. If it is recurrent, I should go for a CT chest and followed by bronchoscopy. So if it is a high risk patient, even though it is a single episode, this patient is having high risk of developing lung cancer, I should immediately go for CT chest followed by fiber optic bronchoscopy. If chest X-ray is abnormal, go for CT chest followed by fiber optic bronchoscopy. Now if you see, in majority it is first CT chest bronchoscopy. Now what is the advantage of doing a CT chest prior bronchoscopy? See, CT chest will give you the precise anatomical location of the disease. So it will tell you whether right lung is involved, left lung is involved, upper portion, lower portion, the precise bronchopulmonary segment. Whereas fiber optic bronchoscopy, why it is done later? Now you know which part of the lung is involved. So when you are putting a bronchoscope, you know precisely where to target and where to take sample. So if at all there are some secretions, we take sample called as bronchoalveolar lavage. If at all there is some abnormal tissue, we take bronchoscopy biopsy. So by sending the bronchoalveolar lavage and bronchoscopic biopsy for the lab, you will get some diagnosis. So if you treat the disease properly, hemoptysis will also resolve. So stable patient, CT chest in massive hemoptysis, fiber optic bronchoscopy. CT chest will give you the precise location. Whereas fiber optic bronchoscopy will help you to collect the sample. So if it is secretions, it is called bronchoalveolar lavage. If it is a tissue, it is bronchoscopic biopsy. Send it to the lab, you will get the diagnosis, treat it adequately, so patient will improve. So in few conditions, even after doing all this algorithm, patient will be having persistent hemoptysis. So what to do next? So in persistent hemoptysis, in spite of thorough evaluation, what to do next? In persistent hemoptysis. So one thing is blocking the culprit artery. So what is the culprit artery responsible? Bronchial artery. So we can go for bronchial artery embolization. And next important thing is, if there is a localized disease, resection of affected lobe. Suppose there is left lower lobe bronchiectasis. uh, that is already destroyed lung, it is getting infected and resulting in hemoptysis, you can remove that part. But if they ask you which is the most preferred method, so non-surgical methods are generally preferred, because resection of affected lobe, in the sense it is generally an invasive method. You have to cut open the thorax, remove the lung, and after that also patient should be placed in the hospital for 10 to 15 days. So in persistent hemoptysis, most preferred is block the culprit artery. So what is the culprit artery causing hemoptysis in majority? Bronchial artery. Block the culprit artery. Bronchial artery embolization. So if at all that is not possible, or if there is an localized disease, for example left lower lobe bronchiectasis or some cavity in one lobe, so that is responsible for hemoptysis, you can remove that part. So the next question is, why I am going for bronchial artery embolization, not pulmonary artery? So why we routinely don't do pulmonary artery embolization? Yes. So somebody has already asked a question, why we routinely don't do pulmonary artery embolization? Yes. See, what is the function of pulmonary artery? So it is the artery from the lung. It takes part in gaseous exchange. Pulmonary artery is the one taking part in gaseous exchange. So if you block that pulmonary artery, will gaseous exchange happen in that patient? No, that can kill the patient. So generally we don't go for pulmonary artery embolization. So we prefer bronchial artery embolization, resection of affected lobe. In very rare instances where a branch of pulmonary artery is involved, there is pulmonary artery aneurysm, a small branch. So there you can try embolization. But routinely we don't go for pulmonary artery embolization. Now try to solve this case. Another important case. Yes. A 54-year-old female, she is a known endobronchial carcinoma. So already you know that there is endobronchial carcinoma in the left mainstem bronchus. So you know the disease is on the left. So she develops massive hemoptysis. So 1 liter of frank hemoptysis of bright red blood while hospitalized. All of the following should be considered in the management except. Yes, all of the following should be considered in the management except. So in mitral stenosis, the source of hemoptysis can be the connections between bronchial and pulmonary veins. So Rahul, as you only tell me what is the function of pulmonary artery, gaseous exchange. So why do you want to block the pulmonary artery if it is taking part in gaseous exchange? Yes. Let us see the answer. See, all of the following are done except. So this is a massive hemoptysis. So you can go for bronchial artery embolization. You can go for early bronchoscopy. So these two are routinely done. Now placing the patient in lateral decubitus position with her left side down. So now you know in this patient, this is the right lung and this is the left lung. So left lung is affected. So there is bleed happening in the left lung. So if you place the patient on the left lateral position, so whatever bleed has accumulated will go and stay in the left lung only, because already left lung is damaged. So there is no problem for bleed going and staying in the left lung. So you have right lung which will be expanding. So here the thing is protect healthy lung. You protect the healthy lung by keeping bleeding lung down. So whenever you are managing massive hemoptysis, so these are all stabilizing. So whenever you are managing massive hemoptysis, if you know that patient is having left side disease, you should keep the patient on left lateral position. So I protect the healthy lung by keeping the bleeding lung down. Now the answer here is option B. So this is the answer. See, already there is hemoptysis. You should not encourage the patient to cough more. So whenever you ask the patient to cough more, the pressure within the lungs will increase and it will cause further rupture of the blood vessels. So pressure. See, why bronchoscopy? As we already know the diagnosis. So Rishabh Raj, bronchoscopy is not just diagnostic, it is also therapeutic. Now there is a big bleed there. Patient may go into, that bleed can reach the trachea. You put a bronchoscope and you clear the clots. You can clear the clots easily. And if there is a bleeder there, you can put some cold saline, you can put some adrenaline there, so that you can also decrease the tendency of the vessels to rupture. You can cause some vasoconstriction. Okay. So a 54-year-old female endobronchial carcinoma. So you can do here bronchial artery embolization. You can go for early bronchoscopy. You can place the patient on the diseased side down. So if you ask the patient to cough, what will happen? More bleed will happen. So better is you should give some cough suppressant. See, Raul, I don't know why you're asking this question very frequently. In high risk, why do you do chest X-ray when CT we are anyway doing? See, don't think CT as a routine investigation. See, patient is not having significant hemoptysis. If you just tell him that go and take a CT chest which costs 5,000, and if you are having a chest X-ray which costs only 200, patient will never come to your clinic. Okay, so that is all even economic issues. So you start from the basic investigation, go to the advanced investigation in relatively patients with less disease. See, if he is having massive hemoptysis, no issue in writing. Okay. And radiation risk. So I think Raul will always go to the most aggressive management for any case. If there is an infection in the finger, I think he'll plan cutting that finger instead of giving antibiotic. See, medicine is like you have to start according to the patient's condition. You have to start with the treatment with less risk and go accordingly. So you have to hike up the treatment according to the severity. Yes. So causes of hemoptysis, various respiratory diseases that we will discuss throughout our class. Now coming to some histological aspects in the lung. So type 1 pneumocytes and type 2 pneumocytes. So type 1 pneumocytes, yes. So these are pavement epithelium. And these cover majority of alveolar surface area. Majority of alveolar surface area. And these are easily damaged. Easily damaged. So the answer is option B. So you don't do vigorous coughing maneuvers here. You don't do vigorous coughing maneuvers here. So type 1 pneumocytes. So if you consider this is the lung, alveolus. So we have type 1 and type 2. So type 1 pneumocytes are generally pavement epithelium. So pavement epithelium. So it will be like this, flattened cells. And they cover majority of alveolar surface area and they are vulnerable to injury, easily damaged due to disease. Whereas type 2 pneumocytes. So type 2 pneumocytes. So what is the most important function of type 2 pneumocyte? They secrete surfactant. And they are majority in number. So type 2 pneumocytes. So if you see the alveolar surface, they are majority in number. So these have tendency to divide. So they can divide and give rise to type 1 cells. So that's why type 2 pneumocytes are also called as precursors of type 1. So very important points in this table are these type 1 pneumocytes, they cover majority of alveolar surface area. So alveolar surface area is covered majority by type 1 cells. If they ask you by number which are in majority, your answer should be type 2 pneumocytes. So can type 1 pneumocytes divide by themselves? No, they are easily damaged. They cannot regenerate by themselves. So what are dividing? Type 2 pneumocytes can divide and give rise to type 1 cells. So these are also called as precursors of type 1. So whenever there is an alveolar damage, type 1 cells easily get damaged. And type 1 cells have no capacity to regenerate or proliferate by themselves. So type 2 cells divide and later on give rise to type 1. So this is something generally happening. Very, very important line from Harrison. Usually during alveolar injury. So whenever there is an alveolar injury, type 1 cells easily damaged. Type 1 cells easily damaged. Type 2 proliferation is seen. Type 1 cells easily damaged. Type 2 proliferation seen. But in very severe diseases, so in severe diseases like ARDS, both type 1 and type 2 damaged. So because both type 1 and type 2 are damaged, so this is one of the reasons why patients with ARDS have poor prognosis. So why patients in hemoptysis have poor prognosis. So very important. Usually, routinely, whenever there is an alveolar injury, which cells are easily damaged? So this you should know. Type 1 cells easily damaged. And type 2 cells proliferate and replace them. But in severe diseases such as ARDS, so when we discuss ARDS, I'll tell you how there is alveolar epithelial damage. Both type 1 and type 2 are damaged. Because both type 1 and type 2 are damaged, there will be poor prognosis. So there will be poor prognosis. Now let us see some physiological concepts. Let us see some. See, initially there will be type 2 hyperplasia, Himanshu, but later when the patient complicates, there will also be destruction of type 2 cells. Okay, so type 1 is damaged, type 2 will undergo hyperplasia for some time. Later that inflammatory damage will also destroy type 2 cells. So that is the same thing happening in COVID related ARDS. This you must be knowing. COVID is everywhere. In COVID related ARDS, why patients are dying? Type 2 cells are getting affected, later on getting destroyed. Okay. So now let us see some physiological concepts in respiratory medicine. So I'll tell you what are all the physiological concepts that you should be learning to understand respiratory medicine better. Now first physiological concepts, the first break will be at 11:30. Okay. So around the lung, there is a covering called as pleura. See, Shubhan Sharma, what was the answer for case 3? So you should avoid vigorous coughing maneuvers. Option B, vigorous coughing maneuver should be avoided. Around the lung, there is a covering called as pleura. In that, always a pressure is being generated. Always a pressure is being generated. So this pressure is called as intrapleural pressure. Now let us see the physiological concepts regarding intrapleural pressure and how to understand this. So we know that your lungs can be taken just like equivalent to a spring. So whenever I stretch a spring like this and I leave it on surface, so ultimately what will happen? That spring will try to come back to its normal position. So any elastic structure will have a tendency to recoil. So just like your lung also, always its tendency is to recoil towards the center. So always the tendency of the lung is to recoil towards the center. So it feels like going towards the center. Whereas they have identified the tendency of the chest wall to go outward. So when they have done some autopsies, they have found out the tendency of the chest wall to move outward. So your lung will always be trying to come forward. Your chest wall will be trying to move outward. If this is continuously happening without a balancing pressure, your inspiration and expiration will not be comfortable. So in between these two opposing forces, there is a balancing pressure which brings lung to an equilibrium volume, chest wall to an equilibrium position, so that inspiration and expiration is comfortable. So this balancing pressure is called as negative intrapleural pressure. So why it is called as negative intrapleural pressure? So when they measured this intrapleural pressure, they have found out this intrapleural pressure was slightly less than atmospheric pressure. So in lung physiology, we take atmospheric reference pressure as 0. So anything less than 0 is negative. Anything more than 0 is taken as positive. Actually, this is not a negative pressure. But when they measured with atmospheric pressure, because we are taking atmospheric pressure reference value as 0, it was less than atmospheric pressure. So they termed it as negative intrapleural pressure. So between these two opposite forces, there is a balancing pressure. There is a balancing pressure. So this balancing pressure is called as negative intrapleural pressure. This is called as negative intrapleural pressure. Now let us see the important functions. So this intrapleural pressure always tries to maintain equilibrium lung volume. It always tries to maintain equilibrium lung volume. So what is that equilibrium lung volume called as? It is called as relaxing volume. Also called as. Is physiology done for you? Yes. Is respiratory physiology done for you? Yes or no? So then you should be answering. Is respiratory physiology done? Yes or no? Also called as functional residual capacity. So very simple logic. Lungs always try to recoil towards center. Okay. So chest wall tries to move outward. So in between these two there is a balancing pressure which will bring lung to an equilibrium volume, chest wall to an equilibrium position, so that the inspiration and expiration is comfortable. If physiology is done for you, I think we'll discuss more on clinical concepts. Yes. So intrapleural pressure, I'll just tell you what is relevant to understand clinical medicine. Okay, because this is not a physiology class, I'll tell you what physiology you should know to understand clinical medicine. So intrapleural pressure always tries to maintain equilibrium lung volume. So this equilibrium lung volume, the name is relaxing volume, also called as functional residual capacity. So don't worry foundation, I think you are also fresh from physiology. I'll give you the basic concepts. Now. So what is needed for understanding the disease? When you get physiology class done, you will understand it more better. So relaxing volume or functional residual capacity. Now if you see in a normal individual at the apex and at the base, so they found out that the intrapleural pressure was slightly different. So in the apex they found it was more negative. In the base they found it was less negative. So this regional variation, they thought it was due to gravitational influence on the lung. So if you take a normal lung, in the apex around the lung, the intrapleural pressure was more negative. There is intrapleural pressure for more negative. In the base, it was less negative. They thought this regional differences in the pressure was due to gravity. Exact reason is not known. This is a theory. The regional differences, they thought it was due to gravity. So what you need to understand here finally is, so I am telling even for foundation students, now just you know that around the lung, there is a pressure called as intrapleural pressure. I don't think it is difficult to know that. And the function of intrapleural pressure is to maintain equilibrium lung volume. So to make sure the lung volume is maintained at functional residual capacity. So you kindly know these 2 points. Okay. So there is a pressure around the lung called as intrapleural pressure. and its function is to maintain functional residual capacity, and it is a negative intrapleural pressure. See, if I start telling physiology, I think then you will not learn medicine now. So only basic physiological concept, it should refresh your mind. So when I say negative intrapleural pressure, positive intrapleural pressure, you should not be confused. I'll introduce you to the concepts. So the concepts necessary for understanding medicine. Now let us see what are the conditions responsible for more negative intrapleural pressure. See, IPP means intrapleural pressure. And what are the conditions responsible for less negative or positive intrapleural pressure? Now first we will see some physiological conditions. So more negative intrapleural pressure, generally deep inspiration. Less negative or positive intrapleural pressure, generally forced expiration, cough, and also Valsalva maneuver, Now let us see why there is more negative intrapleural pressure during deep inspiration. So whenever I want to take deep inspiration and I want to fill my lungs with excess air, so by simple laws of physics, generally gases travel from high pressure to low pressure. Now if my lung has to accommodate more air, what should be the pressure generated around my lung? It should be more negative. Only around the lung, if the pressure is more negative, the air from the atmosphere will come and accumulate into your lung in excess. So this is some basic physiology so that your lung is functioning well. See, anywhere in physics it will not change. So generally gases flow from high pressure to low pressure. Now if I want to accommodate more gas into my lungs, so around my lung the pressure will be converted into more negative. Okay. Now in the same way, now my lung is filled with excess air. So now a balloon is filled with excess air. Now I want to rapidly empty out that balloon without breaking that balloon. So what is the thing that you can do? You can just press the balloon tightly. So once you press the balloon, what will happen? You are applying positive pressure around the balloon. So rapidly air can expel out. In the same way, now your lung is fully filled with air. Now I want to forcibly expel that air out. So what I should generate? What will my body generate? It will generate a positive pressure around the lungs. So during forced expiration, the intrapleural pressure will become more positive. Just think a balloon which is completely filled with air like this and it has a narrow opening. Now if that air has to expel, what you should do? You should press the balloon. The same way, you are generating a positive pressure around the balloon. In the same way, a positive pressure will be generated around the lung so that air will go out forcefully. Now, why in cough, why in Valsalva maneuver also there can be a positive intrapleural pressure? What is the reason? What is meant by cough? Cough is forced expiration against closed glottis. So it is forced expiration. So intrapleural pressure can be positive. Then Valsalva maneuver. Valsalva maneuver is forced expiration against closed mouth and closed nose. So any deep inspiratory maneuvers will generate more negative intrapleural pressure. Forced expiratory maneuvers will generate positive intrapleural pressure. So these are some physiological conditions. Now let us see in diseases. So first group of diseases, very important group of clinical diseases, we have pushing lesions. So just concentrate for 5 minutes here. In this you will learn so many concepts. So pushing lesions, we have pleural effusion and other is pneumothorax. Pleural effusion, pneumothorax. Now let us see why they are called as pushing lesions and what is pleural effusion and pneumothorax. See, pleural effusion means excess accumulation of fluid within the pleural space. Pneumothorax means accumulation of air in the pleural space. As simple as this. Normally in the pleural space, there will be about 3 to 5 ml of fluid. Now instead of that, if 1 liter of fluid accumulates, it is generally a clinically relevant pleural effusion. So whenever the fluid is increasing in the pleural cavity, this fluid can generate positive pressure. Now suppose if there is right pleural effusion, so there will be right positive intrapleural pressure. And what will this positive pressure do? It can push the adjacent structures to that side. So if there is an elevated right intrapleural pressure, it can push the mediastinum to opposite side. So how will you clinically detect mediastinal position? So one is trachea and other is apex beat. So because of buildup of pressure here, so that pressure can push the mediastinum to opposite side. Then pneumothorax. Pneumothorax is air in the pleural space. So air will generate still more positive pressure. And what will that positive pressure do? It will push the mediastinum to opposite side. So very simple logic. If consider this is the normal position of your trachea. If there is right-sided pleural effusion, what will happen? Trachea will be shifted towards the left. In the same way, if there is left-sided pneumothorax, so increased pressure in the left pleural cavity can push the trachea more towards the right side. So write down the mechanism. Due to excess accumulation of fluid or air can generate positive intrapleural pressure, that results in push of mediastinum to opposite side. Say very simple. Normally in the pleural cavity only 3 to 5 ml of fluid is present. Now excess fluid is getting accumulated. So whenever something excess is becoming here, what will this excess do? It will push the ordinary structures to opposite side. In the same way, in the left side, if there is excess air accumulating in the pleural space, so that excess air can generate a positive pressure which will push the mediastinum to opposite side. So because disease is responsible for pushing the mediastinum to opposite side, this is called as a pushing lesion. See, just like in raw language, see, initially on this side 2 people were sitting, so it was very comfortable. Now a third person has come here. What will that third person do? He will push these 2 to this side. As simple as that. So who is that third person here? It can be either fluid in the pleural cavity or air in the pleural cavity. So just imagine 2 persons are sitting here. So third person started growing in the pleural cavity, either fluid, pleural effusion or air, pneumothorax. So what will third person do? He will push these persons to opposite side. So because disease is causing push of mediastinum, this is called as pushing lesions. So 2 pushing lesions that you should know, pleural effusion and pneumothorax. Whenever there are pushing lesions, there will also be pulling lesions. So what are the pulling lesions that you have come across? So just name them. I'll tell you the reason behind this. Collapse and fibrosis. Now, what is meant by collapse? So what is common in both collapse and fibrosis? Collapse means airless lung field. A part of lung is not containing any air. That is called as collapse. Now, what is meant by fibrosis? What is meant by fibrosis? So, fibrosis is not complete absence of air. So, there is some lung damage. Because of that, that area is shrinking gradually. So, there will be presence of less air. There will be presence of less air. Collapse means in that area there will be complete absence of air. Fibrosis means when compared to normal lung, in that there will be less air. So ultimately what happens to the affected side here? There will be lung volume loss. So let it be collapse or fibrosis. They are also called as lung volume loss lesions. So collapse or fibrosis, lung volume loss lesions. See, fluid in the pleural cavity, let it be blood, hemothorax, let it be pus, empyema, will all cause pushing lesions eventually. Okay. So pulling lesions, collapse and fibrosis, volume loss. See, now why here pleural pressure becomes more negative? Now, the lung is not expanding. So let it be collapse or fibrosis. Now as a defense mechanism, so what is the function of intrapleural pressure? At any cost, it has to maintain equilibrium lung volume. So because now the lung is not expanding, so your body as a defense mechanism will generate more negative intrapleural pressure to expand this lung. So only if more negative intrapleural pressure is applied, it will try to expand the lung. So to expand or to maintain equilibrium volume, more and more negative intrapleural pressure is applied. So after few weeks, on the diseased side, there will be more negative intrapleural pressure. On the normal side, there will be normal intrapleural pressure. So what will this more negative intrapleural pressure do? It will pull the mediastinum to same side of the disease. So write down the mechanism to maintain. So there is lung volume loss. To maintain equilibrium lung volume. To maintain equilibrium lung volume. To maintain equilibrium lung volume. More negative intrapleural pressure generated. So this will result in pull of mediastinum to same side of disease. Pull of mediastinum to same side of disease. So if at all there is right-sided fibrosis, trachea will be pulled more towards the right. If there is left-sided collapse, trachea will be pulled towards the left side. So in pulling lesions, why they are called as pulling lesions? Because disease is responsible for pull of mediastinum. They are called as pulling lesions. So these are the important differences between pulling lesions and pushing lesions. Now my question is, by seeing the patient, how will you identify the diseased side? So now I have given a patient in front of you. By seeing the patient, how will you tell whether the right side is involved or left side is involved? So whether the right side is involved and left side is involved. Yes? Whether the right side is involved or left side is involved. So it is not by tracheal position. So why it is not by tracheal position? Because if at all trachea is shifted towards the left, for example, it can be either due to right pushing lesion or it can be due to left pulling lesion, either right pushing lesion or left pulling lesion. So you cannot identify the diseased side by tracheal examination. So what is the best method? You see the chest wall movements. See, for example, this hand is healthy, this hand is damaged. So which hand will move better? Healthy hand will move better, diseased hand cannot move better. In the same way, healthy lung will give good chest wall expansion. Diseased lung will not have proper chest wall expansion. So write down very, very important point. To localize disease side. To localize diseased side. Always identify side of decreased chest movements. Always identify side of decreased chest movements. So very important table that you should understand for clinical examination. Now I'll give you a clinical scenario. Tell me the answer. There was a patient with decreased movements on the right side and trachea was shifted towards the left. What might be the possible diagnosis? Yes, tell me. Decreased movements on the right and trachea was shifted towards the left. What might be the possible diagnosis? First tell me, what is the diseased side? Decreased movements on the right. So it is a right-sided disease. Now is it a pulling lesion or pushing lesion? So disease is on the right, trachea is on the left. So it is a right pushing lesion. So right pushing lesion in the sense the differential diagnosis can be pleural effusion or pneumothorax. Now how to differentiate whether it is a pleural effusion or pneumothorax? Just percuss. So if you are getting a very dull note, it is fluid. If you are getting a very resonant note, it can be pneumothorax. Again we will have a detailed discussion on percussion auscultation. So till that you should know what are pulling lesions, what are pushing lesions, what is the genesis of this physiology. See, why I have discussed about intrapleural pressure means if I just say pulling lesions are collapse and fibrosis, pushing lesions are pleural effusion and pneumothorax, you may not understand this properly. So I hope the concept is clear. So once again you read this, you will have better idea. So we'll take break for 15 minutes. So any doubts, I'll clarify now. See, ball we don't overdo it. We see the surfactant and we remove it by seeing the patient saturation. If the patient is comfortable, respiratory efforts are good. We don't overdo it generally. See, lung cancer, if it causes pleural effusion, it will be a pushing lesion. Intrabronchial lesion resulting in collapse, it will be a pulling lesion. So HPE examination can show areas of surfactant within the alveolar macrophages and past positive staining will be seen. See, why not silico? I told you an example. An obese patient presenting to the emergency department with chest pain, ECG is showing myocardial infarction. Now, will you write diagnosis as obesity or myocardial infarction? You should write it as myocardial infarction. Obesity is the risk factor causing the disease. Okay. In the same way, silicosis is the risk factor causing. Patient has not come for silicosis. He has come for pulmonary alveolar proteinosis. So rigid bronchoscopy, as the name indicates, it is rigid, made up of metal, flexible. It is made up of some plastic and a flexible material. So big suction channel in rigid. So in emergencies, to remove a foreign body or to remove secretions in the large airways, rigid is more helpful. So my A is good. Thank you. Thank you. So first slide of the class. So Dhruvijan, let it clot in the left lung. It will not go into the right and stop respiration. So only if more negative intrapleural pressure is generated, then only lung will expand. So most common segment in sitting and standing, it is right lower lobe posterior segment. No, bronchial artery embolization is done radiological procedure, not bronchoscopy. So consolidation, no push or no pull. So chronic silicosis, generally that amount of silica in low quantities generally will not cause pulmonary alveolar proteinosis. So how will we know massive or non-massive? Just ask the patient how much blood he is expectorating. So you can easily tell, you can ask him small questions. Is it equivalent to a teaspoon, tablespoon or teacup? If you say every time I expectorate I am getting blood equivalent to a teacup, it is generally massive hemoptysis. So they're asking regarding COVID. Actually, COVID we have made 2 modules, one in AIMS capsule and DVT also I have discussed extensively regarding COVID. So it will just be repetition for you. Okay, we'll just meet after 10 minutes, 11:45. So welcome back. So next important topic is compliance. So in general terminology, compliance means stretchability. So next important physiological concept is compliance. Compliance means stretchability. So it is unit change in volume. The technical definition: unit change in volume per unit change in pressure. So it is written as compliance is equal to compliance is equal to dV by dP. Compliance is equal to dV, change in volume per unit change in pressure. Now let us see this with a simple example. So consider you are having 2 balloons in both hands. So the first balloon is made up of thin material and the next balloon is made up of thick material. So the balloon made up of thin material, you have applied 1 centimeter H2 of pressure and it has expanded to 5 liters. So what is the compliance of this balloon? 5 liters per centimeter H2O. The second balloon, which is made up of thick and hard material, you have applied the same 1 centimeter H2 of pressure. It has only expanded to 2 liters. So what is the compliance of the second balloon? It is 2 liters per centimeter H2O. Out of these two, which has better compliance? The first balloon. Which has reduced compliance? Second balloon. So compliance means what is the pressure you are applying, for that how much lung volume a given substance is stretching, or how much volume a given substance is stretching. So this is the general concept of compliance. So for your exam, they will ask you, what are the lung diseases associated with reduced compliance? Lung diseases associated with reduced compliance. So first important lung disease is fibrosis, interstitial lung disease, occupational lung disease, surfactant deficiency, acute respiratory distress syndrome. So compliance in simple words means what is the amount of pressure you are applying to that how much a given substance is expanding. If it is expanding more, it has good compliance. If it is not properly expanding, it has less compliance. So compliance is reduced in fibrosis, ILD, occupational lung diseases. So what is happening? So for example, there is some injury to my skin here. After few days, there will be formation of scar tissue. So whenever there is formation of scar tissue, so will that scar tissue be expansile like the normal skin? No, its scar tissue will be very, very hard. So in the same way, when there is some lung injury and ultimately there is fibrosis occurrence, so your lung is filled with scar tissue. So scarring of lung is nothing but fibrosis. So now your lung becomes hard. It is very difficult to stretch a hard substance. It is very difficult to stretch a hard substance. So in fibrosis, because lung is becoming shrinking and becoming hard, so compliance will be reduced. So let it be interstitial lung disease, ILD. occupational lung disease. In all this, the end result is fibrosis. In interstitial lung disease and occupational lung disease, the end result will be fibrosis. Now, why in surfactant deficiency and something similar happening in the adults called as ARDS, there will be reduced compliance. So now we have understood that whenever there is less surfactant, your alveoli can close early. Now, to open this closed alveoli, will you apply more pressure or less pressure? So, to generate volume in this closed alveoli, you should be applying more pressure. So, when more pressure is applied to give the same amount of volume, denominator is increasing. Simple mathematics. What will happen to ratio? Ratio will decrease. Denominator is increasing, ratio will decrease. So in surfactant deficiency and in ARDS also, few alveoli can close. So to open the closed alveoli, you have to apply more pressure. So whenever denominator is increasing, what will happen to ratio? Ratio will decrease. So this is the important concept of compliance. Why I have discussed here is, so when I am discussing ILD, I will tell you the compliance of lungs have decreased. So you should correlate with this concept. When I say ARDS, compliance might be reduced. Occupational lung disease, compliance might be reduced. So in all this, you have to apply this concept. Next physiological concept is airway resistance. Airway resistance. So resistance of the respiratory tract to airflow during inspiration and expiration. So whenever there is air flowing, there will be some resistance. So this resistance, both during inspiration and expiration, it is called as airway resistance. Now, simple law of physics from your school days, resistance is generally proportional to 1 by radius to the power of 4. So resistance is proportional to 1 by radius to the power of 4. So it means whenever there is airway narrowing, there will be increase in airway resistance. Whenever there is airway narrowing, there will be increase in airway resistance. Whenever there is airway narrowing, there will be increase in airway resistance. So when the radius decreases, proportionally the resistance increases. Now let us see what are all the conditions responsible for airway narrowing. Two important diseases. So one is asthma. Second is COPD, chronic obstructive pulmonary disease, especially emphysema. So emphysema, subtype of COPD, so very frequently asked in your exam. Now why in asthma there is airway narrowing? So asthma is due to some allergen resulting in some inflammation. So whenever an allergen is causing some inflammatory response, there will be some substances called as histamine, serotonin, leukotrienes produced. So because of these inflammatory mediators, there will be bronchospasm. So whenever there is bronchospasm, the airway diameter decreases. That will result in increased airway resistance. So why it happens in COPD emphysema, I'll discuss in detail in the next slide. Before that, let us see some basic respiratory physiology. So respiration has two phases. One is inspiration, next is expiration. Everybody accept that two phases, inspiration and expiration. So out of inspiration and expiration, which phase is generally slightly prolonged? Is it inspiration or expiration? Respiration has two phases, inspiration and expiration. Which phase is slightly prolonged? Your answer should be expiration. So expiration is slightly prolonged generally. What is the reason behind that? Inspiration is an active process. body applies energy, so inspiration will be quicker. Whereas expiration is a passive process. It is only dependent on lung recoil. So it will be bit slower. So in a normal individual, if inspiration is 2 seconds, expiration can be 3 seconds. So total duration of respiration is 5 seconds. Like that, how many cycles can happen in 60 seconds? About 12. That's why my normal respiratory rate is taken as 12 to 15 per minute. So simple logic, inspiration active, bit quicker. Expiration passive, that's why slightly prolonged. Now if at all there is an obstruction in the airway, during which phase it will be more pronounced? During expanding inspiratory phase or closing passive expiratory phase. See, inspiration, it is an active process, so body will apply energy and it will overcome that obstruction. Whereas expiration is a passive process, it cannot overcome the obstruction and it will be more pronounced during expiration. So that is why whenever I give my stethoscope and ask you to examine for wheeze, which is a sign of airway obstruction, during which phase you will hear it clearly, inspiration or expiration? Expiration. So 3 important concepts that you should know here before going into emphysema pathophysiology. So first is generally expiration, passive. It is a passive phenomena and slightly prolonged. Okay, this is some basic concepts. And obstruction, whenever there is an obstruction in airway, more seen during expiration. So that's why, because there is obstruction more during expiration, you hear a clinical finding called as expiratory wheezing. So these 3 you should never forget in your clinical practice. So these are some basic rules to understand respiratory physiology. Expiration passive, so it is slightly prolonged. Obstruction in airway more during expiration. That's why whenever there is bronchospasm, when you put your stent, you should listen both inspiration and expiration. Expiration will give you lot of information on auscultation. Obstruction in airway more during expiration. That's why we call it as expiratory wheezing. Now with this background, let us see how COPD emphysema is responsible for airway narrowing. And let us also discuss the pathophysiology of emphysema. So write down pathophysiology of emphysema. So first I'll tell you what is normally happening. So normally in all of us at expiration, so consider this structure is alveoli and these are airways connecting into the alveoli. So at expiration, my alveoli are partially open. So what is the reason behind that? Because there is a substance called as surfactant. So surfactant will keep the alveoli open at expiration. In the same way, the airways getting connected to the alveoli are also kept open. The reason is, around the airways there will be some elastic fibers. So again, this is a basic physiology concept. Around the airways there will be elastic fibers. So elastic fibers, I am writing with the same color, elastic fibers around airway. We are discussing pathophysiology of emphysema. First we will see the normal phenomena happening in all of us. Elastic fibers around airway apply traction. So it will apply a pulling force, traction, to keep it open, Now, what will happen in emphysema? Now, if at all the patient develops disease, what is going to happen? Now, can you tell me what is the most common cause of emphysema? Most common risk factor, etiology. It is smoking. So, most commonly it is smoking. Apart from this, there is a genetic cause also causing emphysema. So, this you must be knowing from your pathology. Alpha-1 antitrypsin deficiency. So let it be smoking or alpha-1 antitrypsin deficiency. Ultimately, there will be increased elastasis in the lung. Smoking will cause increased elastasis in the lung. Alpha-1 antitrypsin deficiency, because antitrypsin is less, trypsin will increase. Trypsin is nothing but an elastase. Apart from increased elastasis, there will also be gradual accumulation of inflammatory cells. So whenever there is some pathology happening in my body, inflammatory cells can accumulate. So gradual accumulation of inflammatory cells into the lung. So first of all, let us see what will this elastase actually do. So these are elastases. Because of alpha-1 antitrypsin deficiency or due to smoking, there will be increased elastasis in the lung. So the property of elastase anywhere is to destroy the elastic fibers. So these elastic fibers which were keeping the airways open, will now be destroyed. So whenever these elastic fibers are destroyed, now what will happen at expiration? At expiration, because of damage to the elastic fibers, airways close early during expiration. So airways. So previously they were kept open even at end expiration. Now because the elastic fibers which were keeping the airways open have been destroyed, so airways close early. So airways close early during expiration. So whenever airways close early during expiration, from the alveoli generally air will go out during expiration. Now because they are closing early, air will not be expelled completely. There will be air trapping. In alveoli. There will be air trapping within the alveoli. See, try to understand this simple concept. Say normally during inspiration, if I take 100 units of air, so 100 is just an imaginary number for you to understand. During expiration also 100 should come out. So during expiration, for 100 units of air to come out, these airways should be completely open, or else at least open like this during expiration. Now what is happening in this emphysema? Because of damage to elastic fibers, these airways are getting closed early. So instead of 100 units going out, only 50 units of air will go out. So how much is getting trapped in the alveoli? 50 units. During next inspiration, because inspiration is an active process till maximum capacity of lung is attained. So again 100 units of air will come inside. So now how much is there in the alveoli? 100 units of new air plus 50 units of trapped air. So it will be 150 units. During expiration, again only 50 units will go out. So how much is remaining in the alveoli? 100 units. Now during next inspiration, another 100 units will come into the alveoli. Now how much is in the alveoli? 200 units. So during expiration, only 50 units will go out. Now how much has remained in the alveoli? 150 units. So previously, after each inspiration and expiration, not much air was remaining in the alveoli. Now with each expiration, 50 units of air is getting trapped in the alveoli. Now if it continues for years together, gradually all your alveoli will be hyperinflated. So these hyperinflated alveoli all put together, it is called as a bulla. So as time progresses, see this, the airways will be more and more closer like this, resulting in more and more air trapping. So why all this is happening? Because the elastic fibers have been destroyed. See, doesn't narrowing affect inspiration volume? See, till the patient can tolerate it, inspiration is an active process. It can overcome that narrowing. So till then, air will be coming inside. Okay. So what is going to happen here? There will be more narrowing of the airway. There will be increase in residual volume. So within the alveoli, more and more air is getting trapped. So if residual volume increases, there will be increase in functional residual capacity. So that will ultimately result in total lung capacity. All these over distended air spaces, they are termed as bulla. So keyword again, in emphysema, what do you observe? Bulla. So bulla is nothing but over distended air spaces due to trapping of air for years together. Now if you observe, initially this was the radius of the airway. Now what has happened to the radius of the airway? There is decrease in airway radius. So whenever there is decrease in airway radius, automatically what will increase? Airway resistance increases. So simple concept, gradually airways are narrowed. So airway radius decreases, airway resistance increases. So beneath that, the alveoli are getting over distended. So there will be increased residual volume, increased total lung capacity, increased functional residual capacity, and formation of bullas. Now, how will these findings happening in the lung be visible to me on the patient? So that is important for me. See, as a physician, whatever happened inside the patient's body, I am not worried. Whenever it manifests and he is coming to my clinic, here I am worried. So how it is manifesting on the patient? As time progresses, all your alveoli are filled with excess air. So when alveoli are filled with excess air, the lung volumes increases. So once the lung volume is increasing, it will not only expand sidewards, it will also expand antero-posteriorly. So what will happen due to expansion of the lung? There will be increased antero-posterior diameter. So lung volumes are increasing. They will not only increase sidewards, they'll also increase antero-posteriorly. So this phenomena of increased AP diameter, it is called as barrel-shaped chest. So barrel-shaped chest is due to excess air filling into the alveoli, not going out. Now if I take a chest X-ray, what I am going to notice? In a normal individual, this will be the lungs, normal lungs, comfortably sitting on the diaphragms, and you will have a globular heart occupying this space. So normal lungs, good curved diaphragms, nice curves on the diaphragm, and globular heart. This is in a normal individual. Now if the lung volume is increasing, now suppose this was the normal lung, so it was having less weight, so the curve was well maintained. Now the lung volume has increased like this. So what will happen? So the curved diaphragm will become flat and low-lying diaphragm. So curved diaphragm will become flat and low-lying diaphragm. So previously in this space there was a globular heart. Now once the lung area increases, this globe will be adjusted like a tube. So 3 important findings: hyperinflated lung fields, curved diaphragms becoming flat and low lying, globular heart becoming, what is that? Tubular heart. It looks like a tube. I'll show you on a chest x-ray. You will understand this better. Now, still the disease is progressing. What can you notice? So, in advanced disease, what else can happen? Now, previously, the inflammation was more around the airways. Now, once the disease progresses, now this inflammation will start involving the important areas, the alveolar and capillary areas. Alveolar and capillary membranes. So in advanced disease, there will be involvement of alveolar and capillary membrane. So that inflammation, previously it was only around the airways. Now it can involve the alveolar and capillary membrane. So because of that, there will be decreased diffusion of oxygen. So in emphysema, what you should understand is, so why there is air trapping, why there is increased airway resistance, why there is increase in residual volume, increase in FRC, increase in TLC. So why there will be decreased diffusion of oxygen? So when a patient with emphysema comes to me, so I will see him and know that, so this fellow has problem in expiration. He is unable to empty the air out. So he has big lungs. His diffusion capacity is also declined. So this is the pathological basis. Now let me show you some pictures so that you can understand this better. So what do you notice here? Yes, can anybody tell me? So there, this is the anterior portion, this is the posterior portion. You can see there is increased AP diameter. So there is increased AP diameter. So this increased AP diameter, clinically it is called as barrel-shaped chest. So clinically there is barrel-shaped chest. So Kalpana, you are asking how was the elastic fibers destroyed? It is like listening to complete Ramayanam and asking who is Sita and who is Rama. So the reason is, see, there were elastases. So because of smoking, that can increase elastases. Alpha-1 antitrypsin deficiency, that can also increase elastases. So elastase function is destroying elastic fibers. So increase AP diameter, it is barrel-shaped chest. Now if you see this patient in real time, he will be like this. Can you see the hyperinflated chest here? The increased AP diameter. This is the barrel-shaped chest. And this patient, because his gaseous exchange is not proper, he will be having tachypnea. Now let us see what are the gas exchange abnormalities. So gas exchange abnormalities, because diffusion is not happening properly, oxygen will not go into the blood. So once oxygen is not going into the blood, there will be hypoxemia. And second important thing is, there will also be hypercapnia. So what is the reason for hypercapnia? Normally during expiration, what should go out? Carbon dioxide should go out. But in this patient, what is happening? Expiration is not happening properly. Because of air trapping, CO2 is staying in the body, not going out. So this fellow will have increased CO2 in the body, that is called hypercapnia. And moreover, as the weight of the lungs increases on the diaphragm, your diaphragm cannot function properly. So what is the strongest muscle for respiration? Diaphragm. So once your diaphragm is not functioning properly, during inspiration, oxygen will not come inside properly. During expiration, carbon dioxide will not go outside. So if you see a patient with COPD emphysema, there will be two gas exchange abnormalities. in his body, oxygen will be less, carbon dioxide will be increased. So there is hypoxemia due to decreased diffusion of oxygen, decreased transfer of oxygen. Hypercapnia, CO2 is not going out, it is getting trapped, and also because lung size has increased, it applies weight on the diaphragm, not allowing your diaphragm to move properly. Usually your diaphragms will move very well if lung is having normal architecture. Now because of heavy lungs, it will not move properly. Now if you see such a patient in the emergency department, what will you do initially? You will connect him to an oxygen. You'll put a pulse oximeter, and by seeing in the pulse oximeter, you will notice saturation about 70 to 80%. See, diaphragm is strongest muscle for respiration. See, why diaphragmatic impairment? See, if you are putting more weight on a muscle, will it move properly or will it decrease? Yes, it will not move properly. Okay. See, when you find such patient in the emergency department, you connect him to a monitor. His monitor will show hypoxemia, so about 70 to 80% of saturation. So then immediately you start him on oxygen. So generally let it be any hypoxemic patient. So you increase the oxygen. So you increase the flow of oxygen to 10 liters, 15 liters to bring his saturation to near normal, 95 to 97. My question is, can you give such high oxygen in a patient with COPD? So the question is, what is role of oxygen therapy, excess oxygen therapy? See, in a routine patient with pneumonia or ILD, if his saturation is less, so we can increase the oxygen to 10 to 15 liters per minute on the flow meter, and we try to bring the saturation to 95 to 98%. So in a patient with COPD, emphysema, can you give excess oxygen therapy? Yes or no? Yes. Can you give excess oxygen therapy? The answer is no. Now why I should not give excess oxygen in this patient? What is happening? So what happens in this patient is, so before that, some basic respiratory physiology. So in my body, respiratory drive is controlled by two receptors. So one is central receptors and other is peripheral receptors. So central chemoreceptors usually are stimulated by CO2, whereas peripheral chemoreceptors are stimulated by hypoxemia. So if there is increased CO2, your central chemoreceptors will be stimulated. If there is less oxygen, your peripheral chemoreceptors will be stimulated. Now what happens in COPD is a different disease, because this patient takes about 10 to 15 years to develop this disease, and it is going to stay in his body for another 20 years. So this is such a chronic disease. So COPD will not happen like pneumonia in 1 or 2 weeks. It will take years to happen. And once it has occurred, it will stay there for years if you treat him properly. So in such long duration, there will be some permanent changes in the respiratory receptors. So you have central chemoreceptors and peripheral chemoreceptors. So this central chemoreceptors, because there is hypercapnia, continuous hypercapnia, always these are getting stimulated. After few days, these central chemoreceptors become tired and they announce their retirement. So they will stop functioning. Whereas your peripheral chemoreceptors are very, very loyal and durable. They will fight up to the last breath. So it is just like if you give a work to few persons, so few people will leave the work after few days and escape, whereas some will be fighting up to their last breath. So in your body, the durability of central and peripheral chemoreceptors is different. So central chemoreceptors will work for few years, and after few years, because of continuous hypercapnia, they stop working. So they give up. Now respiratory drive is only taken care by this peripheral chemoreceptors. Now only if there is slight hypoxemia, patient can breathe properly. Now if you give him high flow oxygen, 10 to 15 liters oxygen, and if you correct the hypoxemia, the stimulus for peripheral chemoreceptors will be lost. Already central not working. Now peripheral will not work. There is no stimulus to breathe. Patient will develop respiratory arrest. He will stop breathing. So that will result in death of the patient. So what you need to understand is, as years progress in COPD, chronic hypercapnia. So because of chronic hypercapnia, CO2 level may not stimulate respiration properly. So that's what I am telling. See, normally respiration is stimulated by CO2 central, by low oxygen peripheral. After few years, these central chemoreceptors are not that durable. So they do not function for long. So they give up, they announce their retirement. Now the respiratory drive is completely taken out by peripheral chemoreceptors. So these patients keep breathing only because of hypoxic drive. So already this is not functioning. Now patient is breathing only because of hypoxic drive. If you suddenly give him more oxygen, what will happen? His hypoxic drive will be withdrawn. By giving excess oxygen, breathing may stop. So if hypoxic drive is withdrawn by giving excess oxygen, breathing will be stopped. Breathing will be stopped. Now the question is, this fellow is in hypoxemia. If you don't give him oxygen, his organs will not function properly, because for any organ oxygen is required. Then what to do? So instead of giving high flow oxygen, so in this patient I prefer low flow oxygen. So instead of giving 5 to 15 liters per minute, I adjust to 2 to 3 liters per minute. And target saturation in these patients is not normal 95 to 97. So we only try to bring it to near normal 88 to 92%. So we always keep some amount of hypoxemia in his body so that he can breathe properly. So we give him low oxygen, we give him low flow oxygen. So we give him low flow. See, yes, Yashashwini, why oxygen? As already air is done. See, you should know that oxygen is not going. Trapped air is not good oxygen actually. Trapped air is carbon dioxide. Oxygen is not going into his body because of diffusion defect ultimately. So we give him low oxygen 2 to 3 liters per minute. So we do not overcorrect the oxygen. We do not make it to 95 to 96. So saturation is 88 to 92%. So keep this in mind. A patient with pneumonia, for example, his saturation is 70 to 80% on room air. So what should be target saturation in a patient with pneumonia? 95 to 98%. In a patient with COPD, what should be the target saturation? It is 88 to 92%. If you give excess oxygen and if you make his oxygen levels to 95, 98, what will happen? That patient will lose the hypoxic drive. Already this is not working. So you have removed hypoxic drive also. There is no stimulus to breathe. So patient will stop breathing and there will be respiratory arrest. So instead of doing good by giving excess oxygen, you will be doing bad. Why I am stressing on this is, so I am seeing so many foundation students. Tomorrow you will go into your clinical practice. So if you find it is COPD, don't give excess oxygen and bring his saturation to 95 and 98% and tell your PG that, sir, 98% saturation, but he is not breathing, what to do next? So maintain 88 to 92, he will be comfortable. Now this is a chest X-ray of a normal individual. So a normal individual, you can see the lungs, the curved diaphragms and globular heart. So first keep normal X-ray in your mind, then you will understand the X-ray of emphysema. Can you see the normal lung volumes, curved diaphragms, globular heart? Now what happens in emphysema? Yes, tell me, what is this finding? What is number 1? What is this finding? This is bilateral hyperinflated lungs. Bilateral hyperinflated lungs. Now, what is number 2 finding? So this, what is number 2 finding? Yes, what do you see here? Flat diaphragms. Flat diaphragms. Then what is number 3 finding? So what has happened to heart? Instead of globe, It is looking like a tube. This is tubular heart. Okay, so one is bilateral hyperinflated lung fields. Bilateral hyperinflated lung fields. 2 is flat diaphragms. 3 is tubular heart. See the classical difference. I'll zoom it so that you can understand better. Yes. Can you see the difference? The lung field size. So normal, this is COPD. The diaphragm curved, flat. The heart globular, tubular. So this you should not forget. So bilateral hyperinflated lung fields, flat diaphragms, tubular heart. So COPD consists of two aspects, emphysema and chronic bronchitis. That I'll discuss. What is the correct terminology in COPD? When we discuss, I'll tell you. Now case 5. Whatever I told you, if you apply this, it will be very easy. A 70-year-old male with non-COPD admitted with fever, purulent sputum, increased shortness of breath, fever, purulent sputum and increased shortness of breath. So whenever COPD patient develops excess symptoms than routine symptoms, see, routinely he'll be having some shortness of breath, but suddenly one day he comes, sir, today I'm feeling more shortness of breath, more fever, I'm getting purulent sputum. So increased symptoms in COPD, that worsening of COPD, it is called as COPD exacerbation. So a patient with COPD, if you find fever, purulent sputum, increased shortness of breath, it means he is in acute exacerbation. So as usual, his SpO2 was 75%. True regarding the case. I want you to answer this. So there is a patient with COPD in exacerbation. He has come to the emergency department. See, I wish to solve every MCQ as a case. So this is not just an MCQ. This is a case that you will face in your clinical practice. What is the best answer? True regarding the case. So chest X-ray shows shrunken lung fields. No, this is COPD. You will have hyperinflated lung fields. Then oxygen should be prescribed to hypoxemic patients with target SpO2 94 to 98%. No, target should be 88 to 92%. Supplemental oxygen did not demonstrate decrease in mortality in patients with COPD. False. See, why you are giving oxygen to him? To save his life. So if you give oxygen, definitely his life will be saved and actually mortality will be decreased. So we are left out with option B. So whether option B is true, higher concentrations of oxygen blunt the hypoxic ventilatory drive causing CO2 retention. It is true statement. So why will it cause CO2 retention? Because if the ventilatory response is lost, patient will not breathe. So once he is not breathing, whatever CO2 is there in his body, it will never come out. So gradually CO2 will increase in the body. So the best answer is don't give high oxygen to this patient. It will stop the respiration that can further cause CO2 retention. So that's why in Western countries you have something called as oxygen alert card. So oxygen, excess oxygen is actually toxic to COPD patients. So they will be carrying the card. There will be patient's name and it will be written, I am having risk of respiratory failure with high CO2. So whenever I am ill, maintain my SpO2 only between 89 to 92%. And if I need a nebulizer, give low flow oxygen 2 liters per minute. So this is the concept. So very frequently seen case, especially in these winter seasons, in your casualty, make sure you are treating it adequately. So answer for case number 5 is B. So answer is option B. So next is mechanisms of hypoxemia. So mechanisms of hypoxemia. So we have important mechanisms. So first is ventilation perfusion mismatch, VP mismatch. We call it as VP mismatch. Second is a shunt mechanism. Third is diffusion defect. Fourth is hypoventilation. So mechanisms of hypoxemia. So disease related, we have 4 important mechanisms. VP mismatch, ventilation perfusion mismatch, shunt mechanism, hypoventilation. So out of this, VP mismatch is considered as most common mechanism. Most common mechanism is VP mismatch. So we will now discuss regarding VP mismatch and shunt in detail. So this diffusion defect and hypoventilation when I discuss respiratory failure. So afternoon we will discuss an important topic called respiratory failure. There I will tell you in detail. VP mismatch, ventilation perfusion mismatch. So first let us see what is normally happening. Normally consider this is the alveolus and this is the blood vessel. So consider your alveolus is containing 2 ventilations like this. So it is having ventilation of 2 V's. And generally in the blood vessel also there will be similar perfusion. So in a normal individual, ventilation and perfusion will be matching. So if there are 2 V's, there will be 2 P's. So whenever ventilation and perfusion is matching at least nearly, there will be good gaseous exchange. Now let us see what are the conditions where there will be ventilation perfusion mismatch. So clinically important condition is pulmonary embolism. So what is happening in pulmonary embolism? So this is an alveolus and let this be the blood vessel. So generally pulmonary circulation is the one taking part in gaseous exchange. So here the ventilation might be the same. But what happens to perfusion? There will be a P here, whereas in the other part there is an embolus or thrombus. So because of thrombus, the perfusion will be blocked here. Now if you see here, so this ventilation and perfusion will be matched. But what is happening to this ventilation? It is getting wasted. So it is also called as wasted ventilation. In alveoli, it is called as alveolar dead space. Because there is no good perfusion, there will be no proper gas exchange. So previously there were 2 ventilations, 2 perfusions, good gaseous exchange. Now one perfusion is lost. So when there is no proper perfusion, this ventilation will be wasted and there will be defective gaseous exchange. So this again accounts for ventilation perfusion mismatch. So if they ask you in pulmonary embolism, where is the defect? Is it in ventilation or perfusion? Tell me, in pulmonary embolism, where is the defect? Is it in ventilation or perfusion? Your answer is no problem in ventilation actually, defect is in perfusion. Next important clinical disease is emphysema. So as emphysema, in emphysema we know that there is overinflated alveoli like this. So because of that, what is going to happen? The blood vessel beneath that will be compressed. So here also instead of 2P, only 1P will be flowing. See normally your normal size alveoli will not compress the blood vessel. Now this emphysematous alveoli, it is huge. It will compress the blood vessel. Again here there will be no sufficient ventilation, there will be no sufficient perfusion. So there will again be ventilation perfusion mismatch. So if they ask you important diseases responsible for ventilation perfusion mismatch, pulmonary embolism and other is emphysema. So in emphysema there will be problem both in ventilation and perfusion. Okay, in emphysema there will be problem. See ventilation, air may not come properly into the alveoli. Perfusion, the huge alveoli may compress the blood vessel. So there is a complex relation in emphysema that will eventually cause ventilation perfusion mismatch. So let it be any of this, pulmonary embolism or emphysema. Ultimately, it can cause ventilation perfusion mismatch, hypoxemia. And what you need to know is ventilation perfusion mismatch is the most common cause of hypoxemia. So next important thing is shunt. So what do you mean by the word shunt? So what is the meaning of shunt? What is the meaning of shunt? Yes. What is meant by shunting? Shunting means diversion. So shunting means diversion. So this shunt with respect to hypoxemia has a similar definition. Shunt means diversion of blood flow. So the definition of shunt is diversion of blood flow without oxygenation. Diversion of blood flow without oxygenation. So shunt means some bypass or diversion. So very good. So same thing. Whenever the pressure in the ventricles increases, so we do a surgery called as ventriculoperitoneal shunt. So what we are doing, we are diverting the pressure into peritoneal cavity. In the same way, a patient with portal hypertension, what we do a surgery called as portosystemic shunt. We are diverting the pressure into some systemic circulation. So shunt anywhere means diversion. Shunt with respect to hypoxemia is diversion of blood flow without oxygen or without oxygenation. So it can happen at two areas. If it happens in the heart, it is called as intracardiac shunt. Intracardiac shunt. If it happens in the lungs, it is called as intrapulmonary shunt. So shunt can happen either in the lungs, either in the heart. Now intracardiac shunt, the best example is a right to left shunt. A right to left shunt. So already we have discussed. So let us have a brief review. So in my body, any deoxygenated blood ultimately reaches the right heart. So from the right heart, it goes into the pulmonary artery. So pulmonary artery takes the blood into the lungs. It gives rise to pulmonary capillaries. So there will be gaseous exchange, and these pulmonary capillaries will merge into a pulmonary vein. So this pulmonary vein will drain into left atrium, left ventricle, and blood goes into the systemic aorta. So this is the routine circulation. Now what happens in right to left shunt? So in right to left shunt, because of an abnormal opening, deoxygenated blood from the right heart directly goes into the left heart. So generally any blood reaching the right heart should go into the lung, get oxygenated, then only come into the left heart. But here what is happening? Directly from the right heart, blood is going into the left heart because there is diversion of blood. And is this blood going into the lung for oxygenation? No. There is diversion of blood into the circulation without oxygenation, and it is happening in the heart. So that's why it is called as intracardiac shunt. So whenever there is mixture of bad blood and good blood, there will be mixed blood. And mixed blood, is it good blood or bad blood? It is bad blood. So this patient will ultimately develop hypoxemia. So this patient will ultimately develop hypoxemia. So this patient will also reach to the emergency department. If you see his pulse oximeter reading, it will be about 70 to 75%. Now you start connecting oxygen to this patient. Now my question is, will this patient be more responsive to supplemental oxygen or less responsive to supplemental oxygen? So there is mixture of good blood and bad blood. He has developed hypoxemia. You have started on oxygen. Will he be more responsive or less responsive to supplemental oxygen? So your answer should be, this patient will be less responsive to supplemental oxygen. Less responsive to supplemental oxygen. So what is the reason behind this? See, whatever oxygen you give through a mask, it will ultimately reach the lung. But whatever blood is getting mixed with left heart is never going into the lung. So whatever oxygen you give, it will go into the lung. So but the blood which is responsible for causing hypoxemia is never going into the lung. So even if you give oxygen to the patient, always deoxygenated blood from the right heart goes into left heart, mixes. That will result in mixed blood. Mixed blood is bad blood, so there will be persistence of hypoxemia. So then what will be the most effective treatment in this patient? Most effective treatment is correction of the shunt. So by doing some surgery or putting a device, you should close that shunt, so then only this patient will improve. So even if you give oxygen, there will not be significant improvement in this patient, because whatever oxygen you give, it will go into the lung. But the blood always is moving from right to left, resulting in persistence of hypoxemia. Now coming to intrapulmonary shunt. So what are the diseases responsible for intrapulmonary shunt? So we have severe pneumonia. We have severe pneumonia, ARDS, atelectasis. So atelectasis is nothing but alveolar collapse. So alveolar collapse is also called as atelectasis. See, generally localized areas of collapse is called as atelectasis. More generalized, we call it as collapse. So collapse and atelectasis are nearly the same. If small airways are getting collapsed, we generally call it as atelectasis. If large areas are getting closed, we just call it as collapse. So intrapulmonary shunt is seen in severe pneumonia, ARDS and atelectasis. Before going into the details of intrapulmonary shunt, first let us see what is normally happening. So whatever I draw with this color, it is normal phenomena. Normally oxygen during respiration reaches the lung, so it will go into the majority of alveolus, and usually deoxygenated blood will be coming like this. It will also come like this to the alveoli. So once oxygen is going into this blood, oxygen is going into this blood, so this blood will now become oxygenated blood. So this blood will now become oxygenated blood. So this is becoming oxygenated blood. So this will also become oxygenated blood. This will also become oxygen. See, example of right to left shunt. So there are many congenital heart diseases. We also have discussed in surfactant deficiency. Okay. So oxygenated blood, and it goes into circulation. And in circulation, mixture of oxygen rich blood. So ultimate result is oxygenated blood, good oxygen status. So this is normal phenomena happening in all of us. Oxygen reaches the lungs, goes into the blood, into the pulmonary circulation, from there into the left heart, into the systemic circulation. Now patients with intrapulmonary shunt. So in severe pneumonia and ARDS, what happens is alveoli are filled with secretions. In ARDS also, inflammatory damage that will result in inflammatory exudate. In severe pneumonia, infection, proliferation of bacteria can result in secretions. Atelectasis, the alveoli are not at all opening. So let us take prototype as severe pneumonia. So for intrapulmonary shunt, let us take prototype as severe pneumonia. In severe pneumonia, what happens is alveoli will be closed like this. Alveoli will be filled with secretions like this. So in this patient also, whenever he takes oxygen, so he is breathing in oxygen. So whatever I write in black, it is regarding the disease intrapulmonary shunt. So this oxygen definitely will go into the healthy alveoli and it will go into the blood vessel here. So here this blood will be oxygenated blood. So this blood will become oxygenated. Now the problem here is on the other side. On the other side, this oxygen cannot penetrate this alveoli because all these alveoli are filled with secretions. So oxygen cannot penetrate these secretions and cannot reach to this side of the blood. So here oxygen cannot reach because oxygen is not reaching. So this blood coming this side will remain deoxygenated. So whatever blood was flowing here, it remains deoxygenated because it is not getting oxygen. Now into the circulation, this oxygenated blood and this deoxygenated blood will both come. See, on that side it is healthy, so blood is getting oxygenated. So here blood is getting oxygenated. This side the alveoli are filled with secretions. Oxygen is not reaching. So deoxygenated blood will flow into circulation without getting oxygen. So because of mixture of oxygenated and deoxygenated blood, the end result is mixed blood. Now mixed blood, is it good blood or bad blood? It is bad blood. So because of that, patient will develop hypoxemia. Now try to understand this simple concept. See here, on the healthy side, this is the healthy side. Oxygen reaching the blood, blood is getting oxygenated and going into circulation. Whereas on the diseased side, oxygen is not going into the blood, deoxygenated blood flowing into the circulation. Mixture of good blood, bad blood, resulting in mixed blood that will be resulting in hypoxemia. Now why this phenomena is called as a shunt? So why it is called as a shunt? So what was the definition of shunt? Diversion of blood flow without oxygenation. Now if you observe here, on the healthy side, blood is getting oxygenated and going into circulation. Whereas on the diseased side, blood is not getting oxygenated, but still blood is going into circulation. So this area, this is called as shunting. You can see here, the blood is not getting oxygenated, but still flowing into circulation. And this area is called as shunt. So this blood, this fraction is called as shunt. So this is happening in the lung, so it is called as intrapulmonary shunt because it has happened in the lung, intrapulmonary shunt. So you can see on this side blood is getting oxygenated and going into circulation, whereas on this side blood is not getting oxygenated but still going into circulation. So this phenomena is happening in the lung, so it is called as intrapulmonary shunt. So ultimate result is hypoxemia. Now my question is, when this patient reaches to the emergency department, he will also be having low oxygen when you see saturation. Now you will also start connecting him with some supplemental oxygen through a face mask. Now the question is, will this fellow be more responsive to supplemental oxygen or less responsive to supplemental oxygen? Yes. Will it be more responsive to supplemental oxygen or less responsive to supplemental oxygen? Say yes, it is same as wasted perfusion. So wasted perfusion, the name is shunt. Wasted perfusion, the name is shunt. So will it be more responsive to supplemental oxygen or less responsive? Good, you are answering well. This will also be less responsive to supplemental oxygen. This will also be less responsive to supplemental oxygen. So this is a lung disease, but why is it less responsive to supplemental oxygen? Same logic. Now, whatever oxygen you give, it can only pass through a face mask. It can only pass to the healthy lung. It cannot cross these secretions. So you know a property of hemoglobin called as saturation. beyond a point it cannot bind excess oxygen. So how much ever oxygen you give, here saturation cannot cross beyond 100. So it will be well oxygenated blood. So even if you give oxygen on this side, it can only bind up to a point. On this side, oxygen is never reaching at all. So this oxygenated blood will always be mixing with deoxygenated blood. So whenever oxygenated and deoxygenated mix, again the end result will be mixed blood, hypoxemia. So even if you give oxygen, there will be less response to supplemental oxygen. The reason is, whatever oxygen you give through a face mask, it will only penetrate into the healthy side. And you know a property of hemoglobin called as saturation. Beyond a point, it cannot accommodate excess oxygen. Even if you push oxygen, hemoglobin cannot accommodate beyond a point because there is a property called as saturation. Whereas on the diseased side, always there is deoxygenated blood. So oxygenated blood and deoxygenated blood always mix, resulting in hypoxemia. So then, see, this is a shunt. It is happening in the lungs. Akshara Yadav, very simple words. So this is a shunt mechanism because it has happened in the lungs. It is called as intrapulmonary. Pulmonary means lung. Intra means within the lung. That's why it was called intrapulmonary shunt. So this will be less responsive to supplemental oxygen. Then this is a lung disease. Even if you are giving oxygen through a face mask, there is no response. So what will be the effective treatment? So effective treatment in this patient, apart from treating the underlying disease, we should go for invasive mechanical ventilation. So we can go for invasive mechanical ventilation. See, it will undergo vasoconstriction, but it will not be completely closed. Still some amount of blood will be flowing. There will be a mixture of good blood and bad blood. So complete circulation stoppage will not be there. So invasive mechanical ventilation. So what is the benefit of invasive mechanical ventilation? So you give this ventilation with a positive pressure. You put a tube and give positive pressure. So that positive pressure can push the secretions aside and can facilitate oxygen entry. Now suppose there is a door in your home and you want to pass through that door. Now 10 people are standing. How will you still manage to go out through that door? You will push them aside by applying some positive pressure and you will go out. So invasive mechanical ventilation is also the same thing. You give oxygen with pressure. You can see there were initially so many secretions. Once you give with pressure, the secretions will be cleared and oxygen will go into the blood. So for treatment, see, breathlessness, anywhere give oxygen. Okay, if it is COPD, maintain saturation 88 to 92%. If it is any other defect, you give oxygen. See, I said less responsive means it is not a contraindication. You give oxygen till you do the next treatment. You give oxygen till you do the next treatment. So what is the point of invasive mechanical ventilation? Now there are secretions. If you put an endotracheal tube and give positive pressure, those secretions can be pushed aside and oxygen can penetrate into the blood. So there will be better transfer of gases. So better transfer of gases. Better transfer of gases. So invasive mechanical ventilation is not CPAP. So it is putting a endotracheal tube into the lung and giving ventilation. Yes. So why I should not do bronchoalveolar lavage? Because you don't know where the secretions are present, and this is definitely due to pneumonia and ARDS. So you have to treat that pneumonia. Putting a scope and removing secretions may not be feasible because in surfactant deficiency, top to bottom, all the alveoli were involved with a surfactant. Here exactly you cannot tell where it is involved, and removing it will be difficult. It will accumulate immediately. So there is also reduced ventilation. Why not considered as VP mismatch? See, shunt is a type of VP mismatch which is discussed separately. So shunt is a type of VP mismatch which is discussed separately here. They did not include it into VP mismatch because it was not improving with oxygen. Okay. Yes. Now what is this investigation? So before going into next stuff, let it be an intracardiac shunt. or intrapulmonary shunt, both will be less responsive to supplemental oxygen. So this is the bottom line that you should know. So both will be less responsive to supplemental oxygen. Both will be less responsive to supplemental oxygen. See, Himanshu, what you need to understand is, if at all there is cure for every disease, if everything is successful, doctors will be called as gods. Why it is not successful in COVID? Because the disease is so much. You do mechanical ventilation, patient will survive at least 10%. If you don't do, it is 0%. So 10% is better than 0%. Okay, that is the reason. See, success means you think it has 90%. For me, even 10%, if I am able to save a patient, for me it is success. So how will secretions be removed? What is the cause of secretion? Infection. Once you give good antibiotics, the secretions will decrease. Okay. Next, coming to, this is an investigation in respiratory medicine which uses a gas called as carbon monoxide. What is this investigation? Investigation in respiratory medicine. Yes. Which uses a gas called as carbon monoxide. It is called as DLCO. Diffusion capacity, not spirometry. Diffusion capacity of lung with carbon monoxide. We are using a gas called as carbon monoxide. Diffusion capacity of lung with a gas called as carbon monoxide. So why we preferably use carbon monoxide? Because carbon monoxide has 200 to 250 times or 240 times more affinity with hemoglobin. And what is the principle here? DLCO is calculated as difference between inhaled carbon monoxide minus exhaled carbon monoxide. So Kira, just wait, we'll discuss about invasive mechanical ventilation in respiratory failure. Just understand it is ventilation given through an endotracheal tube by positive pressure. So DLCO is diffusion capacity of lung with carbon monoxide. So here we use a specialized device. So we send some carbon monoxide into patient's lung and we are measuring the diffusion capacity. So we will discuss the mechanism in the next slide detail. So what is done in diffusion capacity? There is a specialized apparatus. So whenever patient takes a breath, some carbon monoxide goes into the lung. So then I'll ask him to breath hold for a while and then I'll ask him to expire. So then I'm going to measure the difference between inhaled carbon monoxide and exhaled carbon monoxide. So the percentage of carbon monoxide here is only 0.3%, very less amount, not toxic dose. So don't think it is toxic, very less amount. It is equivalent to you traveling in traffic for 5 minutes. Okay, very less dose, toxic dose. So it's not a toxic dose, very less, 0.3%, nothing will happen. It is equivalent to you traveling in traffic for 5 minutes. So are you dead by inhaling the smoke from your vehicles? No. So it can be given. So very less amount, 0.3%. Now let us see what is happening in DLCO. So during inspiration, so I keep that mission in the patient's mouth. So during inspiration, suppose we have sent 100 units of carbon monoxide. So 100 units of carbon monoxide into the lung. 100 units of carbon monoxide into the lung. Now after inspiration, we ask the patient to breath hold for 10 seconds. We ask the patient to breath hold for 10 seconds. So generally in the blood vessel, what is present? Hemoglobin. So whenever he breath holds, because carbon monoxide has 200 to 240 times more affinity with hemoglobin, So all the carbon monoxide will try to enter and bind with hemoglobin. So here 90% of carbon monoxide will reach the blood. Only 10 carbon monoxide will stay. See, across any membrane 10% is wastage. So what I am saying is what happens in a normal individual. So in a normal individual, if I do DLCO, during inspiration 100 carbon monoxide will come into the lung. He takes inspiration, so 100 carbon monoxide is coming. Now I'll ask him to breath hold for 10 seconds. So during that breath holding maneuver, what is going to happen? So consider this is your blood and this is your alveolus. So this carbon monoxide has very strong affinity with hemoglobin. Wherever there is hemoglobin, it will go and bind. So across any membrane, 10% is wasted. So 90% of carbon monoxide will go and bind with hemoglobin. Now I'll ask the patient to exhale. So forcefully exhale. So during expiration, now which carbon monoxide will come out? So the one remaining in the alveoli or one bound with hemoglobin. So this carbon monoxide will never come out. So the reason is carbon monoxide are having a very strong affinity like this. So just like these two people, they have a very strong affinity. Once they bind with each other, it is very difficult to separate. Once they bind, it is very difficult to separate. Don't think otherwise. This is just for explanation. So once they bind with each other, difficult to separate. So when I ask the patient to exhale, only this carbon monoxide will come out. Only 10 carbon monoxide will come out. So now if I calculate his DLCO. So DLCO is equal to how much did he inhale? 100. How much he is going to exhale? 10. So it means his DLCO is 90. It means 90% of carbon monoxide has crossed the membrane and went into the circulation. It is normal diffusion capacity. Now, if at all there is some disease. Now, how will DLCO change in disease? So what is happening in disease? Suppose there can be disease either in the pulmonary vasculature or in the alveoli. So let me discuss with respect to a disease in the alveolus. So there is a disease which results in lot of secretions in the alveoli. So a disease with lot of secretions. So disease with lot of secretions. So when this patient inspires also, so deep inspiration, I ask him, so if this disease is done with deep inspiration, so carbon monoxide will reach the alveoli. But because there is disease in the alveoli, all carbon monoxide will not go into blood. Instead of 90 going, only 50 carbon monoxide will go into blood. So because there is a disease, majority of carbon monoxide cannot cross this damaged membrane. You need a good membrane to cross and good blood supply to cross. So 50 carbon monoxide, only 50 will remain in the alveoli, 50 will reach the blood. Now if I ask the patient to expire, now how is DLCO different here? So 50 is staying in the alveoli, 50 is staying in the alveoli, 50 in the blood. So this will not come out. So this will come out. So here DLCO is equal to how much is inhaled? 100. How much is inhaled? 100. How much is exhaled? 50. So what is the diffusion capacity? 50%. So when compared to normal individual, only 50% has crossed the membrane. When compared to normal individual, only 50% will cross the membrane. So have you understood the concept? By measuring the exhaled carbon monoxide. See, if there is no disease in the lung, majority of carbon monoxide will go and bind with hemoglobin. So less will be sent out. So if at all there is a disease in the lung or the pulmonary vasculature, if at all there is a disease in the lung and pulmonary vasculature, what will happen? carbon monoxide cannot go into the blood. It remains in the alveoli. So that will be exhaled. If exhaled carbon monoxide is high, it means there is some problem in the body. There is some problem in the body not allowing carbon monoxide to bind with hemoglobin. Not allowing carbon monoxide to bind with hemoglobin. So generally 70 to 90% of DLCO is considered as normal. 70 to 90% of DLCO is considered as normal. Now with this background, let us see the conditions which are responsible for decreased DLCO and conditions which are responsible for increased DLCO. Now decreased DLCO, again you can understand easily with this simple diagram. So alveolus, let this be the blood vessel. So let this be the blood vessel. Now if at all your alveoli is filled with secretions like this, so lot of secretions. Now this carbon monoxide may not be able to penetrate into the blood vessel. So secretions are seen in severe pneumonia. So much of secretions affecting diffusion capacity, and also ARDS. So because of alveoli filled with secretions, severe pneumonia and ARDS, the diffusion capacity decreases. And third important is, now around the alveoli there is deposition of fibrous tissue, scar tissue. Now because there is hard tissue around the alveoli, normally alveoli is smooth and around it there will be no fibrous tissue. Now once fibrous tissue is accumulating around the alveoli, again carbon monoxide cannot penetrate this fibrous tissue. So carbon monoxide cannot penetrate this fibrous tissue. So carbon monoxide cannot penetrate this fibrous tissue. Now can you tell me what are the diseases responsible for deposition of fibrous tissue? We have fibrosis, interstitial lung disease. Yes, parents are not allowing. So that is the main disease. Pneumonia, ARDS, fibrosis, ILD. Then in severe emphysema, all these are villains, don't worry. Severe emphysema. So in severe emphysema, as I have discussed, in advanced disease, there will be involvement of alveolar and capillary wall. In advanced disease, the inflammation will reach the alveoli and capillary wall. Because the inflammation is reaching the alveolar and capillary wall, these inflammatory areas cannot allow proper diffusion. These inflammatory areas cannot allow proper diffusion. So important causes of decreased DLCO: severe pneumonia, ARDS, fibrosis, ILD, severe emphysema. Apart from this, anemia, pulmonary embolism, and pulmonary hypertension. So anemia, pulmonary embolism, pulmonary hypertension. Now tell me, so why in anemia, pulmonary embolism and pulmonary hypertension there is decreased DLCO? The reason is, for carbon monoxide to bind with hemoglobin, not just the membrane should be healthy, even there should be sufficient hemoglobin. So if at all there is no sufficient hemoglobin, carbon monoxide cannot cross at all. So these are the conditions where there is no sufficient hemoglobin or reduced blood flow. In anemia, there is decreased hemoglobin. Pulmonary embolism, it is blockage of pulmonary circulation. So blood is not at all coming here. So where is the point of diffusion? So decreased blood flow. So pulmonary hypertension is generally due to pulmonary vasoconstriction. So whenever there is vasoconstriction, will more blood flow or less blood flow? Less blood will be flowing. So if they ask you what are the vascular causes of decreased DLCO, in your mind, what should be the answer? Anemia, pulmonary embolism, pulmonary hypertension. So for carbon monoxide to diffuse properly, not only the membrane should be healthy, but also there should be sufficient hemoglobin. Now with this background, can you tell me what are the causes of increased DLCO? So very important table. So anemia was decreasing DLCO. So what will polycythemia do? So why in emphysema? See, in severe emphysema, you will have inflammation affecting alveolar and capillary areas. So whenever there is an area inflamed, carbon monoxide cannot diffuse properly to inflamed areas. So polycythemia, why there will be increased DLCO? Because in polycythemia there will be increased hemoglobin. Exercise. So why in exercise there will be increased DLCO? So whenever somebody is doing exercise, what will happen to pulmonary blood flow? It increases. Previously, across this area, only 1 ml of blood was flowing. Now 5 ml of blood will flow. So if blood flow increases, what will happen? If blood flow increases, what will happen? The amount of hemoglobin available will also increase, diffusion will increase. So increased blood flow. Increased blood flow. So next important reason for increased DLCO is alveolar hemorrhage. So in ARDS, apart from collapse of alveoli, there will also be alveoli filled with secretions. Yes, okay, because of alveoli filled with secretions also, there will be decreased DLCO. So Nikita, we are doing forced expiration. See, in a normal individual, it will trap. See, he takes deep inspiration and one forced expiration, so it can come out. That CO can come out. So alveolar hemorrhage. So why in alveolar hemorrhage? So consider this is the alveolus and this is the blood vessel. Okay. So normally CO2 has been sent here. In alveolar hemorrhage, there is excess blood in the alveoli. So there is excess blood in the alveoli. So previously this carbon monoxide used to go into the blood vessel to bind with hemoglobin. Now what has happened? There is hemoglobin available within the alveoli itself. So what is going to happen? So these carbon monoxide will bind with bleed and stay in the alveoli itself. So previously at least 10 carbon monoxide was in free form in alveoli coming out. Now because hemoglobin is present within the alveoli, all the carbon monoxide will bind to that hemoglobin and that carbon monoxide will never come out. So here carbon monoxide binds with bleed. Carbon monoxide binds with bleed. So that results in decreased exhaled carbon monoxide. So previously at least some amount of carbon monoxide was coming out. Now all the carbon monoxide will bind with bleed and stay in the alveoli itself. Because exhaled carbon monoxide is decreasing. Exhaled carbon monoxide has decreased. Automatically what will happen to DLCO? DLCO will increase. Exhaled carbon monoxide will decrease and DLCO will increase. See the same questions, why decrease DLCO in pulmonary hypertension? See, hypertension, pulmonary hypertension is due to vasoconstriction. So whenever vessel size is decreased, will more blood flow or less blood flow? Less blood flow. So if less blood flows, what will happen? There will be no exchange or diffusion of carbon monoxide. So diffusion capacity will decrease. Now next important thing is in asthma. So in asthma also, not in all, in few there can be increased DLCO. So the probable reason is, we know that in asthma there is eosinophilic inflammation. In asthma there is eosinophilic inflammation. So because of eosinophilic inflammation, there is increased production of nitric oxide. And what is the function of nitric oxide? Nitric oxide will result in pulmonary vasodilatation. Nitric oxide will result in pulmonary vasodilatation. Pulmonary vasodilatation. So asthma, eosinophilic inflammation that results in increased nitric oxide. So that results in pulmonary vasodilatation. So whenever there is pulmonary vasodilatation, there will be more blood flowing. So whenever more blood flows, there will be more amount of carbon monoxide going into the blood and less will be coming out as exhaled carbon monoxide. That results in increased DLCO. So with this background, there is a new test for asthma called as fraction of exhaled nitric oxide. Fraction of exhaled nitric oxide. So this is a new test for asthma. So this is a new test for asthma. So this is called as FeNO, FeNO. So previously asked question, which test is useful in asthma apart from spirometry? FeNO. So FeNO was in the option. So FeNO is an useful test for identification in asthma. Identification in asthma. So in asthma, there will be increased secretions also. So whenever we do DLCO, we generally give some bronchodilator and do. So their secretions might be cleared. But important reasons. See, that's why I'm telling not in all asthmatics. So we're not in all asthmatics. So FeNO, fraction of exhaled nitric oxide, is a test for asthma. So how it is done? How it is done? See, now consider this water bottle is filled with water. So now I'm putting some salt into this water. Now if I empty this water bottle, the water will be tasting salty. So why there is salty taste in this water? Because there is mixture of salt in this water. In the same way, consider this is asthmatic lung. So in his lung, there is excess nitric oxide produced. So in an asthmatic lung, nitric oxide might be produced in excess. So whenever there is some severe eosinophilic inflammation. Now, if I ask this patient to empty into a machine which will detect nitric oxide, when compared to normal individual, what will this machine tell? So his lung is filled with nitric oxide. Now when I ask him to exhale, so the air in the lungs already is mixed with nitric oxide. So when he exhales into a machine which measures nitric oxide, what will that machine tell? So that machine tells that there is increased nitric oxide in his exhaled air. So whenever there is increased nitric oxide in his exhaled air, the reason might be excess eosinophilic inflammation, and most important disease is asthma. Most important disease is asthma. So this is very, very important. FeNO is an important test for asthma. FeNO is an important test for asthma. So it will tell you how much nitric oxide is present in his lung. So very simple logic. So there is a specialized device which measures nitric oxide. So when an asthmatic blows into that machine, so it will detect nitric oxide. If nitric oxide is high, it means there is an eosinophilic inflammation, most probably due to asthma. So FeNO you should know, it is a test for asthma. You should know what are the conditions responsible for decreased DLCO, what are the conditions responsible for increased DLCO. So next, coming to ventilation perfusion ratio. So these are the important questions. You should know in which in your lung where is maximum ventilation, where is maximum perfusion, and where is minimum ventilation perfusion ratio. So minimum ventilation, minimum perfusion, but maximum ventilation perfusion ratio. So important thing is for these three answer is similar. For these three answer is similar. So again, to understand ventilation perfusion ratio, use common sense, not rocket science. Okay. So now in your lung, where is maximum ventilation? So I will draw a lung like this. So there is apex and this is base. So just to follow the laws of physics and follow the anatomy of the lung. So which part will have maximum ventilation? Yes, your answer should be base. The reason is whenever you take some inhalation, by gravity everything will reach the base first. And if you see the lung anatomy also, it is narrow at the apex, broad at the base. So it is also adjusted with respect to gravity. See, nothing in this universe escapes gravity. Even light also sometimes cannot escape gravity. See, whenever I say even air follows gravity, so few people will think much and they say that, sir, when compared to air, water is heavy, so air should come to the top. So if that is your concept, so why are you breathing well on land and breathing not properly in high altitude? See, even air follows gravity. That's why atmosphere is very dense on sea level or land. When you go to high altitude, atmosphere becomes less dense. So that's why you need oxygen there. So that's why you are living on ground, not in the sky. So maximum ventilation by gravity is base. Maximum ventilation by gravity is base. In the same way, perfusion. This is your heart. This is apex. This is base. So which is easy for your heart? To supply the base with gravity or to supply the apex against gravity. So again, for your heart also, to push down with gravity is easy. So maximum ventilation and perfusion is at base. But interesting aspect is, even though ventilation and perfusion are maximum, ventilation perfusion ratio was found to be minimum. So maximum ventilation, maximum perfusion, but minimum ventilation perfusion ratio will be in the base. So opposite here, minimum ventilation, minimum perfusion, but maximum ventilation perfusion ratio at the apex. So this is general laws of physics based on gravity and also anatomy of the lung. So to facilitate more ventilation, to facilitate more perfusion, that's why lung is very, very big at the base. So God has designed all organs to follow the basic rules of physics. So nothing will overcome those. Now why the ventilation perfusion ratio is minimum here, maximum here? To understand this, I have made a table. I am dividing the lung into three areas: apex, mid-zone, base. In these three areas, we are going to discuss the ventilation, the perfusion, ventilation perfusion ratio and P capital A O2. So wherever I mention P capital A O2, it means alveolar oxygen. If I mention P small a O2, it is arterial oxygen. So here we are seeing the alveolar oxygen predominantly. So here we are seeing alveolar oxygen predominantly. So these are for example only, whatever values I am writing, this is only for example approximate values. So in your exam they are not going to ask you the specific value, they will ask you the trend. So what happens to ventilation when you go from apex to base, perfusion apex to base? So these values are only just for example approximate values. So when they measure in the apex, the ventilation approximately 1 liter, mid-zone 2 liters, base 3 liters. And perfusion, when they measured in the apex, it was approximately 0.3 liters. Actually, the values were in fractions. So I have converted it into whole numbers for your better understanding. So in mid-zone 2.5 liter, in the base 5 liters. So as you go from apex to base, ventilation is increasing, perfusion is increasing. But if you see the ventilation perfusion ratio, so in the apex, even though ventilation and perfusion are less, but when compared to ventilation, perfusion was very, very less. So whenever denominator is less, the ratio will increase. So here the ventilation perfusion ratio 3.3. So in the mid-zone, it was approximately 0.8. So in the base, it was 0.6. So if you look at the base, both ventilation and perfusion are high. But when compared to ventilation, when they measured, perfusion was very high. Perfusion was very high because denominator is high. What happens to ratio? Ratio will be less. So they have measured these values. So these were measured values. So when they measured in the apex, both ventilation and perfusion were less. But when compared to ventilation, perfusion was very less. Because denominator is very less, ratio has increased. In the base, both were maximum. But when compared to ventilation, perfusion was slightly higher. So that's why denominator was high, the ratio is decreased. Now coming to alveolar oxygen. So what happens to alveolar oxygen? Now to understand this better, I will tell you a clinical concept. So in our country, any patient with fever, weight loss and X-ray is showing some upper zone cavities. So what is the first disease that comes into your mind? So see, no need to memorize the values. So just to know the trend. As you go from apex to base, ventilation increases, perfusion increases, but ventilation perfusion ratio decreases. Okay. So a patient with upper zone cavity, fever, weight loss. So what can be your differential diagnosis in a country of like India? So your answer should be secondary tuberculosis. So secondary tuberculosis or cavitary tuberculosis or active tuberculosis. So generally happens in the apex. So what was the reason that you were told previously why TB usually happens in the apex? Secondary TB, why it happens in the apex? Yes? Any answer? Why it happens in the apex? So you must have been told that TB bacilli and oxygen have a love affair because oxygen is more found in the apex, but because of oxygen more found in the apex, TB bacilli go there and proliferate. But if you notice here, whenever I take maximum ventilation, majority is going into the base. Then why TB bacilli are going into the apex and proliferating? See, TB bacilli are the smartest bacilli. They are not such dumb. So they have understood a concept called as ventilation perfusion ratio and P capital A O2. Now what is happening here is, if you see in the apex, there is 1 liter of oxygen. So that 1 liter is consumed by only 0.3 liters of blood. So after gaseous exchange, there will still be 0.7 liters of oxygen. See, 1 liter of oxygen is getting consumed by 0.3 liter of blood in the apex. So residual oxygen there will be 0.7 liters. Whereas in the base, 3 liters of oxygen is getting consumed by 5 liters of blood. So after gaseous exchange, the amount of oxygen there will be very less. So when they have calculated, they have found out in the apex, alveolar oxygen was about 133 mmHg. In the mid zone, 104 mmHg. In the base, 92 mmHg. So TB bacilli have found this concept, so that's why it is going to the apex and actively dividing. So for this, let us see what happens in primary TB, what happens in secondary TB. So primary TB means first time patient is inhaling the TB bacilli. So first time infection with TB bacilli. So whenever he inhales for the first time, so by gravity, majority of TB bacilli will reach the mid and lower zones. So most common site is mid and lower zones. So for primary TB. So because these are areas of high ventilation. These are areas of high ventilation. Whereas secondary TB is active disease. So whenever body's immunity is reduced, so these TB bacilli from the mid and lower zones migrate to the apex. So there they grow actively and result in areas of destruction called as cavity. So most common site will be apex. So why in apex? Because these are areas of high oxygen tension and also increased ventilation perfusion ratio. So primary TB, it is just like first time deposition. So a thief is coming for first time in the home. So he settles at one place. What is that one place? Mid and lower zones. So whenever he finds that nobody is there and he is having that lock, he goes to the apex. So where there is more money. What is money for TB? It is oxygen. So areas of high oxygen tension, that is increased ventilation perfusion ratio. So I will tell you with an easy example. See, apex is just like many of us middle class individuals. So we earn less, we spend very less. So we will be having a bank balance called as ventilation perfusion ratio or alveolar oxygen. Whereas base is just like Vijay Mallya and Nirav Modi. They earn more, spend more than that and run away from the country with some 3000 crore debt. But unfortunately, who will always be suffering because of government action? We middle class individuals, because we are having bank balance, we have to pay the taxes. In the same, these Nirav Modi and Vijay Mallya will always escape. In the same way, TB usually affects that middle class individuals, that is the apex. So TB usually affects the apex as active disease. Base generally escapes. So apex is just like middle class individuals who earn less, spend less. So they are having a reserve balance called as oxygen tension. So that is what TB is feeding on. So whereas base is just like Vijay Mallya and Nirav Modi, so they always escape any actions from the government. So what you should know: primary TB, mid and lower zones. Secondary TB, apex. The reason is increased oxygen tension and increased ventilation perfusion ratio. Now what is this investigation in medicine called as? Deep inhalation followed by forced expiration. You are having a good flow volume curve. What is this? What is this investigation? So this is spirometry. So I think already spirometry must have been dealt in your physiology. But for completion sake, I will tell you some basics. Now consider a normal individual like me here. So whatever I normally take during inspiration or expiration. So whatever I normally take during inspiration or expiration. So this phenomena is called as tidal volume. See, normally in or out is tidal volume. Now after tidal inhalation, if you apply some extra effort, your lung can accommodate some extra air. So this extra accommodated after tidal inhalation, it is called inspiratory reserve volume. See, don't worry about the terminologies. Once again, it will be dealt in physiology. Just for a brief revision, I am telling you. So normal inhalation or exhalation, tidal volume. After normal inhalation, with extra effort, whatever your lung accommodates, it is called as inspiratory reserve volume. Again, normal inhalation, normal exhalation. So after normal exhalation, even if you put some effort, you can exhale the extra amount of air. So this extra exhaled after normal exhalation, it is called as expiratory reserve volume. Now you have taken deep maximal inhalation, forced expiration. Even after forced expiration, something always remains in your lung. This is called as residual volume. Simply follow my instructions. See here. Normal inhalation, normal exhalation. Whatever coming in or out, tidal inhalation. Now normal inhalation, after that with some extra effort. This is inspiratory reserve volume. Again you are throwing everything out. So normal inhalation, normal exhalation. Even after normal exhalation, you can still exhale some air out. This is expiratory reserve volume. Forced expiration, after throwing out all the air, some air always remains in your lung. That is residual volume. Now volumes are individual parameters. Combination of volumes is called as a capacity. So in my body, total lung capacity is combination of all volumes. Tidal volume plus inspiratory reserve volume plus expiratory reserve volume plus residual volume. So very basic physiology. Total lung capacity means combination of volumes. All lung volumes put together, it is called as total lung capacity. Now let us make this easy. The first two put together, it is called as inspiratory capacity. So first two volumes, it is called as inspiratory capacity. So the last two, expiratory reserve volume plus residual volume, it is called as functional residual capacity. Functional residual capacity, also called as FRC. Functional residual capacity. Now see here, now I am taking deep maximal inhalation. So whenever I take deep maximal inhalation, now my lung contains tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. Now what is this called as? After deep maximal inhalation, now I am doing forcible expiration. So whenever I do forcible expiration, all the lung volumes will be expelled out except residual volume, because residual volume is the lung volume which will stay in the lung at any cost. So this parameter excluding residual volume, so these three put together, tidal volume, inspiratory reserve volume plus expiratory reserve volume, it is called as forced vital capacity. It is called as forced vital capacity, also written as FVC. So in a single equation, we have seen individual volumes. So what is inspiratory capacity? First two inspiratory capacity, last two functional residual capacity. All lung volumes put together, total lung capacity. All lung volumes except residual volume, it is forced vital capacity. So to understand this better, let me represent important volumes and capacities in the famous water tank model. So consider this is a water tank. It is having a tap like this. So whatever this water tank can accommodate completely, whatever it can accommodate totally, it is total lung capacity. It is total lung capacity. And whenever I turn on this tap, whatever comes out eventually, it is forced vital capacity. Even after completely turning on the tap, some volume will never come out. This is called as residual volume. So let us see the basic definitions for better understanding. Total lung capacity, it is air accommodated in the lung at deep maximal inhalation. So whenever I do a deep maximal inhalation, now whatever is accommodated in my lung, it is called as total lung capacity. Then what is meant by FVC? Air expelled forcibly after deep maximal inhalation. Air expelled forcibly after deep maximal inhalation. Now see here, this is TLC. Whatever I have expelled is FVC. Then what is residual volume? air that remains after forcible expiration. Air that remains after forcible expiration. This is total lung capacity. Whatever I have expelled out forcibly, it is forced vital capacity. Whatever is still remaining, it is residual volume. Next concept that you should know is what is timed vital capacity. What is timed vital capacity? So here important will be FeV1, FeV2, FeV3. Now for example, now I have exhaled 100 units of air forcibly during expiration, for example. Now what is the normal expiratory time? It is 3 seconds. A normal individual can forcibly exhale out in 3 seconds. In this 3 seconds, this 100 units of air will not come out as 33 units in first second, 33 units in second, 33 units in third second. The reason is whenever I forcibly exhale, maximum recoil will be during the first second. So maximum amount of air will be coming out during first second. Rest will be coming out during the next 2 seconds. So whatever comes out at the end of first second, it is called as FeV1. So FeV1 is FEC at end of first second. So generally at the end of first second, 70 to 80% of air will be coming out. FeV2 is FEC at end of second. So when I say at the end of second, it also includes first second. So when I say this fellow is doing his MBBS, it includes that he has completed his 10th standard. So don't get confused. At the end of second means it includes also first second. When I say your age is 20 years, it means that you have completed your 19th birthday or 18th birthday. So FEC at end of second is FeV2. So this will be about 90%. FeV3, it is FEC at end of third second. So this will be about 98 to 100%. Clinically relevant is the first second for us because maximum recoil happens during the first second. So if they ask you what is the normal ratio of FeV1 by FEC. So if 100 units of air is being expelled in 3 seconds in a normal individual, how much will come out during the first second? 70 to 80%. So very important, normal FeV1 by FEC ratio will be about 70 to 80%. Next important parameters that you should know is peak expiratory flow rate, PEFR, expiratory flow rate, mid expiratory flow rate, also called as MEFR. So what is this peak expiratory flow rate? This is peak flow or highest flow during FEC. Note down, I'll discuss. This signifies flow in large airways, whereas MEFR, it is average flow or velocity calculated during mid portion of expiration. This signifies flow in small airways. So just write down very important concept. I will discuss in detail with an example. So peak expiratory flow rate, mid expiratory flow rate. Now consider there is a ball in your hand and you are throwing it to some distance. So whenever you throw this ball, initially the ball will reach a maximum velocity. So that maximum velocity, it is called as peak expiratory flow. So whatever maximum velocity this ball reaches when you throw up, it is maximum velocity is called as peak expiratory flow. So after reaching the maximum velocity and maximum height, will the ball immediately fall down or will it travel to some more distance and fall down? So the ball will not immediately fall down. It will travel to some more distance and fall down because of a property called as inertia and also influence of gravity. So whatever maximum velocity it has reached initially, it is peak expiratory flow. In the same way, when I take deep inhalation and do forcible exhalation, whatever velocity is attained maximum, it is peak expiratory flow rate. And later during the mid portion, an average velocity will be calculated by the vision. That is called as mid expiratory flow rate. So this is peak expiratory flow rate, and later during the decline in velocity of the expiration, you calculate an average velocity during mid portion of expiration, that is called as MEFR. Now how is this clinically helpful for me? So I say that PEFR signifies flow in large airways, whereas MEFR signifies flow in small airways. So what is the concept behind it? So whenever I do forcible exhalation, so air from which airways will come out? Just common sense. Air from which airways will come out? From the larger airways or smaller airways? Air from the larger airways will come out and contribute to PEFR. Later, air from the smaller airways will come out. So when you forcibly breathe out, the first velocity, highest velocity is PEFR. This corresponds to flow in larger airways. Later, air from the smaller airways will come out. So this corresponds with MEFR. So if they ask you, patient is having asthma, which parameter will you prefer in the monitoring? Is it PEFR or MEFR? Asthma. Yes. See, why in asthma we go for PEFR is, where does asthma happen? Bronchi. That's why it is called as bronchial asthma. So bronchi are considered as medium to large sized airways. Whereas in COPD emphysema, which parameter will you prefer? So in asthma, I generally prefer PEFR because it is disease of medium to large sized airways. Whereas in emphysema, where is emphysema involving? Areas distal to terminal bronchiole. So these are all small airways. These are all small airways. So for monitoring of asthma, we go with PEFR, large airway flow. Whereas COPD emphysema, here disease happens in smaller airways, we go with MEFR. Now these are the important volumes, capacities and flows happening routinely in all of us. So how are these routinely measured? So how are these flows and volumes routinely measured? So we measure with a device called as, portable device called as pyrometer. So we measure with a device called as pyrometer. Okay. So what is the concept of this pyrometry? So this pyrometer will be having a sensor. So whatever you blow into that device, that sensor will detect that air and it will give the volume and flow respectively. So whatever you blow into that machine, that sensor will detect the volume and it will detect the velocity and will give you the values of volume and flow. So conventional spirometer can measure all lung volumes except, this is the next question. So come on, type the answer. Conventional spirometer can measure all lung volumes except residual volume. Because residual volume will never come out of your lung. So conventional spirometer cannot measure residual volume. So because it is not measuring residual volume, can it measure functional residual capacity? No. So it cannot measure functional residual capacity because residual volume is a component. Can it measure total lung capacity? No. Because again in total lung capacity, residual volume is a component. So can it measure forced vital capacity? Yes. Because in forced vital capacity, there is no residual volume. So write down this concept, conventional spirometry. Conventional spirometry cannot measure residual volume, functional residual capacity, total lung capacity. Then how are these measured? These are measured by some special methods. Helium dilution method, nitrogen washout method, and the most advanced method, body plethysmography. So we use these three methods, but if they ask you out of this which is best, B for body, B for best. So best method is body plethysmography. So a conventional spirometer cannot measure residual volume because any volume has to come out and hit the sensor if you want to measure in conventional spirometer. It is not coming out. So residual volume. So it cannot measure residual volume. So it cannot measure functional residual capacity. It cannot measure total lung capacity. So it is measured by either helium dilution method, nitrogen washout method, body plethysmography. Out of this, body plethysmography is considered as the best method. So before taking the lunch break, just give me 15 minutes so that I'll complete the algorithm of obstructive and restrictive because I don't want to lose the continuity here. Okay. So before going into the differentiation of diseases based on spirometry into normal, obstructive and restrictive, the concept. So first you should know some rules in spirometry. So in spirometry, I usually compare the values with the normal values of that given age and gender. So when I say patient's FVC is 80%, it means 80% when compared to normal individual of that given age. When I say patient's FVC is 50%, it means 50% when compared to normal individual of that given age. So first rule, spirometry values are always compared with normal values of that given age and gender. And second important rule is a normal person can forcibly exhale out in 3 seconds. But a spirometer will wait up to 6 seconds during exhalation. So if required, it will wait up to 6 seconds. So why it will wait up to 6 seconds? Because if at all there is an obstruction in the airway, it will see whether the patient's lungs can overcome that obstruction and throw out extra amount of air. So first important rule that you should know, always spirometry values are compared to normal values of that given age. And second important thing, a normal individual can usually exhale out in 3 seconds. If required, a spirometer will wait up to 6 seconds. So why it will wait? To see whether if the patient is having some obstructive lung disease, whether he is able to overcome that obstruction and exhale the air out. And spirometry is always a forcible maneuver. You take deep maximum inhalation and forcible exhalation. So with this background, so it is just like this. So emptying a bottle, FEV1 is whatever coming out at the end of first second. FEC is what is the volume expelled eventually. See this. So whatever that comes out at the end of first second is FEV1. Whatever comes out eventually is FEC. Now let us see. Obstructive, restrictive always should be compared to normal values of that given age. So normally what will happen? So the same diagram that we have discussed. So let this be the total lung capacity. So this will be the FEC and this will be the residual volume. So whenever patient exhales, whenever I turn on this tap, whatever comes out eventually is FEC. In that FEC, what comes out at the end of first second, that is called as FEV1. So whenever I am turning on the tap, what comes out at the end of first second is FEV1. What comes out eventually is FEC. So this you should understand. In a normal individual, because he is normal, everything tends to be normal. His FEV1 will be normal. If FEC will be normal. So the ratio FEV1 by FEC. So because both are normal, the ratio will be normal. So let us take some imaginary values to understand better. So generally FEC will be about 5 liters in a normal individual and maximum will come out during the first second. FEV1 will be about 4 liters. So if you substitute this, so 4 liters by 5 liters. So if you want percentage, you have to multiply into 100. So it will be roughly 80%. Or if you don't want percentage, if you want in decimals, you can write it as 0.8. See, the normal range is 70 to 80% in terms of percentage. If you write it in decimals, 0.7 to 0.8. So this is how a normal lung behaves. So if at all 5 liters is expelled out, 4 liters will come out during the first second. The ratio will be 70 to 80%. Now coming to obstructive lung, how is this different? So here also this will be the TLC. Let this be the FEC. Let this be the residual volume. At the end of first second, we have FEV1. Now, how is obstructive lung? For example, asthma. We take for obstruction asthma as prototype. How is it different? So in asthma, what will happen is there is bronchospasm, narrowing of airway. So the tap is getting narrowed here. You can see. So the tap is getting narrowed here. So whenever this tap is narrowed, now what will happen? At the end of first second, when compared to normal individual, can this water tank expel the same amount of water or will it expel less? See, now the tap diameter has decreased. So when compared to normal individual's lung, here FEV1 will be significantly declined. So instead of 5 liters, instead of 4 liters, only 2 liters may come out. Then what happens to FEC? FEC tends to be normal or only slightly decreased. So FEC tends to be normal or only slightly decreased. Now what is the reason for FEC to be normal or only slightly decreased? See, the reason here is a normal individual can expel out in 3 seconds. But a spirometer can wait up to 6 seconds. Now, this fellow may not expel out in 3 seconds. But if you give him sufficient time, the air can be expelled out if he applies some extra effort. So FEC is nothing but air coming out eventually, maybe 3 seconds or 6 seconds. So eventually there will be emptying. So just you can take an example. So in a normal individual, if I turn on this tap, everything will come out normally in 3 seconds. In an obstructive lung disease, there is an obstruction here. At the end of first second, definitely it will be less. Now if you apply some extra effort and give some extra time, definitely this will also come out eventually. So FVC will be expelled out eventually, but it will take more time. But at the end of first second, FEV1 is specifically amount coming out at the end of first second, it will be decreased. FVC will be normal or only slightly decreased. So here FEV1 is significantly decreased, whereas FVC can stay normal because numerator is declined. The ratio in obstructive lung disease will always be decreased. The ratio in obstructive lung disease will always be decreased. So the ratio in obstructive lung disease will always be decreased. Now coming to restrictive lung disease. Now what is meant by the term restriction? Restriction means there is no proper expansion. So whenever your lung is not expanding, what will happen to the lung volume? It will become small. So this is a small water tank. This is a small water tank. So this will be its total lung capacity. This will be the FVC. Whatever comes out at the end of first second will be FEV1, residual volume. Okay. Now this is a small water tank. See, instead of being of 5 liters FVC, so this will be only 2.5 liters. And FEV1, instead of being 4 liters, it will be reduced 2 liters. So this is a small water tank. Instead of expelling, it is a small water tank. So instead of expelling 5 liters, this is a small one, it will only expel 2.5 liters. At the end of first second, because there is no obstruction in the airway, so a specific amount of air will come out or water will come out, it will be 2 liters. So what happens here is FEV1 absolute value will be decreased, FVC will also be decreased. Because both are proportionately decreased, ratio will be normal. You can see here, this is 2. So 2 by 2.5 into 100. So it will be 80%. It will be 80%. So FEV1 by FVC, if they are proportionately decreasing, so it will be normal. But in few conditions, there might be disproportionate decrease. In few restrictive conditions, there might be disproportionate decrease. So because of very irregular fibrosis, what will happen is, when compared to FVC, the proportionate FEV1, the proportionate decrease will be more in FVC. So you can also get values like this. So this FEV1, so FVC can decrease to 2 liters, FEV1 may stay at 1.7 liters. See, whenever there is some irregular fibrosis, it is very difficult to predict the decline. So there will be proportionate decrease. So now if you see in these conditions, so because denominator is proportionately more decreased, when denominator is proportionately more decreased, what happens to the ratio? Ratio will slightly increase. You can see here also. So 2 into 50. So 1.7 into 50, it will be about 85%. So in few cases, whenever there is irregular fibrosis, there will be disproportionate decrease. So FVC proportionately when compared to FEV1 will decrease. So because of that, the ratio will be slightly high. So you can see an example. So proportionate decline 2 and 2.5, it will remain the same. Ratio will remain the same. If there is a disproportionate decline, like I have shown you, in few cases it was observed. So no specific mechanism. These were observed values. So FEV1 may decrease to 1.7 liter, FVC may be 2 liters. But if you see here, the ratio, because of the disproportionate decrease, it has increased. So in restrictive lung disease, the ratio FEV1 by FVC can be variable. It can be normal to increased. So very important. In a normal lung, the ratio is always normal. In obstructive lung disease, the ratio is decreased. In restrictive lung disease, the ratio will be normal to increased. So I have given you with some example. In restrictive, why it is normal? If both are proportionately decreased, it will be normal. In few conditions, there is a disproportionate decrease due to very irregular fibrosis, advanced disease. You cannot predict the proportion of decline. So in that disproportionate decrease, FVC generally declines more. So that results in normal to increased ratio. So with this concept, let us see the algorithm of spirometry and then we'll take a break. Algorithm. So whenever they give you any spirometry values, first see the ratio FEV1 by FVC ratio. So by seeing the ratio, you should see whether it is low. Low means less than 0.7. So 70% is normal, borderline. So less than 70% in decimals is 0.7. So if it is low, directly you can call it as obstructive lung disease. On the other hand, if it is normal or increased, it can be still normal lung, because in a normal individual the ratio will be normal, or it can be a restrictive lung disease. Now how to differentiate a normal individual's lung with a patient with restrictive lung disease? So in a normal individual, always FVC will be normal. But in a restrictive lung, FVC will be predominantly declined. FVC will be less than 80%. So if the ratio is normal or increased, and if FVC is declined, you can call it as restrictive lung disease. To call it as restrictive lung disease, you should show that the lung volume has decreased. So that can be shown by FVC less than 80%. So if it is obstructive lung diseases, the conditions responsible, we have asthma, COPD. In COPD, we have two subtypes. One is emphysema, other is chronic bronchitis. So two subtypes, emphysema, chronic bronchitis. And third is bronchiectasis. So these are the classical obstructive lung diseases: asthma, COPD, bronchiectasis. Now if it is restrictive lung disease, so restrictive lung disease are classified into two forms. We have intrinsic restrictive lung disease, other is extrinsic restrictive lung disease. So intrinsic restrictive lung disease means directly pulmonary parenchyma is involved. Because of that, lung is not expanding. So here there is pulmonary parenchyma involved. Extrinsic means the alveoli, pulmonary parenchyma are normal. Something outside the lung is not allowing the lung to expand. So pulmonary parenchyma uninvolved. Pulmonary parenchyma uninvolved. Now let us see what are the lung diseases resulting in restriction. Already we have seen fibrosis. So the lung is becoming hard and it is shrinking. So lung will not expand properly. Interstitial lung disease. Fibrosis, interstitial lung disease, and occupational lung diseases. So very important algorithm. So here directly the pulmonary parenchyma and alveoli are involved. Because of that, your lung is not expanding. Now, extrinsic means the problem is not within the lung. Something outside the lung is not allowing the lung to expand. So, first will be chest wall disorders, kyphoscoliosis. So, if your chest wall is abnormal, it will not allow the lung to expand. Now, your chest wall is normal. Even the lung parenchyma is also normal. But your respiratory muscles have become weak. So, when the respiratory muscles have become weak, that will also not allow lung to expand properly. So, you should know what are the neuromuscular diseases that can involve the respiratory muscles. So, we have polio, myasthenia gravis, polio, myasthenia gravis. GBS. GBS means Guillain-Barré syndrome. And the famous amyotrophic lateral sclerosis. The famous amyotrophic lateral sclerosis. So these are the important diseases. So these are the important neuromuscular diseases which can involve the respiratory muscles and can cause restriction. Now, apart from clinical history, there is a parameter which can differentiate intrinsic and extrinsic restrictive lung disease. So, for this, generally we need to do a body plethysmography because we measure both residual volume and total lung capacity. So, this parameter is called as residual volume by total lung capacity ratio. So to differentiate intrinsic and extrinsic restrictive lung disease, so we have a parameter called as RV by TLC ratio. Now let us see what happens to RV by TLC ratio in both. So in intrinsic restrictive lung disease, the problem is within the alveoli. So these alveoli are affected. So because of that, your alveoli are not expanding. So whenever your alveoli cannot expand, it cannot hold air. So alveoli cannot hold sufficient amount of residual volume. So residual volume is declined. So proportionately, the total lung capacity will be declined. So here the problem is in the alveoli, airways, and it is unable to hold air. They are small alveoli, so it cannot hold residual volume. Because residual volume has decreased, total lung capacity will also decrease. So both have been proportionately decreased. There will be a normal RV by TLC ratio. There will be a normal RV by TLC ratio. Now coming to extrinsic restrictive lung diseases, we'll take prototype of some chest wall disorder. Now here what happens is, your alveoli are healthy because they are not affected. So here residual volume can remain normal. So residual volume can remain normal. But ultimately what will happen to total lung capacity, the absolute value? See, if I want to take good inspiration and good expiration, my chest wall should be convenient. Now because of kyphoscoliosis, now this is causing a restriction around my lung. So what happens is, I cannot take good tidal volume. Even if I put my respiratory effort, I cannot accommodate inspiratory reserve volume. See, residual volume is normal because my chest wall is not cooperating my respiration, so I cannot take proper tidal volume. Even I cannot put extra effort. See, it is not allowing me to put that extra effort. So I cannot take inspiratory reserve volume. So residual volume may be normal, but total lung capacity also includes tidal volume, inspiratory reserve volume. So when tidal volume, inspiratory reserve volume decreases, what will happen to the absolute value of total lung capacity? It will decrease. So because denominator is decreasing, so what should happen to ratio? Ratio can increase. So RV by TLC ratio generally in extrinsic restrictive lung disease is elevated. In intrinsic restrictive lung disease, it can be normal. So the reason and concept is given here. In extrinsic restrictive lung disease, no issue in alveoli. They can still hold air. So residual volume can be normal. But ultimately, total lung capacity will be decreased. So with this background, let us solve a question and conclude this algorithm. There was a 25-year-old female. She came to my clinic with complaint of shortness of breath. I have done a blood examination to rule out any anemia. Her HB was normal, because generally young females with shortness of breath, it can be due to anemia. So then I have done a spirometry. So in this spirometry, patient's FEV1 was normal, FVC is normal. Because both are normal, ratio was also normal. And then I performed a DLCO. So diffusion capacity has been significantly decreased. And whenever I asked her to walk, there was decreasing SpO2 on exertion. So what will be the diagnosis? Previously asked Ames question. The options given were asthma, anemia, interstitial lung disease, pulmonary hypertension. So the faster you answer, the sooner you will get the break. Yes. So what is the answer? Okay, let us go with algorithm. So whenever they say FEV1 is normal, FVC is normal, ratio is normal. So when they say all these parameters are normal, you can actually exclude all the diseases given in this algorithm. You can exclude all the diseases given in that algorithm. The reason is, see here. See, I'll go option by option. So can this be asthma? No, because in asthma, to call it as asthma, the ratio should be low. So can this be anemia? How will you call it as anemia if HB is normal? How will you call it as anemia if HB is normal? Can it be ILD? No, ILD is a restrictive lung disease. So to call it as restrictive lung disease, FVC will be declined. FVC will be declined. Here FVC is normal. So FVC is normal, you cannot call it ILD. FVC is normal, you cannot call it ILD. Then what is the only remaining option? Pulmonary hypertension. So pulmonary hypertension is the answer. So can such a spirometry happen in pulmonary hypertension? Yes. So pulmonary hypertension is a disease of pulmonary vasculature. So there is no disease in the lung actually here, especially in primary pulmonary hypertension. So there is FEV1 normal, FVC normal, ratio normal. It means there is no obstruction, there is no restriction. But here DLCO is decreased. It means there is some problem in the diffusion of the gases. So we have discussed what are the three vascular causes of decreased DLCO. Three vascular causes. One is anemia. So this cannot be anemia. Second is pulmonary embolism. Young female without any risk factors, pulmonary embolism is also unlikely. Whereas pulmonary hypertension, it is a possibility. Young females are predisposed to primary pulmonary hypertension. So exercise induced asthma. See, asthma means it is an obstructive lung disease. The ratio should be low. Let it be any asthma. Ratio should be low. Okay. Whereas why it is not ILD? To call it as ILD, it should be restrictive. To call it as restrictive, FVC should be less than 80%. It should be less than 80%. Okay. So why it is not asthma? Because the ratio should be decreased in asthma. Why it is not anemia? HB, if it is normal, you cannot call it anemia. Why it is not interstitial lung disease? To call it as interstitial lung disease, FVC should be reduced. See here, interstitial lung disease, FVC should be reduced. But FVC here is normal, so it is not ILD. So only option left here is pulmonary hypertension. Pulmonary hypertension. Okay. So we'll take lunch break for 45 minutes and we'll return back. So any doubts, you can ask me. So pneumothorax and pleural effusion will result in restrictive lung disease. So severe pneumonia, patient will be on bed, patient will have fever. Here there is no fever. How can you say it is severe pneumonia? Yes, chat box was not working up to now. Now I am seeing the chats. You can just type your doubts here. So young female without risk factors. So you are a young female. Can pulmonary embolism happen in you so early? But without any risk factors also, in few primary pulmonary hypertension happened. So AP diameter was found to be more increased. Emphysema is not an infectious disease. Pneumonia is an infectious disease. Use clinical signs. So break till 3:10, 3:15. Okay. Yes, ratio less than 80%. So 70 to 80% is normal. See, FEV1 absolute value is not increased in restricted, it is decreased. So pneumonia, you can put it under restrictive, but it is not a classical restrictive disease. Ventilation perfusion mismatch will be improved by oxygen, yes. Why FVC normal and obstructive? So simple reason. So if you give more time for the patient, he can still exhale out. If ratio will be less than 80%. See ratio, if it is normal 70 to 80 or more, that is restrictive. So for CO2 washout to happen, patient should have sufficient respiratory drive. See, how do you differentiate normal and restrictive? See the FVC. FVC, if it is less than 80, it is abnormal. So shunt in ARDS and atelectasis. In ARDS also there will be accumulation of secretions. Most common, one of the common cause of ARDS is severe pneumonia. Atelectasis, the alveoli are not expanding. Same thing, even if you give oxygen, it will not expand. See, in a routine inspiration and expiration, air trapping will be there. If you ask the patient to forcibly exhale, the trapped air can come out. But you cannot each and every time do forcible expiration. Patient will develop fatigue. So spirometry, I told you, it is deep inhalation, forced exhalation. So at that time, air will come out. In pneumonia, it is an acute condition, no damage to your central, no problem with your central and peripheral chemoreceptors. Yes, pneumo and pleural effusion, if there is no parenchymal involvement, they can be considered as extrinsic restrictive lung disease. See, your pulmonary artery should be healthy for maintaining saturation, oxygenation. So if it is compressed, what will happen? Oxygen reaching the periphery will decrease, so SpO2 will decrease. So atelectasis, minor areas of lung collapse is atelectasis. Those are similar terms. We use it according to the situation. If I say alveolar collapse, that generally I call it as atelectasis. If I say a big lobe collapse, we just write it as collapse. See, normal lung, FVC will be normal. Again the same thing. In normal lung, FVC will be normal. In restrictive, FVC will be reduced. See, how will you differentiate between this bottle and this bottle? Yes. So this is restrictive. Its FVC will be less. Normal lung FVC will be about 5 liters. Okay. Restrictive will be only 2 liters. See, by seeing these two bottles, can you not differentiate? Yes. The same. This is normal lung. This is restrictive lung. See, normal FeV1 by FVC ratio is 70 to 80%. Raunak Agarwal, you have understood it completely wrong. The ratio is 70 to 80%. Not FVC is not 70 to 80%. Yes, pleural effusion is restrictive. Yes, it can decrease. FeV1 is 80%. FVC in total in restrictive lung disease is less than 80%. See, you take the absolute values. FeV1 is 80%. You should take, see, I have given you questions 1.7 liter, 2 liters. So from that you should calculate percentage. In VP mismatch other than pulmonary embolism, since alveoli is normal, can DLCO be normal? See, whenever there is some ventilation perfusion mismatch, DLCO ultimately can be decreased. It may not be normal. Sarcoidosis ultimately leads to lung fibrosis. When it leads to lung fibrosis, you see restrictive. Let us see a question, clinical scenario based question. So there was a 54-year-old roofer. He is evaluated for 5-year history. Of gradually progressive dyspnea. Is evaluated for 5-year history. Progressive dyspnea and dry cough. There is no wheezing or hemoptysis. He smoked 1 pack of cigarettes from the age 18 to 50 years and he worked as a roofer. So whenever they give you roofer, there is asbestos exposure. No digital clubbing or cyanosis. Auscultation, you can listen some crackles. So crackles means crepitations. Pulmonary function test shows the following parameters. Now if you see here, this patient is also having smoking history. He is also having exposure history. Now he has presented with some dyspnea. Now we need to know whether this was due to some obstructive lung disease or restrictive lung disease. So for that, we go for a spirometry. So crackles or crepitations generally happens in fibrosis. Why it happens, I'll let you know. So when we discuss clinical medicine, now they have given the spirometry parameters. So according to algorithm, first I should see FeV1 by FVC. So predicted means what is normal for given age. Observed means what you have identified in this patient. Percent of predicted is out of the normal, how much is the value in this given patient. Now observed FeV1 by FVC is 85%. So it is increased. So whenever it is increased, so possibility of restrictive lung disease. So how do you say it is restrictive lung disease? So to call it as restrictive lung disease, we should have FVC less than 80% of predicted. So a normal individual's FVC for that age is 4 liter. But this patient's FVC is only 2 liter. So it is only 50% of predicted. It is only 50% of predicted. So definitely this is a restrictive lung disease. So FeV1 by FVC has increased, FVC has decreased. So this is a restrictive lung disease. So out of this, which will cause restrictive lung disease? So it will be asbestosis, because asbestosis can result in lung fibrosis. Lung fibrosis will be responsible for this restrictive defect. So why it is not COPD? So by history, even though patient is smoking, he is not having any V's, and also there is no obstructive defect. So it is not COPD. So pneumonia, it is a 5-year history. So generally pneumonia will be having a 5-day history or 2 or 3 week history. So bronchiectasis is also not a possibility, because this patient is not having an obstructive defect, he is having a restrictive defect. So best answer here is asbestosis. So whenever they give you any spirometry question like this, first see the ratio. So if ratio is decreased, directly it is obstructive. Normal or increased, look for FVC. So FVC, if it is less, generally it is a restrictive lung disease out of the given options. So out of the given options, best answer is asbestosis. Now coming to the clinical medicine, we will start with breath sounds. So breath sounds, it can be divided into 2 forms. We have vesicular or normal breath sounds that happens in all of us. Abnormal breath sounds called as bronchial breath sounds. So vesicular breath sounds are generally low pitch. The character is of low pitch and soft sounds. These are heard over. These are heard over healthy lungs. So low pitch and soft sound heard over healthy lungs. So somebody is asking, why not pneumonia? So Mr. Shakti Bhushan, do you think pneumonia will happen in 5 years? Pneumonia happening without fever, cough, shortness of breath, that is unlikely. Okay. So crackles also present in cells. Generally, crackles are not seen in obstructive lung disease. So DLCO is decreased. The reason in fibrosis is around the alveoli there is fibrous tissue. So carbon monoxide cannot penetrate that fibrous tissue and go into the blood vessel. So because carbon monoxide cannot diffuse properly, DLCO will be decreased. So Navya, Why not bronchiectasis? Bronchiectasis is an obstructive lung disease. So do you find anything suggestive of obstructive lung disease here? So FEV1 by FVC is not decreased. Okay. And also bronchiectasis patient will have productive cough with expectoration. So productive cough, here it is dry cough. So clinically in no way you can call it as bronchiectasis. So spirometry readings in pneumonia, restrictive pattern. So it can have a restrictive pattern. So FEV1 by FVC ratio can be normal to increase, FVC can be decreased also. So I feel that these are all simple things that you should try to solve by yourselves, okay? If there is any complex thing, we can go for a discussion. So if you think once, you will do it, no issue, don't worry. So bronchial or abnormal breath sounds, these are high pitch, loud. So these are high pitch and loud sounds, similar to tracheal sounds. So similar to tracheal sounds, and these are heard over diseased lungs. These are heard over diseased lungs. So bronchial breath sounds or abnormal breath sounds, high pitch and loud, similar to tracheal sounds. These are heard over diseased lungs. Now let us see how normal breath sounds are generated and what happens in diseases. So consider this is the lung with alveoli, very important table. So this is my trachea. So trachea is the large central airway. So generally trachea is a large airway. Air flows into it with lot of turbulence. So because of that, whenever I put my stet on the trachea, even if you take this stet and put on your trachea, so what will be the nature of sound on the trachea? So nature of sound on the trachea, it will be high pitch and loud. So nature of sound on the trachea, it will be high pitch and loud. Now the same sound when it reaches the lung at the level of alveoli. So in the lung, the trachea divides multiple times and finally gives rise to alveoli. So here you will get a low pitch and soft sound. Now what is the reason for this? On the trachea you get high pitch and loud sound. When the same sound reaches the alveoli, it will become low pitch and soft. So what has happened? So trachea is a single airway, so sound in that will have more conduction. But when it comes down, this sound is diversified into millions of alveoli. How many tracheas are present? One. How many alveoli are present? Millions. So this sound will be filtered by the alveoli. So this alveoli effectively filters the sound. Alveoli effectively filters the sound. So because alveoli are effectively filtering the sound, so if you put this stet on the lung, it will be low pitch and soft sound. Whereas on the trachea, it will be high pitch and loud sound. It will be high pitch and loud sound. Now what happens in diseases? So generally on the lung, it is usually low pitch and soft. On the trachea, it is high pitch and loud. Now because of some disease, again if you develop this high pitch and loud sound on the lung, so it is called as a bronchial breathing. So any problem there? It's a black screen. Yeah, I think mine is working fine, no issue. Okay. So in the diseases, now listen here, normally on the lung, you will get low pitch and soft sound. So instead of that, if you get this high pitch and loud sound, it is called as bronchial breathing. So bronchial breathing is high pitch and loud sound similar to tracheal sounds heard on the lung. Now let us see what are the important diseases. So first disease is consolidation. So first disease is consolidation. So what happens in consolidation? A part of lung will be solidified like this. And what is the disease responsible for consolidation? We have pneumonia. Now if you go back to your pathology, there are stages in pneumonia. Stage of congestion, red hepatization, gray hepatization and resolution. So what is meant by hepatization? Hepatization means becoming liver-like. So pathologically, lung is becoming hard liver-like. So clinically, it is called as consolidation. So lung is becoming solid-like. Now tell me, which is the best conductor of sound? Solid. So whenever from the trachea, the sound comes into the solid media, it generally is well conducted and amplified. So because of this solid media, there will be a bronchial breath sound, high pitch and loud sound heard on the lung. So this bronchial breath sound in consolidation, it is called as tubular breathing. This bronchial breath sound in consolidation is called as tubular breathing. So normally on the lung, it will be low pitch and soft in healthy lung. So normal lung. In a disease called as consolidation, the affected part becomes solid. So because of that, you get this high pitch and loud sound. So that is a bronchial breath sound. And the special name given to bronchial breath sound in consolidation is tubular breathing. Next important is alveoli effectively filters the sound. Alveoli effectively filters. It will filter the sound. Okay. So the next important thing is cavity. So what happens in cavity? So in cavity, these alveoli are destroyed and you find a air-filled area like this. So air-filled area. So this is called a cavity. So alveoli can be destroyed and there will be a uniform air-filled area. So what is happening here? So in cavity also there will be a bronchial breath sound. So this bronchial breath sound in cavity is called as cavernous breathing. Cavernous breathing. So why there is loud sound in cavity? So previously in this area there were multiple alveoli filtering the sound. So now what has happened? All the alveoli are destroyed and there is a air-filled structure called as cavity. So there is a cavity formation like this. So now it becomes a uniform structure. So because of that, air directly from the bronchus is going into the cavity. Previously in this area, there were multiple alveoli filtering the sound. So previously when air is to go into this area, it was diversified into multiple alveoli. Now alveoli are destroyed there and it has formed into a uniform area. So there will be no filtration of sound or there will be no decrease in intensity of sound. So if at all there is no decrease in intensity of sound, it will be heard same as in trachea, resulting in bronchial breath sound. Bronchial breath sound. See, the name of bronchial breath sound in consolidation is tubular breathing. Okay, solids conduct the sound effectively. Kindly don't ask me why solids are best conductors of sound. Okay, cavity, in the cavity what is happening? The alveoli are destroyed. So alveoli generally diminish the intensity of sound and now we are having a uniform area. So in that area, directly from the bronchus, sound is going into that cavity, that is resulting in a bronchial breath sound. This is called as cavernous breathing. So there is another entity when the cavity is very, very large. So in a very large cavity like this, so usually occupying a lobe, so a very big cavities. So whenever there was no effective treatment for tuberculosis, we used to see such big cavities. So in this big cavity also, there will be a bronchial breath sound. and this bronchial breath sound will have more blowing cavity. So more blowing quality. So it will have a blowing quality, or sometimes also called as metallic quality. So as if you are blowing into a big jar, as if you are blowing into a big metallic jar, you will listen. So this breathing, it is called as amphoric breathing. So this is only of historical significance, because as of now we are not seeing this big cavities in the lung, because we are treating tuberculosis very effectively. So we are not able to see such large cavities. So but previously there was bronchial breath sound with more blowing cavity or metallic quality. So amphoric breathing. So this is called as amphoric breathing. So cavernous breathing, consolidation will have more harsh, because it is a solid media, it will be more harsh when compared to cavernous breathing. So that when you listen, you can find out the difference. Okay. So these are the three important bronchial breath sounds that can be asked. In consolidation, tubular breathing. In cavity, we have cavernous breathing. So very large cavity occupying a lobe of the lung, we can see amphoric breathing. So amphoric breathing is a bronchial breath sound with more blowing quality and metallic quality. So whenever consolidation or cavity is present, there are some additional auscultatory findings. So if at all I ask the patient to tell 1, 1, 1 and I hear the sound with my stet, what is this phenomena called as? Vocal resonance. So whenever there is cavity or consolidation, when compared to normal side, on the affected area, the vocal resonance will be elevated. So this finding is called as bronchophony. So why will it be elevated? Because either cavity or consolidation will conduct sound very well. Because of that, whenever patient tells 1, 1, when compared to normal side, on the affected side, you can listen the sound excessively. So this phenomena of increased vocal resonance. So this phenomena of increased vocal resonance, this is called as bronchophony. So increased vocal resonance, this is called as bronchophony. Now instead of asking the patient to tell 1, 1, instead of asking the patient to tell 1, 1, I'll ask him to whisper like this. 1, 1, 1, 1. Usually whispered sounds cannot be conducted by normal lung parenchyma. If at all there is consolidation or cavity, even the whispered sounds can be heard clearly with your stethoscope. So this phenomena is called as whispering pectoralici. Increased perception of whispered sounds. This phenomena is called as whispering pectoralici. So in your exam, in your viva, they will be asking all this. What is tubular breathing? Consolidated. Bronchial breathing in consolidation is called as tubular breathing. Bronchial breathing in cavity is called as cavernous breathing. Bronchial breathing with metallic quality is called as amphoric. So increased vocal resonance, bronchophony. Increased perception of whispered sounds, whispering pectoralici. Apart from this, there is an additional finding with unknown mechanism. We don't know the mechanism. So in these areas of consolidation and cavity, there will also be change in character of sound. So change in character of E to A. So this phenomena is called as egophony. So now if I ask the patient to tell a letter called as E. So on the normal side, it will be audible as E only. But if there is consolidation or cavity, there it will be audible as A. So he will be saying E, but on your stethoscope you will listen it as A. So we don't know the exact mechanism, but it was observed here. So this is an unclear mechanism. So let it be consolidation or cavity. What are the additional findings on auscultation? We get bronchophony, whispering pectoralici, egophony, bronchophony, whispering pectoralici, egophony. So the mechanism of egophony is not that clear. So this is the difference between normal breath sounds and abnormal breath sounds. Apart from breath sounds, there will be some additional sounds called as adventitious sounds. So adventitious sounds or C or V's crepitation. See, this bronchophony, egophony, whispering pectoralici can coexist in consolidation or cavity. So they can be seen in consolidation cavity. Now coming to adventitious sounds, we have V's, other is crepitations. So crepitations are also called as crackles, rails. So later on, if in some place I mentioned rails and some place I mentioned crackles, don't get confused with synonyms. Crepitations or crackles or rails mean the same. Crepitation, crackles or rails mean the same. So once again I am telling you, see, this bronchophony, egophony, whispering pectoralici happens in both consolidation and cavity. Both consolidation and cavity. Now coming to V's. So V's is a musical sound. V's is a musical sound that signifies airflow limitation. That signifies airflow limitation. So based on the mechanism, it can be classified into monophonic V's, polyphonic V's, monophonic V's, polyphonic V's. So monophonic V's, it is due to localized airway involvement. So for example, a tumor in bronchus. Polyphonic V's due to diffuse airway involvement. Diffuse airway involvement. Now first of all, let us see what is this V's. So whenever air flows through a narrow space, there will be a whistling sound. So if you take this pen cap, if you blow air into that, there can be a whistling sound because air is passing through a resistance. So that can later on result in a whistling musical note that is called as V's. Monophonic V's means if a single airway is obstructed and it is resulting in V's, it is called as monophonic V's. Polyphonic means simultaneously multiple airways have been obstructed and that is responsible for V's. Can you tell me a disease where multiple airways are simultaneously involved that can result in V's? So multiple airways simultaneously obstructed. So we have COPD, asthma. So COPD and asthma. So multiple airways are simultaneously involved, resulting in polyphonic V's. So the difference is, I think most of you know an instrument called as guitar. If you strike one string, the sound will be different. If you strike all the strings together, the sound is different. So striking a single string is equivalent to monophonic V's. Striking all the strings of guitar together is equivalent to polyphonic V's. Next, in few books, there is a sound called as rhonchi. So clinically, we use it both interchangeably, but rhonchi are actually low pitched wheezes. So wheezes of low intensity and low pitch. So if they ask you exact definition, what is rhonchi? It is a low pitched wheeze. Bronchi, it is a low pitched wheeze. But clinically, it is very difficult to differentiate. We generally use it interchangeably, wheeze or bronchi. So only after doing acoustic studies, sound analysis, we can exactly differentiate wheeze or bronchi. Now coming to crepitations, crackles or rails. So these crepitations are classified into two forms. We have coarse crepitations and also fine crepitations. So coarse crepitations, these are bubbling sounds. Bubbling sounds due to air flow into secretions. So bubbling sounds due to air flow into secretions. So how to identify this? So if you take a straw and blow air into a glass filled with water. So if you blow through a straw into a glass filled water, you will find bubbling sounds. So that bubbling sounds are called as crepitations. So in which disease we see these coarse crepitations? Tell me a disease where your bronchus is dilated like a straw and always there are secretions in that bronchus due to recurrent infections. It is bronchiectasis. So coarse crepitations is actually seen in bronchiectasis. So here bronchus is abnormally dilated like a straw. Always due to some infection there will be secretions. So whenever air flows into that, there will be bubbling sound. This bubbling sound, it is called as coarse crepitations. Next important is fine crepitations. So fine crepitations are sounds of less intensity when compared to bubbling coarse crepitations. So these are popping sounds due to sudden inspiratory opening. Sudden inspiratory opening of previously closed alveoli. So the rule of thumb is coarse crepitations generally happen when large airways such as bronchi are involved. Fine crepitations generally happens when small airways such as alveoli are involved. Fine crepitations, alveolar involvement. Coarse crepitations, generally bronchial involvement. But let us see the mechanism. So popping sounds due to sudden inspiratory opening of previously closed alveoli. Now first of all, let us see what is normally happening. So normally at expiration, your alveoli will be partially open like this. So why it is partially open? Because of a substance called as surfactant. Now whenever there is a disease in and around alveoli, so there can be inflammation or fluid. Inflammation or fluid in and around alveoli. So whenever there is inflammation and fluid in and around alveoli, what will happen? So when there is inflammation like this in and around alveoli, so this inflammation will not allow the surfactant to function properly. Will not allow the surfactant to function properly. Because of that, during expiration, these alveoli will be closed like this. So during expiration, alveoli will be closed like this. So because this inflammation is not allowing surfactant to function properly, so alveoli will be closed like this. So these are all the inflammation in and around alveoli. Now to open this closed alveoli during the next inspiration, all these closed alveoli will be forcibly opened with a popping sound. So all these closed alveoli will be forcibly opened with a popping sound. So see the difference here. See, normally during expiration, your alveoli will be partially open like this. Now, whenever there is inflammation in and around alveoli, that inflammation will result in closure of alveoli like this. During the next inspiration, all these closed alveoli now forcibly will open with a popping sound. So, this popping sound is called as fine crepitations. So, what are the diseases that causes popping sound? So, first is fibrosis. Diseases causing inflammation and fluid in and around alveoli. Pneumonia, pulmonary edema, and interstitial lung disease. In interstitial lung disease, specifically, the crepitations were given a special name called as Velcro crepitations. The fine crepitations in interstitial lung disease was given a special name called as Velcro crepitations. So what is meant by Velcro? So Velcro means a strap like this. So whenever I open a strap like this, can you listen some popping sounds? Yes. So the person who has first identified crepitations in ILD felt the popping sounds were similar to opening of a strap. So that's why he called it as Velcro crepitations. So Velcro means a strap. So when you open a closely affixed strap, you will have some popping sounds. So fibrosis, pneumonia, pulmonary edema, interstitial lung disease. So there will be fine crepitations. So that's called as Velcro crepitations. Now with this background, let us see clinical entities in respiratory medicine. So we can broadly classify this into pulling lesions, pushing lesions, in between no pull or no push. See, emphysema, there is airway narrowing, it will cause wheeze. Emphysema, there is airway narrowing, it will cause wheeze. So what are the pulling lesions that you have come across today? Yes, what are the pulling lesions? So we have collapse. Next is fibrosis. So this is a very important table. I am going to differentiate all these conditions clinically, radiologically. See, in pulmonary edema, there is fluid in the alveoli. So generally fine crepitations happen when there is an alveolar pathology, either inflammation or fluid. Either inflammation or fluid. Next, pushing lesions. As discussed earlier, we have pleural effusion. PLEF means pleural effusion, and other is pneumothorax. And no push or no pull is generally consolidation. So consolidation is a solidification of lung. So there may not be change in intrapleural pressure that acutely. So no push or no pull, consolidation. Now let us try to differentiate this by percussion, auscultation and chest x-ray. First let us start percussion. So if you consider this is the baseline. So if you percuss, so this will be normal lung resonance. So normal lung resonance. Anything more than normal lung resonance, it is called as hyper-resonant note, also called as tympanic note. Anything slightly less than normal lung resonance, impaired note. Still less, it is dull note. Maximum dullness, it is called as stony dull note. So stony dull note generally signifies presence of fluid in the pleural cavity. Very simple. If this is the normal lung resonance, see this will come by practice only. Just I cannot percuss and show you the sounds. It will come by practice only. So this is normal lung resonance. So anything more than normal lung resonance, it is called as hyper-resonant or tympanic. Slightly less, it is called as impaired note. Still less, it is called as dull note. Still less, maximum dullness, it is called as stony dull note. Stony dull note indicates presence of fluid within the pleural space. Now let us first see the pulling lesions, what happens in collapse and fibrosis. So in collapse, there is no air at all. So when I percuss in that area, because there is no air, there will be a dull note. There will be a dull note. And for breath sounds to be generated, air should be flowing in that area. So in that area, there is no air at all. There is no airflow at all. So breath sounds will be absent. Breath sounds will be absent. So breath sounds will be absent. Now coming to fibrosis. Fibrosis is not complete absence of air, presence of less air. So when compared to normal lung, the air will be less. It will not be completely absent. So the resonant note will be between a normal and dull note. It is called as an impaired note. So here the note will be impaired note. And breath sounds will not be completely absent. They will be diminished. Breath sounds will not be completely absent. They will be diminished. Now coming to pleural effusion. So presence of fluid generally will result in a stony dull note. And auscultation, depending upon the amount of fluid, breath sounds will be diminished to absent. Pneumothorax, it is excess air in the pleural cavity. So here it will be an hyper-resonant note. Or in some books, it is also called as tympanic note. Hyper-resonant note, also called as tympanic note. And depending upon the severity of pneumothorax, breath sounds will be diminished to absent. The simple logic is, when there is air, normal resonance. More air, hyper resonance. Less air, impaired note. No air, dull note. Presence of fluid, stony dull note. So as simple as this. So nothing to get confused. So collapse, no air, dull note. Fibrosis, less air, impaired note. Pleural effusion, fluid, stony dull note. And pneumothorax, excess air around the lung, it is hyper-resonant or tympanic note. Now coming to consolidation, because of secretions within the lung. Consolidation is generally due to pneumonia, so it can cause some secretions in the lung. So again there will be a slightly dull note. So slightly dull note. Now coming to auscultation, we have already discussed. There will be bronchial breath sounds. Along with that, bronchophony, whispering pectoralici. So whispering pectoralici. Along with that, egophony. So we have discussed in detail. Consolidation is solidification of lung. So that area can conduct the sound very effectively. So you will have bronchial breath sounds, bronchophony, whispering pectoralici, and egophony. Now coming to the chest X-ray part. Now the collapse. Collapse means airless lung filled. So whenever there is no air, what will be the color of abnormality? It will be white. And consistency, because there is no air at all, it will be homogeneous. So white and homogeneous. Whereas fibrosis is not complete absence of air, it is presence of less air. So because there is less air, so less air is less, so it will be white. But it will not be as dense white as collapse. It will be heterogeneous. So when you see the X-rays, you will know better. So white patch, so complete white, it is collapse. Fibrosis will be bit less white and heterogeneous. So you're asking me, why will sounds decrease in pneumothorax? See, whenever air is accumulating in the pleural cavity, because of that positive pressure, it is going to compress the adjacent lung. So whenever your lung is getting compressed, what is generating breath sounds? Lung is generating breath sounds. So air has to flow in the lung for breath sounds to be generated. Now lung is gradually getting compressed. So air flow will not be proper. So breath sounds will be diminished. If it is a tension pneumothorax or more pressure, complete lung is being compressed whole. So there will be absent breath sounds. Okay. See, for breath sounds to be produced, your lung should be expanding properly. So when there is a pneumothorax, a positive pressure pushing your lung, will your lung expand? No. So breath sounds will be diminished to absent. Now coming to the pleural effusion. So how will fluid appear on the chest X-ray? White. Because it is fluid, you will have the classical meniscoid fluid level. So you will have the classical meniscoid fluid level. So if I show you in the chest X-ray, you can appreciate the meniscoid fluid level better. Now pneumothorax, it is excess air in the pleural cavity. So it will be black. So black is also called as hypertranslucency. So there will be a hypertranslucent area. So along with hypertranslucent area, what else is important? What else is important? See, whenever there is pneumothorax, it will start compressing the lung. So to call it as pneumothorax, you should see the hypertranslucent blackish area along with that compressed lung margin. So that air will be compressing the lung significantly. Compressed lung margin. So compressed lung margin. Now coming to consolidation. So to understand the radiological findings of consolidation, you should know the pathophysiology of the consolidation based pneumonia. So in pneumonia, what happens is initially bacteria enters, bacterial pneumonia, it enters the alveoli. So these bacteria will start proliferating. To fight against that bacteria, your body will send some immune response. Interaction between the pathogen and immune response can result in secretions. So because secretions are present in the lung, patient will develop a cough and this will be expectorated as sputum. Because this is an infection, there will be fever. And because there are secretions in the lung, there will be productive cough. So fever and productive cough are classical features of bacterial pneumonia. Now what do you see on the chest X-ray? Now if you consider a normal chest X-ray, you cannot differentiate bronchi and alveoli as two different structures. The reason is bronchi are filled with air, alveoli are also filled with air. So in a chest X-ray, when two substances are having same density or two structures are having same density, you cannot differentiate them as two different structures. So if you keep two black things closely or if you keep two white things closely on a chest X-ray, so you cannot differentiate them as two different structures because there is no difference in density. Now what is happening in consolidation? So in consolidation pneumonia, secretions are accumulating in the alveoli. So alveoli will turn white. Secretions appear white on chest X-ray. So bronchi will be still black because secretions still will not go into the bronchi. They will be more in the alveoli. Now against this whitish background, the air in the bronchus can be clearly seen. So this phenomena is called as air bronchogram. So write down the classical finding. I'll tell you the mechanism again. In the chest X-ray, you notice air bronchogram. So what is the explanation here? Air in the bronchus will be clearly visualized against secretions filled alveoli. Try to understand this simple concept. So don't make it complex. So don't have other thoughts. Just it is as simple as this. Bronchi and alveoli in a normal person cannot be differentiated because both appear black. In pneumonia, in the alveoli, secretions start accumulating. So what will happen now? So these secretions in the alveoli will give a whitish background. So against this whitish background, air in the bronchus can be clearly seen. So this phenomena is called as air bronchogram. So in this table, we have differentiated the clinical entities into pulling lesions, pushing lesions, no push or no pull. So pulling lesions, we have collapse, fibrosis. Pushing lesions, pleural effusion, pneumothorax. Consolidation, no push or no pull. Apart from this, on clinical examination, if they ask you what is the effective method of localizing the disease, so very important, let it be any of these clinical entities. You should not forget this statement I have told you previously. So to localize in all this diseased side, to localize diseased side on clinical examination, always identify side of diminished chest movements. Always identify side of diminished chest movements. So to localize diseased side, always identify side of diminished chest movements. So with this background, now let us see various radiological features. So in collapse, there will be white homogeneous density. It is a pulling lesion. In fibrosis, it is a pulling lesion, white heterogeneous. Consolidation, no push, no pull. You should look for air bronchogram. Pleural effusion, you should look for whitish area with meniscoid fluid level. Pneumothorax, you should look for hypertranslucent area with compressed lung margin. Hypertranslucent area with compressed lung margin. Just wait, I'll show you on a chest x-ray what is that compressed lung margin. You will understand. So mass lesion, if it is within the bronchus and causing collapse, it will be a pulling lesion. So if it is on the parenchyma and causing push, it will be a pushing lesion. So why heterogeneous? In fibrosis, there is presence of only less air, not complete absence of air. So it will be white but less dense. So that's why it is called white heterogeneous. White heterogeneous. Okay. If there is complete absence of air, it will be completely white. So there will be areas of less air, less air. So it will be, because fibrosis is a bit irregular, it will be heterogeneous. Okay, now let us see some x-rays so that you understand. Now keep these findings in your mind and let us try to recognize on chest x-rays. So first chest x-ray, when they give you, first know whether it is a pulling lesion or pushing lesion. So see the trachea. So tracheal position is maintained. And next is heart shadow. Normally 1/3 of the heart will be on the right, 2/3 will be on the left. So it is maintained. So the heart position is maintained, tracheal position is maintained. So there is no push or no pull, and there is a density here. So there is a density here. So there is a density here. So you are thinking this as consolidation. How to exactly call it as consolidation? You should find air bronchograms. Now can you notice in this whitish area some blackish lines? So there is whitish area. In that, can you notice some blackish lines? Can you notice some blackish lines? Yes. Can you notice some blackish lines? See, there is no change in tracheal position. There is no change in heart position. So, but you can see a blackish lines in the whitish area. So this is consolidation air bronchograms. So if you keenly see, can you see these lines here? So all these are bronchi filled with air. So these are air bronchograms. So same thing you can see on a CT chest. So this is CT chest. So right lung, left lung. So left lung, there is no problem. It is completely black. So whereas right lung, you find areas of whitish area. All these are secretions within the alveoli. So adjacent to these secretions, can you find air in the bronchus clearly seen? See, such air bronchograms are not seen on the normal side. So this is consolidation with air bronchogram. So try to identify. So can you see bronchi here, air in the bronchus is clearly visualized. Same thing, even on a chest X-ray. No significant shift in tracheal position. Heart shadow, it is maintained. So normal heart shadow, there is no pull or push. And can you notice all these black lines? So air bronchograms. So these are air bronchograms and this is consolidation. So next X-ray, this patient is said to have collapsed. So how will I tell this fellow is having collapse? If you look keenly, so the trachea is slightly shifted towards the left. And most important is heart shadow. Nothing is present on the right. Nothing is present on the right. Everything has been shifted towards the left. And moreover, you are having a whitish density here. Now, if you keenly see into this white, can you identify any blackish lines? Can you identify any blackish lines? No. So what is this? This is nothing but collapse. Homogeneous white. So it is homogeneous whitish density. Homogeneous. It is very white. You cannot see anything in that white. Same thing on a CT scan. So right lung, left lung. So right lung, left lung. So right lung is completely expanded. So whereas left lung, this is the area that has underwent collapse. So this is the area that has underwent collapse. So it is completely white. It is completely white. This is collapse of lung. Now keep this white in your mind. Keep this white in your mind and compare the white of consolidation. Now your eyes will automatically recognize air bronchogram. Keep this white and see this white. Now can you see in this white blackish lines called as air bronchograms? Yes. There is no significant shift. So there is no significant shift of trachea or heart shadow. This is air bronchogram seen in consolidation. Now here if you see, it is completely white. Even if you look into that white, there are no lines. So this is not air bronchogram. Shift is present. So this is collapse. Now with this background, can you tell me what is this? So what is this? I'll give you a clue. Disease is on the right side. So disease is on the right side. Disease is on the right side. So disease is on the right side. Yes. So if you notice, you can see right side whitish areas. So the trachea is pulled towards the right. The lung volume has also decreased. You can see left side lung volume has increased. Okay. So right side what has happened? So there is decrease in lung volume. Tracheal pull. Diaphragm is also pulled up. So it is white. So is it homogeneous or heterogeneous? So this is homogeneous white. So what is this? Heterogeneous white. So this is a case of right fibrosis. So once again see here. Consolidation, no shift, air bronchograms. Collapse, shift, white, homogeneous. Fibrosis, shift, white, heterogeneous. So this is a right fibrosis. Now this fellow was said to have left pneumothorax. So to call it as pneumothorax, first I should identify air-filled hypertranslucent area. So this black area is all air-filled hypertranslucent area. Apart from that, what else I should identify? Compressed lung margin. Now if you follow these arrow marks, can you see the lung margin is getting compressed here? Yes. Can you see this? The lung margin is getting compressed here. And also what do you see? Shift of mediastinum to opposite side. So this is a left pneumothorax. So I will zoom it so that you can see air-filled blackish area. So this is hypertranslucent area. Hypertranslucent area. So with compressed lung margin. So this is the visceral pleural line. So because the air has accumulated and it is compressing the lung. So hypertranslucent area with compressed lung margin and shift of mediastinum to opposite side is diagnostic of pneumothorax. Same thing if you see here again for completion sake. So air-filled area. So can everybody see this compressed lung margin? Yes. Can you follow these arrow marks and see the compressed lung margin? Same thing on the CT chest. Right lung, left lung. So right lung majority looks healthy. Whereas left lung, this is the air. So adjacent to air, what you can see? Compressed lung margin. So I'll zoom it so that you'll understand better. So to call it as pneumothorax, air-filled area with compressed lung margin. So you can see here also air-filled area with compressed lung margin. Air-filled area with compressed lung margin. So you should never forget a CT scan of pneumothorax, a CT scan of a chest X-ray of pneumothorax. Air-filled area with compressed lung margin. Next, this patient was said to have pleural effusion. So how did I conclude that this fellow was having pleural effusion? If you notice, the trachea here is going towards the left. And moreover, heart shadow has also come extremely towards left. And there is a density on the right, white homogeneous density. And if you look, it has a meniscoid fluid level. So you have whitish density with meniscoid fluid level with push of mediastinum to opposite side. So all this is suggestive of a right pleural effusion. Now you can get a doubt why it is not collapse. Sir, collapse also X-ray. You are having homogeneous density. Why it is not collapse? Why this is not collapse? Yes. So there are two reasons why it is not collapse. Because collapse is a pulling lesion. If there was collapse here, trachea and heart shadow would have been pulled towards the same side. And second important thing, collapse will not have this meniscoid fluid level. So collapse will not have this meniscoid fluid level. So to call it as pleural effusion, you need a whitish density, meniscoid fluid level, and push of trachea and heart to the opposite side. So collapse is a pulling lesion, very good. And meniscoid fluid level will not be seen generally in the collapse. Sometimes both fluid and air can coexist in the pleural cavity. So what is this phenomena called as? Hydropneumothorax. Both fluid and air can coexist. This phenomena is called as hydropneumothorax. So no doubt this fluid part is hydro. So this, to call it as pneumo, I should not only identify air-filled area. Along with that, what else I should identify? Compressed lung margin. You can see how much the lung has got compressed. So to call it as hydropneumothorax, identify the fluid area. So this is the fluid part. And identify the pneumo. This is the pneumo part. You can see air with compressed lung margin. Air with compressed lung margin. So next question is, they will ask you clinical findings. So what are the important clinical findings? See, will your heart shadow be so irregular like this? So anywhere in the world, so Kothari, how to differentiate compressed lung margins and heart shadow? So will your heart shadow be anywhere irregular like that? And will your heart shadow have a pneumo part like that? Yes, it will not be there. So lung margin may not be that regular like heart, and there is a obvious pneumo. So what I am worried about few students is you are having obvious pneumo and obvious hydro, still you are confused whether that is heart border. So when you are having obvious findings, go with that as diagnosis. So don't think different here. Think what is there first. So it is looking more like hydropneumothorax. So now patient is going to die of hydropneumothorax, not because of heart problem. So don't worry about it. Yes. So what happens if effusion and collapse are together? So the shift may not happen because two are opposite forces. Okay. Now let us see what are the clinical findings in hydropneumothorax. So very, very important, they will ask you. Now consider this bottle equivalent to pleural effusion. So this bottle equivalent pleural effusion completely filled with fluid. So now I will convert this into hydropneumothorax. So because hydropneumothoraxes are done like this only hydrogenic. So whenever I ask my postgraduate to get some sample from the pleural cavity, he will puncture very deep, not only damaging the pleura but also the lung parenchyma. So whenever lung parenchyma is damaged, air from the lung parenchyma will start accumulating in the pleural cavity. Already there is fluid in the pleural cavity. Now if air accumulates, it will become hydropneumothorax. So this is an example for hydropneumothorax. So let us see the findings. So first important finding, now if I start percussing, so wherever there is air, okay, you'll see this better. So this is hydro part, this is pneumo part. So when I percuss, wherever there is air, I get a resonant note. Where there is fluid, a dull note anteriorly. Mid-axillary plane, resonant, resonant, dull note. Posteriorly, resonant, resonant, dull note. Now if I join these 3 points, there will be straight line of dullness. So first important point is straight line of dullness. Second point, I'll percuss in the axillary plane, resonant, resonant, dull. Now I'll ask the patient to lie down like this. So whenever he is lying down like this, now what has happened? Fluid has gone down. Fluid has gone down and air has come up. Now if I percuss, the previous dull note will be shifted to resonant note. This phenomena is called as shifting dullness. This phenomena is called as shifting dullness. Now if I put my stat on the patient's chest, see, now if I shake this bottle vigorously, what do you listen? A splash. Same thing if I put a stat on the patient's chest and shake him vigorously, I will listen a splash. So this splash is called as succussion splash. So 3 important findings. So first is straight line of dullness, shifting dullness, succussion splash. So write down the clinical findings. So 3 important. So first is straight line of dullness, straight line of dullness, shifting dullness, shifting dullness. Third is succussion splash, succussion splash. So these are 3 important clinical findings that you see in hydropneumothorax. Everything starts with the letter S. Straight line of dullness, shifting dullness, succussion splash. So there is a old finding called as sound of coin. Nowadays it is not done. So if they ask you what are the classical findings in hydropneumothorax, 3 important: straight line of dullness, shifting dullness, succussion splash. Yes, you should shake the patient. See, how are you listening a splash here? By shaking the bottle. So it appears a bit uncomfortable, but it has to be done like this only. So hold him like this and shake. So I think Deepu Sharma has never touched a patient. She is worried how to shake the patient. So shake him, no problem. So it is done like that only. So this completes the important clinical concepts. We have discussed the clinical findings of pleural effusion, pneumothorax, consolidation, fibrosis, collapse, hydropneumothorax. We have also seen relevant X-rays. Now coming to the most engaging topic, that is clinical respiratory medicine. So old pattern of questions. So before 2019, so this is old pattern, completely black and white. So direct questions. So so easily you can solve. Whereas new pattern of questions. So colorful. So they were asking clinical scenario based questions, ECGs, chest X-rays regarding instruments, so many, and definitely most dangerous. So this is in short the difference between old pattern of questions and new pattern of questions. Old pattern of questions and new pattern of questions. And MCQs generally nowadays will be like this. All options will look similar. Option A, option B, option C, and always expect the unexpected. So MCQs nowadays are generally like this. So all options look similar. So you should choose the perfect option for the perfect question. So be very choosy, choose the perfect option for the perfect question. Now let us see a clinical case. So there was a 65-year-old male. So there was a 65-year-old male with progressive shortness of breath. Other than history of heavy tobacco use, the patient has a benign past medical history. So the patient has a benign past medical history. So breath sounds are absent on 2/3 on the left of the chest. So I am underlying important points. Percussion reveals dullness. While you place your hand on the left side and ask the patient to tell 99. So there is no tingling. And trachea appears to be deviated towards the left. Which of the following diagnosis is most likely? Which of the following diagnosis is most likely? Which of the following diagnosis is most likely? So whenever they give you a clinical scenario based question, you should solve it stepwise. So first step is, what is the diseased side? What is the diseased side? Second is, what is this? Is it a pulling lesion or pushing lesion? Is it a pulling lesion or pushing lesion? Third, with the given clinical scenario, what might be the probable diagnosis? So what might be the probable diagnosis? Now, step by step. So what is the diseased side? So if they haven't given chest wall movements, you can go with breath sounds. So breath sounds are absent on 2/3 on the left of the chest. So breath sounds are absent. So diseased side is left side. Now is it a pulling or pushing? So look at the trachea. So where is the trachea? It is also left. Trachea is also left. So this is a left pulling lesion. So left pulling lesion in the sense it can be either collapse or fibrosis. It can be either collapse or fibrosis. But in the question they specifically mentioned there is dullness and breath sounds are completely absent. So dullness and complete absence of breath sounds will show collapse. So no doubt this is a left-sided collapse. Now with the given clinical history, what is the probable diagnosis? So this patient is an elderly male, heavy tobacco use. So old age and heavy tobacco use, chances of development of lung cancer. Now what must have happened? In his bronchus, a tumor must have developed resulting in bronchial obstruction. So here the probable diagnosis is bronchial obstruction. So collapse due to, so left-sided collapse due to a bronchial obstruction. So of probable malignant etiology. So what must have happened in this patient? A tumor must have taken origin in the bronchus, and that must have resulted in collapse. Now let us see other options. So why it is not bacterial pneumonia or viral pneumonia? Generally bacterial pneumonia and viral pneumonia, patient will have some fever, cough. And in bacterial pneumonia, you have bronchial breathing, not absent breath sounds. Then why it is not pleural effusion? So why it is not pleural effusion? Yes. So in pleural effusion, if disease was on left side, trachea must have been to opposite side. Pleural effusion is a pushing lesion, not pulling lesion. So whenever they give you any clinical entities based question, first identify the diseased side, whether it is a pulling lesion or pushing lesion. Then with the given history, what is the probable diagnosis? So the answer is left-sided collapse due to bronchial obstruction. Answer for question number 7 is option C. Answer for question number 7 is option C. Now what is this disease? There is problem in gaseous exchange, ultimately results in a dangerous condition called as respiratory failure. So next topic, respiratory failure. So respiratory failure is characterized by either hypoxemia. So hypoxemia means PaO2 less than 60 mmHg, or hypercapnia, PaCO2 more than 45 mmHg. So respiratory failure means PaO2 less than 60. Any one can be seen. Sometimes both can also be seen. We'll discuss in detail. Hypoxemia, oxygen less than 60 mmHg, or carbon dioxide more than 45 mmHg. Now coming to types of respiratory failure. So types of respiratory failure. We have type 1 respiratory failure, also called as hypoxemic respiratory failure. Type 2 respiratory failure, hypercapnic respiratory failure. So hypercapnic respiratory failure. Sachin Daruwala, bacterial, what was bacteria point set? Bacteria will cause consolidation. Okay. So differentiate viral and bacterial pneumonia. See, when I discuss pneumonia, so bacterial and atypical viral pneumonias will discuss in detail. You will see there. Type 1 and type 2 are frequently occurring. So these two are also very important for your exam. We will discuss in detail with help of a table in the next slide. So less frequent are type 3 and type 4 respiratory failure. So type 3 respiratory failure is perioperative respiratory failure due to lung atelectasis, associated with general anesthesia, whereas type 4 it is due to hypoperfusion of respiratory muscles, as in shock. See, type 1, type 2 I'll discuss in detail in the next slide. So less common, we have type 3, type 4. They are associated with specific conditions. So type 3 is a perioperative respiratory failure due to lung atelectasis associated with general anesthesia. See, whenever I give a patient general anesthesia, after surgery is done in the post-operative ward, we generally advise the patient to do some breathing exercises. You will be seeing in post-operative ward, patient will be doing that ball exercise, he will be taking deep breaths. So what is the reason behind that? See, these effects of general anesthesia will be persisting for few days. So if the patient does not do deep breathing exercises properly, his respiratory muscles have not yet recovered. His lung will not expand properly. If at all this patient is not doing breathing exercises properly, lung expansion will not happen. So whenever lung is not expanding, gaseous exchange will not happen. And this respiratory failure in the setting of general anesthesia and perioperative time, it is called as type 3 respiratory failure. So that's why any post-operative patient, once he regains his consciousness, we generally advise deep breathing exercise, because still there will be some residual amount of anesthesia effects on the respiratory muscles. If the patient is not doing deep breathing exercise, his lung will not expand properly. If lung expansion is not there, it results in lung atelectasis, poor gaseous exchange and respiratory failure. Now coming to hypoperfusion of respiratory muscles in shock. So type 4, it happens due to hypoperfusion of respiratory muscles in shock. So in shock, the blood supply to various organs will decrease. So even my respiratory muscles require some blood supply. Even my respiratory muscles require some blood supply. In shock, the blood supply decreases. So respiratory muscles will not function properly. That's why patient can develop damage to can develop problem in gaseous exchange, resulting in respiratory failure. So these two are respiratory failure in specific conditions. So if they ask you general anesthesia related lung atelectasis perioperative in the question, it is type 3 respiratory failure. So shock related is generally type 4 respiratory failure. So these two are in specific conditions, anesthesia related and shock related. Now let us see important type 1 and type 2 respiratory failure. So first let us see what is normally happening. So this is your alveolus. So there will be some oxygen in the alveolus called as alveolar oxygen. So generally we take the value 100 mmHg. So finally the oxygen reaches the artery P small a O2. So this is usually 90 mmHg. So in all the normal individuals, there is a slight difference between alveolar and arterial oxygen. So 100 minus 90. So the AA gradient, the difference will be 10 mmHg. So the average value is 10. The range is 5 to 15 mmHg. So in most of us, there will be a slight difference between alveolar and arterial oxygen. This is called as alveolar arterial gradient. The range is 5 to 15 mmHg. So we take the value 10 mmHg as the standard value. Now with this background, let us see what is happening. So what is happening in type 1 respiratory failure and type 2 respiratory failure. So type 1 respiratory failure is predominantly diseases resulting in transfer of oxygen. And most importantly, there will be a diffusion defect. So there can be a diffusion defect. So all those diseases which result in decreased transfer of oxygen into the blood, and there will be a diffusion defect. So let us see with an example. So consider this is the alveoli and let this be the artery. So let this be the artery, alveoli and artery. So here the oxygen reaches the alveolus. The oxygen reaches the alveolus, but there will be some problem in the alveoli. For example, alveoli are filled with secretions like this. Alveoli are filled with secretions or some problem in the pulmonary vasculature. So because of this, this oxygen cannot completely penetrate into the circulation. Instead of 90 reaching here, only 50 will reach here. So here P capital A O2 can be normal. P small a O2 will be decreased. But if you calculate the alveolar arterial gradient, so here how much is the alveolar arterial gradient? 100 minus 50. So it will be about 50 mmHg. So it is significantly elevated. It is significantly elevated. And PaCO2 can be normal or diminished. Can be normal or diminished. Can be normal or diminished. Now if you see here, the alveolar oxygen reaching the alveolus will be normal. So the problem is not bringing the oxygen into the alveolus. So from alveolus, it is not going into circulation. So because it is not properly going into circulation, within the blood, only 50 mmHg of oxygen will reach. So if you see the alveolar arterial gradient, it will be very, very high. Now what happens to CO2 here? CO2 can be normal or decreased. Now you should get a valid doubt. It is the same membrane where oxygen is finding its way difficult into the circulation. How come CO2 is going out easily? How come CO2 is going out easily? So there are two important reasons. So kindly concentrate here. So first reason is the solubility of oxygen and CO2 in my body is different. CO2 has 20 times more diffusibility and solubility in my body. See, it might be difficult for oxygen to come in, but CO2, because of its 20 times more solubility and diffusibility, it can easily go out. So CO2 can easily go out even if there is some membrane defect. And second important reason is whenever there is hypoxemia. So whenever there is hypoxemia, how will your body fight against hypoxemia? Whenever there is less oxygen, how will your body fight? By increasing the respiratory rate. So whenever somebody is taking more respiration, what is the gas going out in excess? Again your answer is CO2. So either because of increased solubility or hypoxia mediated hyperventilation, CO2 will be normal or diminished. CO2 will be normal or diminished. CO2 will be normal. See, P small a means arterial. I am only discussing about arterial. So alveolus generally CO2 will not be that significant. I am only discussing about arterial. So in this patient, the carbon dioxide levels in the body will be normal or diminished. Now let us see what are the causes of type 1 respiratory failure. So first group, it can be alveolar flooding. So alveolar flooding, alveoli filled with secretions. So it happens in severe pneumonia, ARDS. Second, some problem around the alveoli. So deposition of fibrous tissue. So fibrosis, ILD. And third important thing, even problem in pulmonary vasculature. So pulmonary embolism. Pulmonary embolism. So why CO2 is normal or decreased? One, the solubility of CO2 is high, so it can escape easily. And whenever there is a hypoxemia, there will be hyperventilation. So whenever you are hyperventilating, what is the gas going out in excess? So in hyperventilation, there will be CO2 washout. Now coming to type 2 respiratory failure. So type 2 respiratory failure is due to hypoventilation or any defect that is responsible for decrease in respiratory effort. Any defect that is responsible for decrease in respiratory effort. Again the same diagram. So let this be the alveolus, let this be the blood vessel. Now whenever I say decrease in respiratory effort, it means the patient during inspiration, his inspiratory effort is less. So he cannot take sufficient amount of oxygen. Now his expiratory effort is also compromised. He cannot expel the CO2 out. So what happens here is, because his respiratory effort is not proper, the amount of oxygen coming into his body will be less. So here PaO2, instead of 100, it will be only 60. So there will be decrease in alveolar oxygen. So if the membrane is unaffected, a constant fraction will go into circulation. So a constant fraction. So P small a O2 will be decreased ultimately, because amount of oxygen reaching the alveolus has decreased, and P small a O2 will also decrease. So if you see the gradient, P capital A minus small a. So what happens to the gradient here? 60 minus 50, 10. It will be normal. It will be normal. PaCO2. It will be elevated. So here carbon dioxide will be elevated. See Ajay Kumar, how fibrosis? So we have discussed in diffusion defect. So in fibrosis, what will happen? So there will be a fibrous area around the alveoli, not making the this to go into not making oxygen to go into the blood vessel. So diffusion defect. So these are all the conditions where there is decreased DLCO. We have discussed pneumonia, ARDS, fibrosis, and pulmonary embolism. Okay. So PaCO2 will increase. Why will PaCO2 increase? Because there is no proper respiratory effort. So he is not taking proper inspiration. So oxygen reaching his body is less. He is not doing expiration. So what will happen to CO2 in the body? It will increase. So whenever CO2 increases, pH will reduce. So why this is? Because in my body, acid like substance is CO2, base is bicarbonate. Why it is? Tomorrow we will discuss in acid base balance. Because pH decreases, it is acidosis. This is due to a respiratory parameter. So it is called as respiratory acidosis. So type 2 respiratory failure, there is hypercapnia, and this phenomena is also called as respiratory acidosis. Now let us see the causes of type 2 respiratory failure. So first is a central cause. A central cause. So central cause, brainstem injury. So brainstem injury, narcotic use. So why will brainstem injury cause type 2 respiratory failure? So when the brainstem is injured, your respiratory center will be damaged. So when the respiratory center is damaged, there is respiratory depression. So why narcotics? Narcotics will also cause respiratory depression. So narcotics will also cause respiratory depression. See, you are asking how PaCO2 increase. Everybody stop respiration. What will increase in your body? Stop respiration. Yes, stop respiration. So what will increase in your body? CO2 will increase. If you stop respiration, CO2 will not go out. Here hypoventilation, respiratory effort has decreased. So inspiration is not proper, expiration is not proper. So there will be no CO2 going out. Okay. See, VP changes. So transfer of oxygen, decreased transfer of oxygen. It means there will be some ventilation perfusion mismatch. Then narcotic use, respiratory depression. Then obstructive causes. Obstructive causes. So in obstructive causes, large foreign body, especially in the trachea. Then severe COPD. So severe COPD. So whenever there is a large foreign body, especially in the trachea, so there is an obstruction here. During inspiration, oxygen will not go into the lung. During expiration, carbon dioxide will not go out. Because carbon dioxide is not going out in the body, carbon dioxide increases. So that is the reason for foreign body in the trachea. Now coming to severe COPD. In severe COPD, there will be extreme airway narrowing. So when your airways are extremely narrowed like this, during inspiration, oxygen may not go inside. During expiration, carbon dioxide cannot be expelled out because carbon dioxide is not coming out. There will be increase in carbon dioxide in the body. Then peripheral causes. So central means directly your brain is getting involved. Peripheral causes. Your respiratory muscles may be affected. So neuromuscular disorders. So what are all the neuromuscular disorders which cause respiratory muscle weakness? So polio, myasthenia gravis, Guillain-Barré syndrome, and next important thing is amyotrophic lateral sclerosis. Then diaphragmatic cause. So this diaphragm is the strongest respiratory muscle. So if the diaphragm is injured, that will also cause decrease in respiratory effort. Decrease in respiratory effort. Decrease in respiratory effort. So you can remember the causes of type 2 respiratory failure with a simple mnemonic called as COPD. So with a simple mnemonic called as COPD. Central cause, obstructive cause, peripheral cause, diaphragmatic cause. And if they ask you what is most common lung disease? Most common lung disease responsible for type 2 respiratory failure. So your answer is again COPD. So most common lung disease responsible for type 2 respiratory failure, COPD. So Sachin Mule, you are telling that restricted disease are type 1. What is neuromuscular disease? See, don't go into your own assumptions. Neuromuscular diseases are extrinsic restrictive lung diseases. So you'll go into your own assumptions and you will completely confuse. So it's not like restrictive will be only type 1. It will not be like type 2. So extrinsic restrictive have been here in type 2. So there is no such classification. Okay. So type 1 respiratory failure, alveolar flooding, fibrosis, IL, it will be overlapping. So this restrictive and obstructive. In type 2, we have central cause, obstructive cause, peripheral cause, diaphragmatic cause. So most common lung disease responsible for type 2 respiratory failure is COPD. See, still I don't understand what is the problem with severe emphysema is COPD. Yes. See, ultimately what you need to know is if the patient is having both hypoxemia and hypercapnia. So deciding factor is always CO2. See, in severe emphysema there is hypoxemia and also hypercapnia. But if there is hypercapnia, it has to be called as type 2 respiratory failure. If there is hypercapnia, it has to be called as type 2 respiratory failure. See how COPD, very simple logic. In COPD, there is extreme narrowing of airways. So your airways are completely narrowed like this. So because of that, during inspiration, oxygen cannot come inside. During expiration, CO2 is not going out. See what is happening in COPD emphysema, there is air trapping. What is the air that is getting trapped? Expiration is not happening properly. If expiration is not happening properly, what will not go out? CO2 will not go out. So when CO2 is not going out, it stays in the body. Okay. Then they are asking foreign body. When there is a large foreign body in your throat, so big foreign body in your throat, during inspiration, oxygen will not go inside. During expiration, carbon dioxide will not go outside. Now let us see the treatment of respiratory failure. So why in pulmonary embolism? When I discuss pulmonary embolism, I'll tell you why there is hypoxemia there. There you will understand better. Don't worry. So when we discuss that specific disease, you'll understand better. So COVID causes pneumonia, severe pneumonia. So when it is pneumonia, so there will be type 1 respiratory failure. So treatment of respiratory failure. So treatment. So let it be any patient with respiratory failure, give him some oxygen depending upon the clinical scenario and treat underlying cause. So if it is a pneumonia, you can give antibiotics. If it is due to some bronchospasm, you can give nebulization. So oxygen plus treating the underlying cause. Oxygen treating the underlying cause. Then even after doing this, if patient not improving, so treat underlying cause means if there is pneumonia, antibiotic, bronchospasm, some nebulization. If there is a foreign body obstructing oxygen entry and carbon dioxide exit, you can put a bronchoscope and remove that foreign body. If patient not improving, so this patient requires mechanical ventilation. So mechanical ventilation. So what is this mechanical ventilation? You are giving oxygen with some positive pressure. In simple words, oxygen, you are pumping oxygen into lungs with a positive pressure. So you are pumping oxygen into lungs with a positive pressure. So this mechanical ventilation based on method of delivery, it is divided into two forms. So we have invasive mechanical ventilation. Next is IMV, non-invasive ventilation, that is NIV. So invasive mechanical ventilation is positive pressure ventilation delivered through endotracheal tube. So we are discussing the treatment of respiratory failure. So let it be any respiratory failure. This is the general treatment. So initially give oxygen and treat underlying cause. If not improving, go for mechanical ventilation. Now what is NIV? So this is positive pressure ventilation delivered through tight fitting face mask. So general treatment of respiratory failure. Now this IMV means you are putting a tube into the trachea, connecting to a ventilator and giving positive pressure. NIV means you are giving positive pressure through a tight fitting face mask. NIV is giving positive pressure through a tight fitting face mask. Now I'll show you some images. By seeing those images, you should only tell me which is NIV, which is IMV. So image number 1. So what is this? So here there is a device called as ventilator. It gives positive pressure ventilation. So how is it given through? It is given through endotracheal tube. It is given through endotracheal tube. So what is this type? It is invasive mechanical ventilation. Invasive mechanical ventilation. Because you are invading the respiratory tract by putting a tube. It is called as invasive mechanical ventilation. So what is the most important benefit of endotracheal tube, especially in unconscious patients? So whenever there is an unconscious patient, his cough reflex will be completely lost. So because of that, there will be secretions pulled up in his oral cavity which can aspirate into the lung, and this aspiration can kill the patient. Now if you put an endotracheal tube, his airway will be secured and there will be less chances of aspiration. Biggest advantage is airway secured. Airway is secured. So somebody is asking how is oxygen given in the first instance? It is given through a face mask. So if you go to the casualty, there will be flow meter central line. You can give it through a face mask. See, again I told you, oxygen in COPD is not a contraindication. Don't give high flow, give low flow. Whatever is required you give. Don't completely stop. Okay. So IMV, It means airway is secured. And next important image here is, what is this? So there is a ventilator. This will also give positive pressure ventilation. And how is it given through? It is given through a mask. So what is this? NIV. So what is this? NIV. So this is NIV. So you can see through a tube, endotracheal tube, it is invasive mechanical ventilation. Through a mask, it is non-invasive ventilation. Now, what is most important prerequisite for giving non-invasive ventilation? So what is the most important prerequisite? Patient should be conscious and coherent. So patient should be conscious and coherent. You cannot give NIV in unconscious patient. So why you cannot give NIV in unconscious patient? What is the reason? So already in unconscious patient, there will be pooling up of secretion in his oral cavity. Now if you seal with a face mask and if you give positive pressure to that patient, all the secretions from the oral cavity will go into the lung, and actually instead of improving the patient, you will be killing the patient. So there are few contraindications for NIV. There are few contraindications for NIV. So write down NIV contraindications, in whom it should not be given. NIV contraindications. So first is unconscious patient. Risk of aspiration. Patient in altered sensorium. Altered sensorium. So if he is altered sensorium, his cough reflex will also be altered. So risk of aspiration. Risk of aspiration. Third is uncooperative patient. Uncooperative patient. So if patient is uncooperative, he will easily pull out the mask. So now my question is, can you give invasive mechanical ventilation in uncooperative patient? Definitely yes. So when you are giving invasive ventilation, you are completely sedating the patient and knocking him down. So there is no point of cooperation or uncooperation. He has to bear with it. But in NIV, you cannot give sedation. If you give again sedation, there will be respiratory depression. Patient may become later unconscious, resulting in aspiration. So fourth important thing is cardiac arrest. So in cardiac arrest, you should not give. So in cardiac arrest, you should not give NIV. So why not in cardiac arrest? Because already patient is unconscious. Already patient is unconscious. Cardiac arrest itself means patient is unconscious and unresponsive. You cannot give in cardiac arrest. Hemodynamic instability. So if at all patient is in shock, you cannot give NIV. Directly go for invasive mechanical ventilation, because you don't know when this patient will land up in cardiac arrest. So generally in hemodynamic instability, we don't prefer NIV. Next is recent nasal surgery. So recent nasal surgery. Recent nasal surgery. So why I should not give in recent nasal surgery? Here positive pressure is not just given through the mouth, it is given through the nose. So whenever there is a recent nasal surgery done, this positive pressure can damage the surgical wound. So whenever surgical wound is damaged, bleeding can happen. So bleeding from nose can eventually go backward into the trachea, and blood clots can form, resulting in asphyxiation with blood clot. So recent nasal surgery, if you give, there will be risk of bleeding from the nose. And second important thing, active GI bleed. Active GI bleed. Active GI bleed. So why in active GI bleed? See, patient is having hematemesis, blood vomiting. So now if you seal his mouth with a mask, if at all patient develop vomiting of blood, so that will not go out, it can go backward into the lung, resulting in asphyxiation with blood clot. Now, if you find any one of these conditions in these patients, NIV should not be given. So, NIV should be avoided in unconscious patients, uncooperative patient, altered sensorium, cardiac arrest, hemodynamic instability, recent nasal surgery, and active GI bleed. Now, with respect to type of respiratory failure, let us see the preferred methods. So this invasive mechanical ventilation is generally preferred method for type 1 respiratory failure. So for type 1 respiratory failure, it is preferred method. The reason is invasive mechanical ventilation guarantees better transfer of gases. Now problem in type 1 respiratory failure is oxygen is coming into the alveolus. From the alveoli, it is not going into the circulation. Now pressure at what level can easily push the oxygen into circulation? Is it at the nose or directly in the lung? So if you give pressure directly in the lung with an endotracheal tube, so that positive pressure will reach the alveoli and it will push the oxygen from the alveoli into the circulation. So there will be better transfer of gases in invasive mechanical ventilation, which was the problem in type 1 respiratory failure. Now coming to non-invasive ventilation. So this non-invasive ventilation is preferred method in type 2 respiratory failure. By the time a patient reaches to me with type 2 respiratory failure, majority will be having COPD, chronic obstructive pulmonary disease. So why in COPD I prefer NIV, not IMV? Why in COPD? You know that in COPD emphysema, there are hyperinflated areas called as bullas. Now, if you put a tube directly into the lung and if you give positive pressure into the bullas, already a balloon is expanded to its maximum capacity. Now, if you blow some extra air, what will happen to the balloon? That balloon will rupture. So, here also those bullas will rupture. When those bullas will rupture, air escapes into the pleural cavity, resulting in a dangerous complication called as pneumothorax. Air will escape into the pleural cavity, result in a dangerous complication called as pneumothorax. And second important thing is, you have put a tube directly into the lung and ventilating. And you are ventilating through a mask. Out of these two methods, which method is associated with ventilator associated pneumonia? Invasive mechanical ventilation, because a tube is placed in the lung and that ventilator can already be huge source of infections. From the ventilator, infections can easily go into the lung, Already a patient with COPD, his lung function is not good. If at all some new infection creeps into his lung, the prognosis will be very, very bad. So to avoid the risk of pneumothorax, so why we prefer NIV? Because decreased risk of pneumothorax and also decreased chances of ventilator associated pneumonia. So decreased chances of ventilator associated pneumonia. Then if patient not improving, on NIV, only as a last resort, IMV can done. Only as a last resort, invasive mechanical ventilation can be done. So you cannot leave the patient like that. So for ethical and moral reasons, you should try with invasive mechanical ventilation. Now try to understand here, a patient with COPD in respiratory failure, So what is the preferred method of mechanical ventilation? Your answer should be NIV. NIV. If patient is not improving on NIV, only as a last resort, we give invasive mechanical ventilation. Invasive mechanical ventilation. See, for COPD, you give low PEEP because of that complication. That complication happens. So when you do it, you give low PEEP. You try to avoid it maximum. But if you are unable to avoid it, you connect to a ventilator, you give low PEEP. Okay. When there is no other choice, you go for invasive mechanical ventilation. Now I'll ask you two questions, you tell me the answer. A patient with COPD, type 2 respiratory failure, was found unconscious. What will be the preferred method of mechanical ventilation? Patient with COPD, type 2 respiratory failure, unconscious. What will be the preferred method of mechanical ventilation? Yes, what is the answer? See, though it is a type 2 respiratory failure, patient is unconscious. Patient is unconscious. So if he is unconscious, you should not go for NIV. You should directly go for IMV. You should directly go for IMV. So next question, patient with COPD type 2 respiratory failure, conscious. What will you prefer? If he is conscious, you prefer NIV. So let it be this IMV or NIV. It actually depends upon patient's present clinical status. At that point of time, you should see the patient condition and decide what to do next. Now try to solve this question. A 25-year-old male brought to the emergency department who was found unresponsive at home. He has history of IV drug abuse. History of IV drug abuse. So even those who are taking inhalational drugs, they will generally be having IV drug abuse. He is having HIV and also medical non-compliance. His last CD4 count was less than 200. On initial evaluation, his BP 120/75, pulse 105, respiratory rate decreased, SpO2 less. ABG is showing these parameters. Which of the following respiratory failure is predominantly seen? So tell me the answer. What is the type of respiratory failure here? Yes, what is the type of respiratory failure here? So if you see here, there is PaCO2 70. It has increased. PaO2 55. It has decreased. There is both hypercapnia and hypoxemia. Whenever both are present, always hypercapnia is the deciding factor. So answer is option B. So what might be the cause of respiratory failure in this patient? So if they extend the question, what might be the cause of respiratory failure in this patient? So this patient is having IV drug abuse and also his respiratory rate is very less. He has become unresponsive. Mostly because of that IV drug abuse, this patient might have gone into respiratory depression. So the reason for type 2 respiratory failure here is drug abuse resulting in respiratory depression. So that is narcotic overdose. I think most of you people might be drowsy. Wake up. Next is very important topic. So this disease is characterized by bilateral diffuse alveolar damage. What is this disease called as? ARDS. Acute respiratory distress syndrome. So write down the definition of ARDS. So ARDS is characterized by acute shortness of breath, hypoxemia, along with that bilateral diffuse pulmonary infiltrates. So very important definition. So characterized by acute shortness of breath, hypoxemia, bilateral diffuse pulmonary infiltrates. Now the causes of ARDS can be classified into two forms: direct cause, indirect cause. So direct cause means the disease starts in the lung. As a complication later, ARDS develops. Indirect means the disease starts in some other system in the body. As a part of systemic inflammatory response syndrome, the inflammation reaches the lung, damages the lung and results in ARDS. So if the disease starts in lung and causing ARDS, it is direct cause. Indirect cause, disease is happening somewhere in the body. As a result of systemic inflammatory response, that inflammatory response reaches the lung, damages the lung and results in ARDS. Let it be direct or indirect cause, already ARDS is a dangerous complication. Direct causes: severe pneumonia, aspiration of gastric contents, toxin inhalation, lung contusion, near drowning. Indirect causes: sepsis, blood transfusion, sepsis, blood transfusion, severe trauma, burns, pancreatitis. So these are the 10 important causes of ARDS. 10 important causes of ARDS. So severe pneumonia, aspiration of gastric contents, toxin inhalation, lung contusion, near drowning. Sepsis, blood transfusion, severe trauma, pancreatitis. According to 20th edition Harrison, about 40 to 60% cases of ARDS, about 40 to 60% cases of ARDS are due to sepsis and pneumonia. So in majority, the cause of ARDS is infective. So in 40 to 60% of cases, the reason for ARDS is some infective manifestation. So about 40 to 60% of cases are due to sepsis and pneumonia. Sepsis and pneumonia. So you can write it as sepsis and pneumonia. So either there will be a systemic sepsis or pneumonia, severe pneumonia resulting in ARDS. Now coming to what are the other names of ARDS. So based on the pathophysiology, there are some different names. So first is ARDS is also called as non-cardiogenic pulmonary edema. So this is frequently used name. It is also called as low pressure pulmonary edema. Also called as increased permeability, pulmonary edema. It is called as diffuse alveolar damage, also called as shock lung. So why in sepsis? So sepsis, I think you must be knowing very basic. There will be SIRS, systemic inflammatory response syndrome. So in that systemic inflammatory response syndrome, there will be multi-organ damage. So if lung will also be damaged, resulting in ARDS. Okay. So now write down these names. Later on I will tell you the physiological basis of these names. It is called as non-cardiogenic pulmonary edema, low pressure pulmonary edema, increased permeability pulmonary edema, diffuse alveolar damage. Because ARDS frequently occurs with septic shock. So this was also called as shock lung. ARDS was frequently occurring with septic shock. This is also called as shock lung. Because ARDS frequently occurs with septic shock, it was called as shock lung. So this ARDS is frequently called as non-cardiogenic pulmonary edema. So first understand what is cardiogenic pulmonary edema. So then you will know how ARDS is different. So see, I'll tell you all the reasons why it is low pressure, why it is not cardiogenic, why it is increased permeability. Just have some patience. Okay. So non-cardiogenic pulmonary edema. Why it is called? So before that, if you understand what is cardiogenic pulmonary edema, it will be clear. So make a table. We are going to discuss the pathophysiology of both cardiogenic pulmonary edema. See, trauma causes lung contusion. Only to the lung, it is lung contusion. Severe trauma throughout the body. So cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, also called as ARDS. So first of all, let us see the basics. So consider this is the body. So from the body, all the deoxygenated blood goes into the right atrium. So from the right atrium, it will go into the right ventricle. So from the right ventricle, there is a big vessel called as pulmonary artery. So pulmonary artery. So this pulmonary artery will carry the blood to the alveolus. At the level of alveoli, this pulmonary artery gives rise to multiple branches called as pulmonary capillaries. And these pulmonary capillaries merge to form a big vein again called as pulmonary vein. And this pulmonary vein opens into left atrium, left ventricle. So from the left ventricle, the oxygenated blood goes back into the body. So this is the general circulation from the body into the right heart into pulmonary artery, oxygenation in the lungs, from the lungs, pulmonary vein into the left heart, from the left heart into the body. Now for development of cardiogenic pulmonary edema, most important thing is patient should be having a pre-existing cardiac disease. So let us take a prototype. So this patient, let him have a severe mitral stenosis. So left heart disease, this patient is having severe mitral stenosis. So what will happen here? So this is the mitral valve has become narrowed. So mitral valve has become narrowed. So whenever mitral valve becomes narrowed, now the pressure in the left atrium increases. So there will be increase in left atrial pressure. So increase in left atrial pressure. Now from the left atrium, this pressure can be reflected backward into the next contiguous structure. What is the next contiguous structure backward? Pulmonary veins. So there will be increased pulmonary venous pressure. There will be increased pulmonary venous pressure. Now from the pulmonary veins, this pressure can be reflected backward into the pulmonary capillaries. So there will be increased pulmonary capillary pressure. Increased pulmonary capillary pressure. See this concept. So whenever there is an obstruction here, okay, there is an obstruction here. Now blood is trying to flow from the left atrium into left ventricle, but there is an obstruction. So because of that obstruction, there will be increased pressure in the left atrium. From the left atrium, this pressure can be going into the contiguous structure called pulmonary vein. So from the pulmonary vein, it will go into the pulmonary capillaries. So this phenomena is called as increased back pressure. So because of increased back pressure, there will be elevated left atrial pressure, elevated pulmonary venous pressure, elevated pulmonary capillary pressure. Now for development of edema anywhere. So just review your pathology, either increased hydrostatic pressure or decreased oncotic pressure. Now increased pressure in the pulmonary capillaries, increased hydrostatic pressure. So because of increased pressure within the pulmonary capillaries, blood and fluid from the capillaries will start accumulating in the lung. So blood and fluid will start accumulating in the lung. So that results in pulmonary edema. So that results in pulmonary edema. So from the pulmonary capillaries, blood and fluid starts accumulating in the alveolus. So this results in accumulation of blood and fluid into the alveolus. This phenomena is called as pulmonary edema. So what is the reason? Increased back pressure. Now if at all this disease is not corrected, now what else can happen? So from the pulmonary capillaries, there will be pressure reflected onto the pulmonary artery. So that can result in pulmonary hypertension. So because of pulmonary hypertension, your right ventricle now will have to pump more. So after some time, your right ventricle will give up, resulting in right ventricular dysfunction and right heart failure. Right heart failure. So now, when there is right heart failure, there will be some peripheral manifestations. So that would have been discussed in cardiology. Now my question is, can a left atrial disease, can a left heart disease result in pulmonary edema? Yes. So what is the mechanism? Your answer should be back pressure, increased back pressure. Can a left atrial disease or left heart disease result in pulmonary hypertension ultimately? Yes. What is the mechanism? Increased back pressure. In the same way, can it result in right heart failure? Yes. So that is also again increased back pressure. Because of increased back pressure, these are the sequence of events. Pulmonary venous hypertension, increased pulmonary capillary pressure, increased pulmonary arterial pressure, ultimately leading to right heart failure also. Now, if you see in this back pressure, most important event here is increased left atrial pressure. Most important event here is increased left atrial pressure. Now, for example, if I want to measure right atrial pressure, I can put a catheter directly into the right heart through the jugulars and measure the pressure. But such accessibility is not available for your left heart. Now, how to measure the left atrial pressure? So for that, I take a specialized catheter. So I put it into the jugulars, right atrium, right ventricle. I go into the pulmonary artery, and in a small branch, I am going to wedge this catheter. Now tell me, any significant change in left atrial pressure, will it be reflected onto this catheter? Yes or no? Yes. So this method of indirectly measuring left atrial pressure by putting a catheter in pulmonary circulation. What is this phenomena called as? Pulmonary capillary wedge pressure. So write down PCWP. So PCWP is pulmonary capillary wedge pressure. So this PCWP is indirect measurement of which pressure? Left atrial pressure. So in my body, I cannot put a catheter directly into left atrium. There is no access. So what I do? From the jugular, right atrium, right ventricle, I go into a small branch of pulmonary artery and I wedge this catheter. Any significant change in left atrial pressure will be reflected here. So in cardiogenic pulmonary edema. What will happen to PCWP? Will it be normal or elevated? Tell me, will it be normal or elevated? It can be elevated because there is increased left atrial pressure. It will be elevated, and the reference value they have taken as 18 mmHg. So normal value is somewhere 8 to 12. So here for cardiogenic pulmonary edema, they have taken reference value as 18 mmHg. 18 mmHg. So Kiranjot Kaur, you want a foramen for just a diagnostic procedure. See, you put a catheter. Foramen means you should open the heart and do a surgery. So I think if at all you become a surgeon, even for a small lipoma, you are going to excise the whole abdomen. Oh my God. Make a foramen in the right heart to left heart. See, the art of a physician or surgeon lies in using minimal access to gain maximum benefit. Use minimal access to gain maximum benefit. Okay, so this is a minimal access procedure, a small catheter. So it goes into right atrium, right ventricle, and it reaches the catheter. No need to drill a hole into left atrium. You take ortho, it will be very good. Okay. Now coming to non-cardiogenic pulmonary edema or ARDS. Non-cardiogenic pulmonary edema, ARDS. What is happening? So here, consider this is the alveolus. So nowadays people have become very, very creative, very good. So here the initiating event is in developing ARDS. Initiating event is there will be damage to capillary endothelium and alveolar epithelium, capillary endothelium and alveolar epithelium at multiple areas in both lungs. So because of disease, there will be damage to capillary endothelium and alveolar epithelium at multiple areas in both lungs. So here one such damage, I will show this as an example. So because of the inflammatory response or because of the disease, there is damage to capillary endothelium. So this is the capillary, this is the alveoli. There is damage to capillary endothelium and alveolar epithelium. So whenever there is a damage, there will be formation of a leak like this. There will be formation of a leak like this. So through this leak, notorious cells in the body called as neutrophils will gain access into the alveoli. So there will be increased permeability to neutrophils. So increased permeability to neutrophils. So lot of neutrophils will start accumulating in the alveoli, and this is happening at multiple areas. So mind it, not just a single alveoli, multiple areas in both lungs. So wherever neutrophils go, what will happen? There will be an inflammatory damage. So that results in inflammatory damage, that results in exudative fluid, exudate formation. So there will be increased permeability to neutrophils. That results in inflammatory damage and exudative fluid. So whenever there is an inflammatory damage, there will be some exudative fluid formation. Now if you observe here also the end result is some fluid formation in the alveoli. And this is happening bilaterally, multiple areas in both lungs. In cardiogenic pulmonary edema also, ultimate result is fluid. Cardiogenic pulmonary also, ultimately there is fluid accumulation. Here also there is fluid accumulation in the lung and multiple areas. But this is not due to a cardiac cause. So that's why it is called as non-cardiogenic pulmonary edema. So somebody was asking me, sir, tell me why it was called as low pressure pulmonary edema, increased permeability pulmonary edema. Now I'll let you know. So this is a pulmonary edema, but there is no cardiac cause. So it is direct injury to the lung. So it is called non-cardiogenic pulmonary edema. And why it is happening? Due to increased permeability to neutrophils. So that's why it is called increased permeability pulmonary edema. Now if you measure PCWP in this disease, so will it be elevated, yes or no? In ARDS, what will happen to PCWP? There is no left atrial disease. In ARDS, PCWP will be not elevated. It will be less than 18 mm Hg. Because in cardiogenic pulmonary edema, the pressure is high. It was called as high pressure pulmonary edema. Whereas in ARDS, the pressure is less than 18 mm Hg. So it is called as low pressure pulmonary edema. So try to understand. There is pulmonary edema without cardiac cause, non-cardiogenic pulmonary edema. There is increased permeability to neutrophils. It is called increased permeability pulmonary edema. And it is associated with PCWP less than 18 mm Hg. So it is called as low pressure pulmonary edema. Because the damage is happening bilaterally, it is called as diffuse alveolar damage. Now I'll show you a clinically relevant image. So this is the technique. So PCWP. So it is a simple and less invasive technique. So what I meant to say before regarding that PCWP, it was just a joke. So I'm extremely sorry if I had hurt anybody. So it was just a joke to activate you, all of you. So what I say is, whenever you are having a minimally invasive procedure, first use it. If it is not possible with that, you go to the next invasive procedure. So medicine, see, I being a physician, I usually go with minimally invasive procedures because I am very frightened, because I am not a surgeon. So because I was frightened to take surgery, so my thing will only be minimally invasive procedures first. So now you can notice here, this is a specialized catheter called as Swan-Ganz catheter, also called as pulmonary artery catheter. Swan-Ganz catheter, also called as pulmonary artery catheter, So here, this is a specialized catheter. I have placed it in the jugulars. So from there, we are going into right atrium, right ventricle, pulmonary artery into a small branch. So what will this indirectly measure? Left atrial pressure. So PCWP indirectly measures left atrial pressure. Now coming to ARDS diagnostic criteria. So ARDS diagnostic criteria. So write down the diagnostic criteria. First is, patient will have acute onset of shortness of breath, and the timeline is within 1 week. And if you take his chest X-ray, there will be bilateral diffuse infiltrates on chest X-ray. Origin of edema will be non-cardiogenic. So origin of edema is non-cardiogenic, and these patients will have hypoxemia. So PaO2 less than 60 mm Hg. So PaO2 less than 60 mm Hg. Hypoxemia. So these were the criteria. So acute onset of shortness of breath within 1 week, bilateral diffuse infiltrates. If you take a chest X-ray, bilaterally, because of lung damage, you will find diffuse infiltrates. Origin of edema, non-cardiogenic. PaO2 less than 60 mm Hg. See, no need to do PCWP in all cases. So when there is a diagnostic dilemma, then you can go for PCWP. See, already patient had some coronary artery disease. Now you are finding some pulmonary edema like picture. So in that, if you want, you can do PCWP. So in generally, by shortness of breath, diffuse infiltrates, and also by hypoxemia, you can diagnose. No need to do PCWP in all cases. So that's for your clarification. How do you differentiate exactly finally? So PaO2 less than 60 mmHg. So but recently, instead of individual PaO2, they are taking a ratio, especially in critical care medicine, PaO2 by FiO2 ratio. So what is meant by FiO2? FiO2 means fraction of inspired oxygen. So what is the normal percentage of oxygen that I am inhaling from the atmosphere? It is 21%. So for calculation purpose, I take it as 20%. 20% if I convert it into decimals, 0.2. So PaO2 by FiO2 ratio 60 by 0.2, it will be less than 300 mmHg. So in ARDS, now the criteria is not just PaO2 less than 60. It is a ratio PaO2 by FiO2. 60 by 0.2. Simple mathematics, the ratio will be less than 300 mmHg. So what is the significance of this ratio? By this ratio, we can differentiate ARDS into mild ARDS, moderate ARDS, and severe ARDS. So mild ARDS, the PaO2 by FiO2 ratio will be in the range of 200 to 300 mmHg. So moderate 100 to 200 mmHg. Severe less than 100 mmHg. So previously asked question. So which of the following qualifies for severe ARDS? PaO2 by FiO2 ratio. So PaO2 by FiO2 ratio less than 100 mmHg. So PaO2 by FiO2 ratio less than 100 mmHg qualifies for severe ARDS. So now I have diagnosed ARDS. Now coming to the treatment of ARDS. So first thing is I should start treating the underlying cause. So if it is due to pneumonia, I should give antibiotics, start treating underlying cause. But already ARDS is a complication resulting in respiratory failure. It requires mechanical ventilation. So they will ask you, in that mechanical ventilation, what is most recommended or what is most beneficial strategy? Most recommended or most beneficial strategy in ARDS is low tidal volume mechanical ventilation. So low tidal volume mechanical ventilation. Low tidal volume mechanical ventilation. So low tidal volume in the sense 4 to 6 ml per kg body weight. So why I should give a low tidal volume mechanical ventilation? To avoid ventilator associated lung injury. So write down all these points, I will discuss in detail. Third important strategy is adequate PEEP. So PEEP in the sense positive and expiratory pressure. Positive and expiratory pressure to improve oxygenation. And fourth, glucocorticoids may be beneficial. And like any other critically ill patient, fluid and electrolyte balance. So these are the 5 important aspects in treating ARDS. But if they ask you most recommended or beneficial strategy is low tidal volume mechanical ventilation. So it is a simple concept. Just listen once, you will not forget. Now in a normal individual, how much is the tidal volume if somebody asks you 500 ml? If you take the weight of a normal individual as 50 kg, per kg body weight, the tidal volume will be 10 ml. So this 10 ml per kg body weight is the routine tidal volume. But when they have seen in many studies, so when you were giving routine tidal volumes to ARDS lungs, so ARDS lungs were very sensitive. So they were behaving in a very sensitive manner. So if you give these routine tidal volumes, they were getting further damage. So it was observed in various studies. So from then onwards, they started to decrease the tidal volume. So once they started to decrease tidal volume, so ARDS lungs were responding better. See, there is a saying that ARDS lungs is equivalent to baby lungs. So it will be very fragile. So ARDS lungs, due to this damage, it will become very fragile. So if you give routine tidal volumes, so whatever an adult takes, if you give it to baby, what will happen? There will be damage. So ARDS are very fragile lungs. So when they were giving routine tidal volumes 10 ml per kg body weight, so there was further damage to the alveoli. So after so many trials, 10 to 15 years, they have concluded that in ARDS, the best thing is you should give low tidal volume mechanical ventilation instead of 10 ml per kg body weight, only 4 to 6 ml per kg body weight. This was to avoid ventilator associated lung injury. And next important concept here is you should give PEEP, adequate PEEP, positive and expiratory pressure, to improve oxygenation. So what is positive and expiratory pressure? So in ARDS, not only type 1 pneumocytes, type 2 pneumocytes are also damaged. So whenever type 2 pneumocytes are damaged, what is going to happen? Surfactant function will decrease. So whenever surfactant function decreases, there will be tendency of the alveoli to close. So because alveoli are having closing tendency at end expiration, I should apply positive pressure even at end expiration to keep the alveoli open and facilitate gaseous exchange. So adequate PEEP will, positive and expiratory pressure, alveoli have got tendency to collapse because type 2 cells have been destroyed. So if you apply adequate PEEP, this will keep alveoli open even at end expiration, facilitating better gaseous exchange. The next important thing is glucocorticoids may be beneficial. I am not telling glucocorticoids must be given here. It may be beneficial. The reason is, why is ARDS happening? Neutrophil mediated inflammatory damage. So if you give glucocorticoids, definitely that inflammatory damage will decrease. But glucocorticoids are a double-edged sword. So they decrease the inflammatory response, they decrease the immunity, and they can flare up infections. So already this is happening in sepsis and pneumonia. If you give glucocorticoids without adequate coverage of antibiotic, so patient can develop sepsis. So patient can have flare up of infection. So glucocorticoids may be beneficial when you are giving adequate antibiotic coverage. Unlike any other critically ill patient, you should take care of his fluid management. You should make sure his blood pressure is good, urine output is good, and his electrolytes are maintained. So this is the treatment protocol. Treat the underlying disease. Most recommended is low tidal volume mechanical ventilation, PEEP to improve oxygenation. Glucocorticoids can decrease the inflammatory damage, fluid and electrolyte balance. Apart from this, whenever there is severe ARDS, what to do next? So some 10 years ago, whenever there was a patient with ARDS in the ICU, so we used to see the patient, treat him adequately, and the last method was to pray God so that he will recover. But recently there are few additional methods helpful in severe ARDS which has brought some benefit. So what are they? So first one is ECMO. So first thing is ECMO. So these are additional strategies in ARDS. ECMO, extra corporeal membrane oxygenation. So what is happening here? So in this mechanism, there is a patient. From the patient's body, deoxygenated blood is pumped into a mission called as membrane oxygenator. So there is a specialized mission called as membrane oxygenator. So this membrane oxygenator will cause oxygenation of blood, and oxygenated blood is sent back into patient's body. So write down the mechanism of ECMO. Deoxygenated blood from patient's body pumped into a mission called as membrane oxygenator. So from the membrane oxygenator, oxygenated blood sent into patient's body. So this is a beneficial, especially in severe ARDS. So see the mechanism. So here, this is the patient. From his body, deoxygenated blood is pumped into a mission called as membrane oxygenator. And that membrane oxygenator is a device which can add oxygen into the blood. And oxygenated blood is coming back into patient's body. Because this method is happening outside the body, it is called as extracorporeal. So it is happening outside the body, it is called as extracorporeal. And the name of the mission is membrane oxygenator. So the procedure is called as membrane oxygenation. It is something similar to your dialysis. So in dialysis, unfiltered blood is taken into a mission and filtered blood is sent back into the body. So here it is not filtration of nitrogenous waste, it is addition of oxygen. So this is very much beneficial in severe ARDS. It is one of the last resort for ARDS. But the problem with ECMO is availability and affordability. It is not available in majority of hospitals. Even though if it is available, it is not that affordable. So to overcome these disadvantages, recently there is another method being done in majority of ICUs. Normally, I put a patient in supine position and ventilate. So what is this position? Prone. So what is this ventilation called as prone ventilation? See, COVID ultimately causes ARDS in the lungs. Whatever I told, you can also apply it to COVID related ARDS. So prone ventilation. So in prone ventilation, what is the benefit? So by proning the patient, there will be decreased diaphragmatic compression. There will be decreased diaphragmatic compression over basal alveoli. That will result in increased participation in gaseous exchange. That results in overall improvement in oxygenation. Somebody is asking what is the price for ECMO. So per day, only the mission rent is about 1.5 lakh. Along with that, doctor charge, nurse charge, ward boy charge, injection charge, drug charge or additional. And you don't know for how many days you have to put this patient on ECMO. So that's why it is a very costly affair and an advanced affair. Now see this prone ventilation. See, whenever a patient is in supine position like this, what will happen? The diaphragms. So the diaphragm can slightly come upward and compress the lung bases. Now if you put the patient in prone position, now weight of the diaphragm will be facing downward. So weight of the diaphragms, if I stay in prone position, weight of the diaphragm will be facing downwards. So because of that, the lung bases will start expanding. You know that highest ventilation will be in the lung bases. So once the lung bases starts expanding and taking part in gaseous exchange, what is going to happen? Already in ARDS, majority of lung is damaged. If some good alveoli from the lung bases starts to take part in gaseous exchange, there will be improvement in oxygenation and there will be improvement in survival. So this prone ventilation is also beneficial in ARDS. And to get this benefit, it is done continuously for 12 to 16 hours. So beneficial, especially in severe ARDS. So if you want to get benefit by this method, if you just do it for 1 or 2 hours, there will be no benefit. You have to do it continuously for 12 to 16 hours. And it is avoided in patients with predominant chest wall abnormalities, predominant anterior chest wall abnormalities, and also severe fibrosis. So to get benefit, it should be done continuously for 12 to 16 hours, and it is avoided in patients with predominant anterior chest wall abnormalities, because if the anterior chest wall is abnormal, I cannot place the patient in prone position. If this is deformed, he cannot lie properly in prone position. And why not in severe fibrosis? So whenever there is severe fibrosis, on the affected side, the lung volume decreases. So because of decrease in lung volume on one side, there will be asymmetry of chest wall. So he can have a drooping like this, asymmetry of chest wall. Again, once there is an asymmetrical chest wall, you cannot place the patient properly in prone position. Apart from that, prone ventilation is very, very important. I don't know why you are asking, does COVID causes ARDS? COVID causes severe pneumonia. Any severe pneumonia will cause ARDS. Any severe pneumonia will cause ARDS. And death in ARDS is respiratory failure. That too, in COVID also, death is respiratory failure due to ARDS. Okay. So in COVID, IMV or NIV is preferred depending on the patient condition. If he is if he is conscious coherent, you can go for NIV. If he is an altered sensorium, you should go for IMV. Yes. So these are the two important additional methods. So which are helpful in severe ARDS. One is ECMO, extracorporeal membrane oxygenation, and other is prone ventilation. So let us see the X-ray and let us discuss one question and take a break. So this is how a patient with ARDS comes to us. You can notice bilateral, top to bottom, side to side, diffuse infiltrates, bilateral, diffuse pulmonary infiltrates. So there can be bilateral diffuse consolidations. So bilateral diffuse pulmonary infiltrates, bilateral diffuse pulmonary infiltrates. Actually, we do ECMO in very critically ill patients. So the response is good. So don't think everybody will survive. So response good means 30 to 40% survival rate can happen. So please explain PaO2 by FiO2 point. So ARDS criteria, previously it was only PaO2 less than 60. Now they have made a ratio. So for a better number, so 200, 300 in that way, PaO2 with respect to atmospheric oxygen FiO2. So 60 by 0.2. So now the ratio, now the value becomes 300. So the ratio PaO2 by FiO2 less than 300. So NIV with helmet mask can be used. Prerana Bellari, NIV with helmet mask. So that will not generate aerosols. So repeat chest wall point. See, if your chest wall is not proper, if a patient wants to lie in prone position, chest wall should be proper. If anterior chest wall, there is some abnormality and asymmetry, patient cannot be placed in prone position. So bilateral diffuse pulmonary infiltrates. Try to solve this question. A 30-year-old presented with features of acute pancreatitis. Few days later, he developed dyspnea. His chest X-ray is shown. What is the respiratory failure? Yes. So what will be the answer here? So they are not vessels. All those are consolidation, secretions. So PEEP is a positive end expiratory pressure. So it will be applied so that alveoli will not collapse that easily. So what is the type of respiratory failure here? So whenever you find acute pancreatitis plus acute dyspnea and chest X-ray, if you notice, bilateral diffuse pulmonary infiltrates. So bilateral diffuse pulmonary infiltrates. So all this put together, this is ARDS. And acute pancreatitis is very important risk factor for developing ARDS. So what will be the type of respiratory failure? It is type 1. So if you find a patient with acute ARDS, it is generally type 1 respiratory failure. So to call it as type 4, you should have shock. To call it as type 3, there should be some perioperative history. To call it as type 2, there should be hypercapnia. Okay, so this is ARDS, and in ARDS it is type 1 respiratory failure. Answer is option A. Next question. A 25-year-old female has severe peripartum bleeding, received 20 packed RBCs and has to be intubated for respiratory failure. So whenever you find out respiratory failure after blood transfusion, somebody was asking why ARDS after blood transfusion? Because blood transfusion will cause a dangerous complication called as TRALI, transfusion associated lung injury. Transfusion associated lung injury. So the ventilator settings or assist control mode with the tidal volume 500 ml. So tidal volume 500 ml and frequency of breaths 15 per minute. So bedside 2D echo shows normal cardiac function. So it means it is not a cardiogenic cause. She weighs 60 kgs. Chest X-ray reveals diffuse pulmonary infiltrates. True regarding the case. So blood transfusion. So the important points here. There is respiratory failure and chest X-ray showing bilateral diffuse infiltrates. So it is transfusion related acute lung injury ultimately resulting in ARDS. So transfusion related acute lung injury. So now we don't use the term acute lung injury. It is just called as ARDS. So what will be the best answer here? So option A. Is pulmonary embolism the diagnosis? No. Pulmonary embolism is not the diagnosis. PCWP if measured will be more than 18 mmHg. No. Your cardiac function is normal. So this is non-cardiogenic pulmonary edema. So PCWP, if at all it is done, it will be less than 18. Decrease ventilator frequency to 10 breaths per minute. No need. So 15 breaths, 12 to 15 breaths is physiological. You are already maintaining physiological respiration and there is no issue in the patient with respect to respiratory rate. So no need to decrease. So decrease tidal volume to 360 ml is the correct answer. Why it is so? Patient is in ARDS. When somebody is in ARDS, we should give low tidal volume. Low tidal volume ventilation. So low tidal volume in the sense 4 to 6 ml per kg body weight. So 4 to 6 ml per kg body weight in the sense how much? So patient weighs 60 kg. So maximum permissible limit is 6 ml. 60 into 6. So this patient should get 360 ml. So I should decrease the tidal volume to 360 ml. Answer C. So this is a case of ARDS. In that preferred management is low tidal volume mechanical ventilation. So in this question, you should know the concept of low tidal volume mechanical ventilation. See, transfusion, whenever there is a transfusion, there will be some interaction between the blood cells. It will result in an inflammatory response. So it is called as transfusion related acute lung injury. So that transfusion related acute lung injury will result in ARDS. So assist control is a mode in mechanical ventilation. See, there is a separate section for mechanical ventilation in e-medicals. There are so many modes. So assist control means, so it will assist the breath if needed, and if patient is not at all taking the breath, it will completely control the breath. So that is called as assist control breath. It is a type of ventilator mode. So why not D? See, why will you decrease? See, will you take respiration 10 per minute? Yes, why not D? Will you take respiration 10 per minute? Your normal respiration is 12 to 15 per minute. Why should you decrease the respiratory rate and kill the patient there? No need to decrease. Your normal respiratory rate is 12 to 15 per minute. So I have set 15. So no problem. Why to decrease it to 10? Now whenever you are not interested from front, you look backward. This is nothing but prone ventilation. So regarding prone ventilation, this was a recent JIPMER question. See, not the picture, the question. So write down, regarding prone ventilation, all are true except. Tell me the correct answer. Yes. Prone ventilation. So meta-analysis of ARDS have suggested that outcomes with prone position are better in the subgroup of patients with more severe ARDS. Yes, it is beneficial in severe ARDS. Patients placed completely in prone position for 16 hours. This is true statement. So in several randomized control trials, mechanical ventilation in prone position improved arterial oxygenation. It is also true statement. So more likely to benefit. So in these patients, you should avoid in anterior chest wall abnormalities and fibrosis, you should avoid prone ventilation. The answer is option C. So we'll take break for 15 minutes. So any doubts up to now, you can ask me. So normal PEEP generally we set at 5 cm H2O. Normal PEEP 5 cm H2O. So FiO2 means fraction of inspired oxygen, what you take from atmosphere. So in ARDS, there is no elevation of PCWP. That's why it is called as low pressure. PCWP is less than 18. Because PCWP is less than cardiogenic pulmonary edema, it was called as low pressure pulmonary edema. ARDS generally type 1 respiratory failure. See, ARDS lungs are very fragile lungs or very damaged lungs. So if you give routine tidal volumes, majority of studies have shown that the lung was getting damaged further. So that's why low tidal volume. See, whenever anybody is having risk of aspiration, we put him in prone position. So prone position actually decreases risk of aspiration. Acute pancreatitis, if there is shock, there will be type 4 respiratory failure. Show difference between cardiogenic pulmonary edema, non-cardiogenic pulmonary edema. So this is this slide, cardiogenic and non-cardiogenic pulmonary edema. So pancreatitis, there is a complication called a systemic inflammatory response syndrome. So pancreatitis ultimately causes burns. It will also cause systemic inflammatory response syndrome. How patients breathe out in mechanical ventilator? There will be an inspiratory limb, expiratory limb. I don't know why they are asking why prone position is contraindicated in anterior. See, you have to be stable. So if your anterior chest wall is abnormal, how will you place the patient in prone position? So normal PaO2, it varies from 70 to 100 mmHg. So ARDS generally with type 1 respiratory failure. So whenever there is lung fibrosis on the affected side, your lung is lung volume has decreased. So because of decreasing lung volume, there will be asymmetry of chest wall. So CPAP is continuous positive airway pressure, BiPAP is bilevel positive airway pressure. Both can be used as methods of non-invasive ventilation. Hello everybody, good evening. Yes. Now what is this disease? There is migration of thrombus into pulmonary circulation. Yes. What is this? This is pulmonary thromboembolism. So migration of thrombus into pulmonary circulation. This is pulmonary thromboembolism. So write down the definition of pulmonary thromboembolism. Migration of thrombus into pulmonary circulation. So this is the basic definition of pulmonary thromboembolism. So generally there will be migration. Sometimes even within the pulmonary circulation directly a thrombus can be formed, but generally it is migration from other areas into pulmonary circulation. So what are the predisposing factors? So what are the predisposing factors? So it can be divided into genetic factors, acquired factors. So what are the genetic factors responsible for pulmonary thromboembolism? So we have protein CS deficiency, factor 5 lead-in mutation, protein CS deficiency, factor 5 lead-in mutation, hyperhomocystinemia, So the genetic causes, we have protein CS deficiency, factor 5 lead-in mutation, hyperhomocystinemia. So in all these conditions, there will be hypercoagulability. So the tendency to form thrombi in the vessels. So when these thrombi migrate to the pulmonary circulation, there will be pulmonary thromboembolism. Protein CS deficiency, factor 5 lead-in mutation, hyperhomocystinemia. All this ultimately will cause hypercoagulability. Now coming to acquired causes, it can be due to recent trauma or surgery, prolonged immobilization, pregnancy. So pregnancy is a hypercoagulable state. Malignancy, estrogen containing pills, presence of varicose veins, nephrotic syndrome. So how hyperhomocystinemia causes? Actually, hyperhomocystinemia ultimately can cause hypercoagulability. Now coming to acquired causes, recent trauma or surgery, prolonged immobilization. So whenever there is trauma, damage to vessels, platelets can aggregate, there will be thrombus formation. Immobilization, there will be stasis of blood in that area, there can be thrombus formation. Pregnancy is a hypercoagulable state. Malignancy, so many of the malignancies can have thrombotic complications. Estrogen containing pills. So why will estrogen containing pills be responsible for pulmonary thromboembolism? Estrogen containing pills, yes. So they cause a side effect called as deep vein thrombosis, and from these deep veins the thrombi can ultimately migrate into pulmonary circulation. And varicose veins are very important predisposing factor for pulmonary thromboembolism. So these varicose veins are the areas which can harbor thrombus formation. From them, if it migrate into pulmonary circulation, there will be pulmonary thromboembolism. So why will nephrotic syndrome cause pulmonary thromboembolism? So in nephrotic syndrome, like all other proteins, there will be antithrombin 3 lost in the urine. So there will be loss of antithrombin 3. So now within the body there will be reduced antithrombin 3. So whenever antithrombin 3 is reduced, again it will cause hypercoagulability. So whenever antithrombin 3 is reduced in the body, there will be hypercoagulability. So in nephrotic syndrome, like all other proteins, this antithrombin 3 is also lost in urine, and that can result in hypercoagulability. Now we know that this pulmonary artery is connection between heart and lung. So whenever there is some problem in pulmonary artery, there can be manifestations happening in the lung, there can be manifestations happening in the heart. So we are going to discuss the pathophysiology of pulmonary thromboembolism with help of a table. On one side, we discuss what happens in the lung, on other side what happens in the heart, what happens in the lung, what happens in the heart. See, estrogen containing pills will cause deep vein thrombosis. So that is the most important side effect of estrogen containing pills. So coming to the pathophysiology, what happens in the lung, what happens in the heart. So consider this is the lung. So let this be the bronchi, finally giving rise to multiple alveoli. And let this be the pulmonary artery. Let this be the pulmonary artery, so with various branches. Okay. Now the problem here is there is an embolus in the pulmonary artery. So there is an embolus in the pulmonary artery. So whenever there is an embolus in the pulmonary artery, consider this is freely flowing pulmonary artery. So now there is an obstruction. Just proximal to the obstruction, now what is going to happen? Just proximal to the obstruction, there will be increased pressure in the vessel. So there will be stasis of blood, increased pressure in the vessel. So once the pressure increases so much, there can be a rupture of the vessel resulting in hemoptysis. So just proximal to the embolus, there will be increased pressure in the vessel. Increase pressure within the vessel. So that can result in rupture of vessel. So whenever vessel ruptures, it can cause hemoptysis. And because there is an obstruction in the pulmonary artery, so in this area there will be no gaseous exchange. So there will be decreased transfer of oxygen into the blood. So that results in hypoxemia. So whenever there is hypoxemia, your body will fight by hyperventilating. So whenever less oxygen is there, your chemoreceptors will stimulate and there will be hyperventilation. So that hyperventilation will cause some breathing discomfort, and this breathing discomfort, it is called as shortness of breath. So there is decreased transfer of oxygen that results in hypoxemia, that results in shortness of breath. And next important cause is whenever a thrombus is formed, around the thrombus there will be accumulation of platelets. So around the thrombus there will be accumulation of platelets, and these platelets can produce a substance called as serotonin. And what is the function of serotonin? It can cause bronchoconstriction or bronchospasm. So because of bronchospasm, the radius of the airways decreases, resulting in increased airway resistance. So this was once asked, can increased airway resistance happen in pulmonary thromboembolism? So the reason is platelets aggregate near the thrombus, it results in serotonin production, bronchospasm, increased airway resistance. As time progresses, the amount of blood reaching the lung will decrease. So whenever the blood decreases, there will be lung ischemia. So because of ischemia, so whenever there is some ischemia, there will be damage to lung. So that will cause increased inflammatory damage. So lung ischemia can result in some lung damage. So lung ischemia can cause lung damage and inflammation. Lung ischemia can cause lung damage and inflammation. See, whenever the blood circulation is reduced to any organ, there will be lung ischemia. So when there is ischemia, still blood is not reaching, there will be some inflammation of that area. So inflammatory cells can reach there. So if this inflammation is reaching the pleural membrane, so lung ischemia can result in inflammation. If that inflammation reaches the pleural membrane, there will be pleuritis. So whenever pleural membrane is inflamed, what is the characteristic complaint? There will be chest pain. And because of pleuritis, there will be some fluid accumulation in the pleural cavity. So this is pleural effusion. Now the question is, what is the most common form of pleural effusion? Is it transudate or exudate? So any pleural effusion happening due to inflammation, it will be exudative in nature. So most common will be exudative pleural effusion. Exudative pleural effusion. So this is the thing happening. So you know there will be hemoptysis, shortness of breath, chest pain. So these are three classical symptoms. So why hemoptysis happens, why shortness of breath happens? Any ischemic injury will cause inflammation. So ischemic injury will cause inflammation. If that inflammation progresses to the pleural membrane, it causes pleuritis, chest pain, and pleural effusion. And pleural inflammation later can cause accumulation of fluid in the pleural cavity. That is pleural inflammation causing fluid. It is pleural effusion. And because it is probably due to inflammatory process, most commonly it will be exudative pleural effusion. So there will be no pulmonary edema here. Okay. Then coming to heart. So what happens in the heart? So consider this is the heart, right atrium, left atrium, right ventricle, left ventricle. So from the right heart we have a big vessel called as pulmonary artery. From the left ventricle we have aorta. Now here within the pulmonary artery, for example, there is a big thrombus here. So generally whenever there is a significant thrombus, then only you will see features happening in the heart. Now to fight against the thrombus, initially right ventricle will try to pump heart. So this right ventricle will now try to pump heart against this obstruction. So there will be increased right ventricular pressures and increased right ventricular dilatation. So your right ventricle now is trying to pump against the thrombus. So there will be excess pressure in the right ventricle. There will be right ventricular dilatation. So your right ventricle will not only dilate sidewards, it can also dilate medially. So whenever your right ventricle is dilating, now what happens to the interventricular septum? So this interventricular septum, which was in the center previously. So interventricular septum was here. It was in the center previously. Now because of right ventricular dilatation, so this right ventricle can also dilate medially like this. So because of that, the interventricular septum will be pushed more into left ventricle. So initially the interventricular septum was here. Now because the right ventricle is dilating, the intraventricular septum will be pushed more into the left ventricle. There will be increased movement. So there will be increased movement of interventricular septum, increased movement of interventricular septum into left ventricle. So once it moves into left ventricle, the left ventricular cavity size decreases. See, previously if you consider this was the left ventricular cavity. So if it was left ventricular cavity, this is interventricular septum. Now because of dilatation of right ventricle, the interventricular septum has moved more into the left ventricle. Now what is happening to the size of left ventricle? So previously the interventricular septum was like this. Because of excess right ventricular dilatation, now the interventricular septum has bulged into the left ventricle. So this results in decreased size of left ventricular cavity. That results in decreased left ventricular ejection fraction. Decreased left ventricular ejection fraction. So whenever left ventricular ejection fraction decreases, there will be decrease in cardiac output. So when there is decrease in cardiac output, there will be decreased blood pressure and ultimately patient can land in shock. Now as time progresses, your right ventricle cannot tolerate such high pressures for long. So it will give up, resulting in right ventricular dysfunction. So if they ask you what are the significant cardiac manifestation usually appreciated whenever there is a big thrombi. So first important is there will be right ventricular dysfunction. Patient can land in hypotension. patient can land in hypotension. Patient can land in hypotension. So if they ask you the manifestations with respect to lung, hemoptysis, shortness of breath, chest pain, pleural effusion. With respect to heart, right ventricular dysfunction, hypotension, shock. Now what is this entity of right ventricular dysfunction due to primary pulmonary cause, excluding causes of left heart, called as? What is this right ventricular dysfunction due to a primary respiratory cause, excluding the causes of left heart, also called as cor pulmonale? So generally, why will right ventricular dysfunction happen? Because of left heart disease. So the back pressure, left atrial pressure increases, increase pulmonary venous pressure, increase pulmonary capillary pressure, increase pulmonary arterial pressure, right ventricular pressure increases and dysfunction. But here there is no involvement of left heart, but still there is right ventricular dysfunction. So this phenomena is called as cor pulmonale. So write down what is meant by cor pulmonale. It is right ventricular dysfunction due to primary respiratory cause, excluding diseases of left heart. So this cor pulmonale is generally classified into two forms. So we have acute cor pulmonale, chronic cor pulmonale. Now if they ask you what is the most common cause of cor pulmonale, acute cor pulmonale, just now we have discussed pulmonary embolism. So which happens in short duration. Acute cor pulmonale, most common cause pulmonary embolism. So if they ask you most common cause of chronic cor pulmonale, it is COPD. Along with that, other lung diseases, interstitial lung diseases, bronchiectasis, obstructive sleep apnea, obstructive sleep apnea. Now, how will a lung disease ultimately result in right ventricular dysfunction? So any of these chronic lung diseases will cause long-standing hypoxemia. So hypoxemia in long run can cause some permanent changes. So there will be pulmonary vasoconstriction. Pulmonary vasoconstriction that results in pulmonary hypertension, that results in right ventricular dysfunction. So how will a chronic respiratory disease ultimately cause? How will a chronic respiratory disease ultimately cause cor pulmonale? It is long-standing hypoxemia, pulmonary vasoconstriction, pulmonary hypertension, right ventricular dysfunction. So most common cause of acute cor pulmonale is pulmonary embolism. Most common cause of chronic cor pulmonale and cor pulmonale overall is generally COPD. So if they ask you chronic, generally it is COPD. If they ask you acute, generally it is pulmonary embolism. So in our clinical practice, we see more patients with chronic cor pulmonale due to COPD. Now we have understood what are the predisposing factors, what are the clinical manifestations in pulmonary embolism. Now integrating the risk factors and clinical manifestations, there is a scoring system. By seeing that scoring system, you can predict the probability of pulmonary thromboembolism in a patient. So this scoring system is called as Wells scoring system. So Wells scoring system for PE means pulmonary embolism. Wells scoring system for pulmonary embolism. See, most common overall is COPD. Whom do you see more? Patients with pulmonary embolism or COPD? So bronchial artery is patent, then also see, ultimately if pulmonary circulation is not happening, blood will also not go into systemic circulation. If blood is not going into systemic circulation, bronchial artery will also have less blood. Okay. So Welch scoring system for pulmonary embolism. So these are the variables that we use. So if the patient is having signs and symptoms of DVT, if the patient is having signs and symptoms of DVT, we give score 3. See, anything that is responsible for pulmonary hypertension without heart disease can cause cor pulmonale. Primary pulmonary hypertension can also cause cor pulmonale. Alternative diagnosis less likely than pulmonary embolism, also 3 points. So alternative diagnosis less likely than pulmonary embolism means by seeing the patient, you are having high suspicion that this has to be pulmonary embolism. So you are having that inner gut feeling. So just like Arnab Goswami, when he speaks in Republic TV, whatever he feels, he says it is true. So that feeling that you have, that this is pulmonary embolism. So that is alternative diagnosis less likely than pulmonary embolism. So then also high clinical suspicion, that will also carry 3 points. Patient's heart rate more than 100 per minute. Patient's heart rate more than 100 per minute. So it carries 1.5 points. So immobilization or recent surgery within 4 weeks. It carries 1.5 marks. So prior pulmonary embolism or prior history of deep vein thrombosis, 1.5. And patient presented with hemoptysis, score is 1. And patient is having history of malignancy, score is 1. So they will ask you which are the clinical variables included in Welch scoring system. So these are the clinical variables. Now how to use this scoring system? So if at all they give you a question like this, there was a patient who recently underwent surgery. He presented he presented in the hospital with hemoptysis. He was having malignancy. So he underwent surgery for some malignancy, and he was having hemoptysis, and his heart rate was more than 100 per minute. So now what will be the total score? Now if you observe here, what will be the total score here? So for surgery 1.5, for increased heart rate 1.5, so for hemoptysis 1, for cancer 1. So if you add this, see the total score will be 5. So any score more than 4. So in the given clinical scenario, you should see what the patient is having from this table. You should add those variables. If the given score is more than 4, it means high likelihood of pulmonary embolism. So this is very, very important point. So score more than 4 indicates high likelihood of pulmonary embolism. Score more than 4 indicates high likelihood of pulmonary embolism. So Niranjan Kumar did not understand point number 2 even after giving Arnab Goswami example. It means you are confident, you are having high grade of suspicion without any investigation. You feel it is pulmonary thromboembolism. So you have not done investigation, just by seeing the patient you feel it is pulmonary embolism. So that is high grade clinical suspicion. Alternative diagnosis less likely than pulmonary embolism is high grade clinical suspicion. So your gut feeling that this is pulmonary embolism. So any score more than 4 means high likelihood of pulmonary embolism. Now let us see how to approach further. Now you will find a patient with a high score, and there is a patient with low score. So high score and low score. So this is from Harrison 20th edition. So I think 20th edition, better to follow Harrison only in pulmonary embolism. So high score, if at all patient is having high score, what will be the next step? So for next step, because high score means definitely patient is having chances of pulmonary embolism, I should not waste my time. I should go for investigation of choice called as CT pulmonary angiography. If patient is having low score, less chances of having pulmonary thromboembolism. I will not go to a costly investigation called as CT pulmonary angiography. I will go for a D-dimer. Depending on the D-dimer value, it can be either normal. If the D-dimer value is normal, you can exclude pulmonary embolism. How normal D-dimer excludes pulmonary embolism, I will teach you in the next slide. If D-dimer is high, more chances of having pulmonary embolism. So if there is high D-dimer, the next step here will be CT pulmonary angiography. So this is also an important algorithm. So if at all you have identified a patient with high score, so it means the probability of having pulmonary embolism is very, very high. You should not waste any time and you should go for the investigation of choice available, CT pulmonary angiography. Now, if at all there is a low score, the chances of pulmonary embolism is less. So what you do is, next you do a blood test called as D-dimer. So you are going to do a blood test called as D-dimer. So depending on the test result, so if it is normal D-dimer generally excludes the diagnosis of pulmonary embolism. Whereas if there is a high D-dimer, so next step you go for CT pulmonary angiography. It means in a patient with high score, don't waste time. Go for CT pulmonary angiography immediately. In a patient with low score, wait. Do D-dimer first. If it is only high, then go for CT pulmonary angiography. If D-dimer is high, only then go for CT pulmonary angiography in low score. In high score, don't waste any time with blood investigations. Directly go for CT pulmonary angiography. So high score means score more than 4. So it is written score more than 4 is generally considered as high score, more than 4. Now let us see what are all the investigations helpful in management of pulmonary embolism. So first we will see routine investigations, ECG. So within ECG they will ask you what is most common finding. So most common finding is sinus tachycardia. So most common finding is sinus tachycardia. Along with that, there will be T-wave inversions, right ventricular strain pattern, because right ventricle is finding it difficult to pump. T-wave inversions in leads V1, V2, V3, V4. But if they ask you most specific pattern, it is S1, Q3, T3 pattern. S1, Q3, T3 pattern. So why no pulmonary? See, pulmonary edema generally happens throughout the lung. So bilaterally it happens. Pulmonary embolism is a localized affection of the pulmonary artery, and usually that localized involvement of pulmonary artery will not cause pulmonary edema. Don't think that any lung disease will cause pulmonary edema. So it needs an overt inflammatory response. It needs bilateral diffuse damage. So most specific will be the classical S1, Q3, T3 pattern. So this S1, Q3, T3 pattern happens because there is change in right ventricular function and morphology. Next important investigation is a chest X-ray. See, S1, Q3, T3 pattern. See, is ECG not yet over for you? ECG. See, deep S wave in lead 1, deep Q wave in lead 3, and T inversion in lead 3. Okay. So chest X-ray. So chest X-ray, most commonly, most frequently, it will be normal. Chest X-ray most frequently will be normal. So most frequently it will be normal. But they will ask you special findings. So what are these special findings seen in pulmonary embolism? So very important chest X-ray findings. So consider this is the lung. So comfortably sitting on the diaphragm, and this is the main pulmonary artery, and these are the branches of pulmonary artery. So we have multiple branches throughout the lung. So multiple branches throughout the lung. Okay. So this is how pulmonary artery generally spreads. Now consider there is an embolus here. So consider there is an embolus here. So don't worry, this pattern I will show you on ECG again. Okay, this S1, Q3, T3, there are some images. I will show you that in ECG again. Don't worry. So special findings. Suppose there is an thrombus here. So okay, in this area. So whenever there is a thrombus in the vessel, distal to the thrombus, the blood supply will be cut off. So all this vasculature will disappear. So all this vasculature, because there is an obstruction in the vessel, so distal to that obstruction, the vasculature will disappear on a chest X-ray. So this area of focal oligemia. So oligemia means less blood. So there will be focal oligemia. So there will be focal oligemia. There will be focal oligemia. So this focal oligemia, it is called as Westermarck's sign. Westermarck's sign. Westermarck's sign. So then next important finding here is, because of less blood, there will be development of lung infarction. So there can be development of lung infarction, which causes a wedge-shaped opacity. So wedge-shaped opacity due to lung infarction. This is called as Hampton's hump. Hampton's hump. So try to understand these two signs. So whenever pulmonary artery, a branch is blocked, below that the sub branches will not be visible because blood supply is cut off. So this area of less vasculature, it is called as focal oligemia. As time progresses, because there is no proper blood supply, there will be a wedge-shaped opacity developing. So this wedge-shaped opacity near the diaphragm due to lung infarction, it is called as Hampton's hump. And second important sign, so whenever there is a thrombus, so just before the thrombus, there will be stasis of blood and there will be transient dilatation of blood vessel. So this transient dilatation of pulmonary artery was observed at the level of right descending pulmonary artery. So they have found out the dilatation of pulmonary artery just before the thrombus. It can happen at any point, but in majority of the studies, it was reported at the level of right descending pulmonary artery. So this is just an observational finding, no specific reason behind this. So this dilated right descending pulmonary artery, which was reported in many studies, this is called as Pallas sign. So this is called as Pallas sign. So three important signs: focal oligemia, Westermarck's sign, wedge-shaped opacity near diaphragm, Hampton's hump. So reported sign in majority of studies, dilated right descending pulmonary artery. This is called as Pallas sign. This is called as Pallas sign. Then in majority of the patients, you should do a lower limb venous ultrasonography. A lower limb venous ultrasonography. So why should I do a lower limb venous ultrasonography? To rule out deep vein thrombosis. So I should do a lower limb venous ultrasonography to see whether there are any thrombus in the deep veins. And if I do echocardiography of heart, So echocardiography can cause can show right ventricular hypokinesia. So this right ventricular hypokinesia, in setting of a thrombus in the pulmonary circulation, it is called as McConnell's sign. So we have understood previously. So in pulmonary thromboembolism, ultimately there will be right ventricular dysfunction. So your right ventricle will stop functioning. So because of that, there will be right ventricular hypokinesia. So this right ventricular hypokinesia, in setting of a thrombus in the pulmonary circulation, this is called as McConnell's sign. Now coming to some special investigations. First special investigation is D-dimer. So D-dimer is a fibrin degradation product. So D-dimer is a fibrin degradation product. So this is definitely elevated in pulmonary embolism. So this investigation is sensitive but not specific. So this investigation is sensitive but not specific. So why it is not specific? Because it is also elevated in other conditions such as sepsis, deep vein thrombus, cancer, etc. So this has good negative predictive value, but poor positive predictive value. Because of this is used only as screening test, not investigation of choice. So coming to D-dimer, this is a very important investigation, not just here but also in COVID. So let us see what is this D-dimer. So whenever there is a thrombus in your body, your body's defense mechanism will try to break that thrombus. So it will try to break initially. So if it cannot break, there will be manifestation as a disease. So whenever these thrombi are broken down, there will be some fragments released. One such fragment is called as D-dimer. So D-dimer is a fibrin degradation product. So it is definitely elevated in pulmonary embolism. Because there is a thrombus, your body will try to break down that thrombus, so it will be elevated. So it is sensitive but not specific. So why it is not specific? Because D-dimer is also elevated in other conditions such as sepsis, DVT, cancer. So it means that if D-dimer is elevated, it means there is an active thrombus in the body that is getting broken down. But it will not specifically say that thrombus is only present in pulmonary artery. So even if the thrombus is in your upper limb, thrombus is in your lower limb, thrombus is in your abdomen, D-dimers will be elevated. So if D-dimer is elevated, it means there is presence of thrombus in your body, but it cannot specifically localize the thrombus to pulmonary circulation. So it is having poor positive predictive value, but good negative predictive value. What does this mean? If D-dimer value is normal, what does it mean? There is no thrombus being broken down. So if there is no thrombus being broken down, it means probability of thrombus being in pulmonary artery is also less. So if D-dimer is normal, it can exclude pulmonary thromboembolism. So this test can be used to exclude. It can be used to exclude. It can be used to exclude pulmonary embolism. So it can be used to exclude pulmonary embolism. But it has poor positive predictive value. If D-dimer is high in the body, it cannot tell this high D-dimer is only due to pulmonary embolism. So there might be multiple causes. So it cannot confirm diagnosis of pulmonary embolism. So positive predictive value means something should confirm the diagnosis. So D-dimer, keep this in mind. D-dimer cannot confirm pulmonary thromboembolism. So it has poor positive predictive value. It cannot say pulmonary thromboembolism is present. It cannot say pulmonary thromboembolism is positive. So that's why it is poor positive predictive value. But it can say pulmonary thromboembolism is negative. It can say, it can exclude pulmonary thromboembolism. So it has good negative predictive value. So very, very important. So that's why it is used only as screening test, not as investigation of choice. So frequently asked question. So what is the role of D-dimer? Good negative predictive value. Test for exclusion, not test for confirmation. Now what will be the test for confirmation? So write down investigation of choice. So investigation of choice is CT pulmonary angiography. It is CT pulmonary angiography. Then if they ask you what is gold standard, your answer should be invasive pulmonary arteriography. Invasive pulmonary arteriography. Now what is the role of old test called as ventilation perfusion scan? So as of now it is having limited use. So useful where you cannot do CT scan, where you cannot give contrast. Renal dysfunction, contrast hypersensitivity. Now, what is meant by investigation of choice? So investigation of choice means that investigation should be easily available, easily done, less complications, good sensitivity and specificity, good sensitivity and specificity. So what exactly we are doing in CT pulmonary angiography? So we are injecting a contrast material. So this contrast material will go into the pulmonary artery. So what is the function of a contrast material? So contrast material will make all the blood vessels very, very white. So contrast material will give more density to the blood vessels. So the blood vessels all will appear very, very white. In that area of white, if you see anything less white, what does it indicate? There is some obstruction in that blood vessel. Because this investigation is directly localizing the disease in the pulmonary circulation, and it is a easy method, easily available, very quick results. It is considered as investigation of choice. Investigation of choice. Now whereas gold standard. So gold standard means it can be difficult to do. It can be difficult to do. It might be associated with complications. But if you do this test, you are 100% sure of the diagnosis. Here, not just contrast, you are putting directly a catheter into the pulmonary artery. Now you know you are in pulmonary artery, but it is not moving beyond a point. It means there is some obstruction. So this is an invasive method associated with complications, not routinely done. So for all practical purposes, if they ask you what is investigation of choice, your answer should be CT pulmonary angiography. So before the advent of CT pulmonary angiography, there was an old method called as ventilation perfusion scan. So this is nowadays replaced by CT pulmonary angiography because you can clearly see the thrombus in a CT scan when compared to ventilation perfusion scan. So it is having only limited use where you cannot do CT scan. So in pregnancy, I don't want the mother to get exposed to high radiation. So that's why I avoid CT pulmonary angiography. I go for ventilation perfusion scan. And renal dysfunction. So whenever you give contrast to a patient, it will cause some renal issues. So already if there is a renal disease, I should not give contrast. And if there are some contrast hypersensitivity, so contrast intolerance. So contrast intolerance. So these are the three important things that you should know. When will ventilation perfusions can be helpful? In pregnancy, renal dysfunction, and contrast intolerance. For all practical purposes, if they ask you what is investigation of choice, your answer should be CT pulmonary angiography. Investigation of choice is CT pulmonary angiography. Now write down the management of pulmonary embolism. Very, very important table. So based on the clinical features, pulmonary embolism is divided into massive pulmonary embolism, submassive pulmonary embolism, minimal pulmonary embolism. See, they are asking CT pulmonary angiography, do we use a catheter to infuse? See, it is injected to an IV cannula. Okay, IV cannula will be placed in the hand. So you inject a contrast material, it will travel through the blood vessels, go into the pulmonary circulation, and whenever there is a thrombus, you can identify it. So it is not through a catheter placed in the pulmonary artery, through a peripheral line you can give. Contrast intolerance. So massive pulmonary embolism. So when do you call it as a massive pulmonary embolism? Whenever a big thrombus is occluding the right ventricle. So patient has developed shock. Along with that, right ventricular dysfunction. So patient is in shock, right ventricular dysfunction. Here still BP might be maintained and there will be some amount of right ventricular dysfunction. So in minimal pulmonary embolism, very, very small embolus, normal BP and normal right ventricular function. So this is how we classify. Shock with RV dysfunction is massive pulmonary embolism. Normal BP but RV dysfunction submassive. Normal BP, normal RV function minimal. So whenever a patient is in shock, this is a medical emergency. So what I do here, I try to stabilize the patient. So to stabilize the patient, I give him IV fluids. So generally 500 ml of NS. So IV 500 ml of NS. Along with that, I can add vasopressor to improve his BP. And I should start anticoagulation. So what is the benefit of anticoagulation in pulmonary embolism? So anticoagulation will prevent the extension of thrombus and it will also prevent the reformation of the thrombus. So if you give anticoagulation, it will prevent the extension of the thrombus and it will also prevent the chances of rethrombosis. Anticoagulation can prevent extension of that thrombus and it can prevent the chances of rethrombosis. But if they ask you, what is the definitive management to save the life of this patient? There is a big thrombus in the pulmonary circulation, occluding the right ventricle, resulting in shock. So what should I do to save this patient now? I should break the thrombus. So just like this, I should break the thrombus. So how will I break the thrombus? By thrombolysis. So I should break the thrombus. If it is not possible in rare scenarios, we can go for surgical embolectomy. So definitive treatment is medical management, thrombolysis, surgical management, surgical embolectomy. You have to cut open the thorax and that is a complicated procedure. So definitive management, reperfusion, thrombolysis, break the thrombus. Now in submassive pulmonary embolism, BP is normal, so I no need to worry much. So here also I start anticoagulation. So but there is some amount of RV dysfunction, so I closely monitor the patient. So I admit him and closely monitor the patient. If at any point of time, if patient worsens or if patient develops hemodynamic compromise, if patient develops hemodynamic compromise, immediately I should go for thrombolysis. Immediately I should go for thrombolysis. Now in a minimal pulmonary embolism, a small thrombus, just anticoagulation will be sufficient. So this is the very important algorithm for management of pulmonary embolism. So what should be done in massive pulmonary embolism? You should stabilize the patient, and definitely what should be given to save the life of the patient? Thrombolysis. Frequently you will be confused between management of massive and submassive. See, in massive pulmonary embolism, definitely in majority what should be done? Thrombolysis. Whereas in submassive pulmonary embolism, start anticoagulation. Only if patient is not improving with anticoagulation, then only go for thrombolysis. So in massive pulmonary embolism, thrombolysis should be definitely done in majority of patients. In submassive pulmonary embolism, it is done selectively in patients not improving with anticoagulation. Selectively in patients not improving with anticoagulation. See, vasopressors means dopamine is also a vasopressor. Okay. So noradrenaline is also a vasopressor. Don't think vasopressor means only vasopressin. Okay, we give dopamine here. Okay, vasopressors, it is different. Now coming to the drugs. So what are the drugs helpful for thrombolysis? So it is not streptokinase actually. For pulmonary thromboembolism, preferred is altiplase. So very important. So for thrombolysis, so we prefer altiplase. Thrombolysis, we prefer altiplase. Then anticoagulation, what are the drugs? Traditionally, we give heparin bridged to warfarin. Heparin bridged to warfarin. And newer drugs, we have heparin followed by dabigatran. So what is dabigatran? It is a direct thrombin inhibitor. It is a direct thrombin inhibitor. So other drugs helpful, other new drugs for anticoagulation, we have rivaroxaban, apixaban. These are factor 10A inhibitors. Factor 10A inhibitors. So heparin bridged to warfarin, heparin followed by dabigatran, direct thrombin inhibitors. Rivaroxaban, apixaban, as the name indicates, factor 10A. So these are all factor 10A inhibitors. So if they ask you, what is the drug that you give for thrombolysis? Altiplase. Anticoagulation, in majority, cheap regimen is heparin bridged to warfarin. See, one warfarin tablet will roughly cost about 1 or 2 rupees. But dabigatran, apixaban, rivaroxaban, each tablet will cost about 20 to 30 rupees. And this patient has to use for 3 to 6 months. So cheap regimen is generally heparin bridged to warfarin, but bleeding complications are high with warfarin. So newer anticoagulants, we have dabigatran, direct thrombin inhibitor, rivaroxaban, apixaban. Now, what is the biggest disadvantage of thrombolysis? So, how will you do thrombolysis? We give altiplase through IV infusion. So, whenever you give IV infusion, so it will not only reach the pulmonary artery, it will reach the systemic circulation also. If at all there is some bleeding tendency in the patient, if he is already having some ulcer in his gastric mucosa, it can bleed. If there is some aneurysm in his brain, it can bleed. So thrombolysis have bleeding complications. So thrombolysis have bleeding complications. Thrombolysis have bleeding complications. To overcome these bleeding complications, there is a new therapy called as catheter-directed therapy. Catheter-directed therapy. So there is a specialized catheter. So this catheter will be sent into the pulmonary circulation. So we localize the thrombus. So wherever there is thrombus, directly you inject the thrombolytic. So it is nothing but targeted thrombolysis, intra-clot infusion of thrombolytics. So because you are directly infusing in the thrombus, so there will be an advantage of decreasing dose of drug. See, if you give to a peripheral vein, the dose of the drug must be high. And because you are directly giving at the targeted site, there will be decreased bleeding complications. Decreased bleeding complications. So very, very important. The recent method is catheter directed therapy. So the recent advanced method for treatment of pulmonary embolism, catheter directed therapy. So this is intra-clot infusion of thrombolytics. The advantage is you can decrease the dose of the drug. So if you decrease the dose of the drug, the side effects of the drug will also decrease. What are the side effects of thrombolytics? So it is bleeding complication. Bleeding complication. So bleeding complication. So this is regarding the management of pulmonary embolism. Once again, you can see this is the algorithm we have discussed. Massive, submassive, minimal. This is the drugs. So thrombolysis, what will you give? Anticoagulation. Traditional is heparin bridged to warfarin, or we can give heparin followed by dabigatran, rivaroxaban, apixaban. So then the advanced method, catheter directed therapy. So here directly infusing the thrombolytic into the clot with the help of specialized catheter. So here the advantage is you can decrease the dose of the drug and it will decrease the bleeding complications. Now this is the classical ECG finding. S1 Q3 T3, S1 Q3 T3. So you can see deep S waves in lead 1, Q waves in lead 3, Q waves in lead 3 and inverted T waves in lead 3. So S waves in lead 1, Q waves in lead 3, inverted T waves in lead 3. Is it most common pattern or most specific pattern? Whenever you see S1, Q3, T3, it is the most specific pattern. Most specific pattern. So this pattern happens because of abnormal morphology and physiology of right ventricle. When compared to normal individual, here right ventricle is dilated and right ventricle is pumping more. Because of that abnormal physiology and morphology, you can see S1, Q3, T3 pattern. Now try to solve this question. A 75-year-old male with history of colon cancer admitted in ICU for 5 days developed the sudden onset of dyspnea with chest pain and hemoptysis. His BP is 100/70, heart rate has increased, respiratory rate has increased, there is hypoxemia. So no tenderness in the lower limbs. ABG analysis was showing type 1 respiratory failure. Chest X-ray appears normal. Which of the following diagnostic test is done in order to confirm your diagnosis? So what will you do here to confirm your diagnosis? What will you do here to confirm your diagnosis? So can you tell me what is this patient having? He is having high chances of pulmonary embolism. So whenever they ask you Which test is helpful to confirm the diagnosis? Investigation of choice. Your answer is multi-detector CT pulmonary angiography. So this was one of our patient, a live case. So when this patient presented to me, I also suspected it as pulmonary thromboembolism, and we have done a CT pulmonary angiography. I'll show you the CT film. So what is this structure? So this structure is pulmonary artery. So pulmonary artery. So why is this pulmonary artery appearing very white? So why is this pulmonary artery appearing very white? Because I have injected contrast. So the function of contrast is to make vessels visible very white. Now in this white, can you see area of less white here in the vessel? In this white, can you see area of less white here? So what is this? This is embolus or thrombus in the pulmonary circulation. Thrombus in the pulmonary circulation. So this is the advantage of CT pulmonary angiography. So it will directly localize the thrombus within the pulmonary circulation. It is easily done, easily available, very quick results, good sensitivity and specificity. Good sensitivity and specificity. So case number 11, answer is C. Case number 11, answer is C. So this is a patient with suspected pulmonary thromboembolism. So investigation of choice is CT pulmonary angiography. CT pulmonary angiography. So direct question. So frequently asked in majority of central exams. Now coming to pulmonary hypertension. So pulmonary hypertension, the definition. So it is defined as mean pulmonary arterial pressure. So mean pulmonary arterial pressure, also called as MPAP, more than 20 mmHg. So more than 20 mmHg. So more than 20 mmHg. See, pulmonary embolism will cause hemoptysis. Kindly see the pathophysiology slide under lung changes. First point is why there is hemoptysis. So mean pulmonary arterial pressure more than 20 mmHg. It is pulmonary hypertension. So they will ask you, what is the initial method of assessment of pulmonary hypertension? All these were frequently asked questions. Echocardiography. So in echocardiography also you can indirectly measure the pressures of the pulmonary artery. But if they ask you what is the most accurate method, so most accurate method for measuring pressure in any blood vessel is directly inserting a catheter. So pulmonary artery catheterization is the most accurate method. Pulmonary artery catheterization is the most accurate method. Then most common symptom. So most common symptom, whenever pulmonary artery is affected, there will be some issue in gaseous exchange. Patient will develop hypoxemia. Because of hypoxemia, he will manifest with shortness of breath. Because of hypoxemia, he will manifest with shortness of breath. Because of hypoxemia, he will manifest with shortness of breath. So echocardiography is initial method of assessment. Pulmonary artery catheterization is the most accurate method. And if they ask you most common symptom in pulmonary hypertension, because of some deranged gaseous exchange, pulmonary artery takes part in gaseous exchange. So when it is diseased, there will be some defective gaseous exchange resulting in hypoxemia, shortness of breath. Next important concept here is WHO. Classification of pulmonary hypertension. So we can divide it into 5 groups. So group 1 includes the diseases responsible for direct involvement of pulmonary artery. Direct involvement of pulmonary artery. It can be due to genetic causes. So most important genetic cause is mutation in a gene called as BMPR2 gene. So because of this mutation, there will be increased smooth muscle proliferation, within vessel. So because of increased smooth muscle proliferation within the vessel can be narrowed. So that results in increased pulmonary arterial pressure, so pulmonary hypertension. And this type of pulmonary hypertension was frequently seen in young females. So this genetic cause of pulmonary hypertension was frequently seen in young females. Next important is connective tissue disorders. So connective tissue disorders. So I write it as CTD. So if they ask you most common CTD responsible for pulmonary hypertension, your answer should be scleroderma. Other important CTD, rheumatoid arthritis, SLE. So these connective tissue disorders, as a part of systemic involvement, can involve the pulmonary artery directly and result in pulmonary artery hypertension. So these connective tissue disorders, as a part of systemic involvement, can involve the pulmonary artery directly and result in pulmonary hypertension. So if they ask you what is the most common CTD, your answer should be scleroderma. Other diseases responsible are rheumatoid arthritis, SLE. And third is, it can be due to drugs or toxins. So pulmonary hypertension can also happen due to drugs or toxins. So what is the drug responsible? Fenfluramine. And toxins such as toxic rapeseed oil. So these rapeseed oil, so when consumed, it was directly involving the pulmonary circulation, the toxins, resulting in pulmonary hypertension. So this drug called as fenfluramine was also directly involving the pulmonary circulation, resulting in pulmonary hypertension. So this is group 1. Now coming to group 2. So group 2. So group 2 pulmonary hypertension is due to left heart disease. Now can a disease of left heart be responsible for pulmonary hypertension? Yes or no? Can a disease of left heart be responsible for pulmonary hypertension? Yes. What is the mechanism? So the mechanism is called as increased back pressure. So what happens here? There is, because of a left heart disease, increased left atrial pressure. Already we have discussed this in cardiogenic pulmonary edema. Increased pulmonary venous pressure. That results in increased pulmonary capillary pressure. Increased pulmonary capillary pressure. That results in increased pulmonary arterial pressure. So this is the mechanism by which a heart disease can be responsible for left heart disease, be responsible for pulmonary arterial pressure. So this mechanism is called as increased back pressure. So there are few special features of group 2. So this group 2 is the most common group overall. It is the most common group overall. So in WHO classification, actually there are 5 groups. Out of these 5 groups, most common group overall is group 2. Most common group overall is group 2. And pulmonary hypertension due to left heart disease is group 2. And here not only the mean pulmonary arterial pressure is elevated. What else is elevated? Pulmonary capillary wedge pressure is also elevated. So why is PCWP elevated? Because it is due to a left atrial disease or left heart disease. There will be increased left atrial pressure. So mean pulmonary arterial pressure means it is average of systolic and diastolic pulmonary arterial pressures. Okay. So in group 2 pulmonary hypertension, not only the MPAP is elevated, PCWP will also be elevated. So why PCWP is elevated? Because there is involvement of left heart, there is increased left atrial pressure. Okay. So is it clear? Group 2 is due to left. What was CTD? I wrote it twice. C for connective, T for tissue, D for disorder. CTD means connective tissue disorder. So increased back pressure responsible for pulmonary arterial pressure increase. It is group 2. It is group 2. Okay. So this is group 1, group 2. Now coming to group 3. So group 3. So this is due to pulmonary hypertension due to primary respiratory disease. So respiratory diseases such as COPD, interstitial lung disease, bronchiectasis, obstructive sleep apnea. So how will a primary respiratory disease be responsible? So any long-standing respiratory disease causes hypoxemia. So this will cause pulmonary vasoconstriction. So because of pulmonary vasoconstriction, there will be pulmonary hypertension. See, explained PCWP, Ananya, when we have discussed cardiogenic pulmonary edema, we have discussed there next there will be increased pulmonary arterial pressure in this sequence. So left atrial pressure is elevated. PCWP is nothing but indirect measure of left atrial pressure. So here, because it is due to left heart disease, not just MPAP is elevated, here PCWP will also be elevated. PCWP will also be elevated. Okay, because this is due to left heart disease, not just MPAP, PCWP will also be elevated. So this is just an extra point for you to understand. So group 3, this is due to primary respiratory disease, hypoxemia, induced pulmonary vasoconstriction, pulmonary hypertension. Then coming to group 4, this is due to chronic thromboembolic events. This is due to chronic thromboembolic events in pulmonary circulation. Chronic thromboembolic events in pulmonary circulation. So because of small thrombi in the pulmonary circulation, the pressure might increase. Now group 5. So this is called as miscellaneous group or group with unclear mechanism. So we don't know why exactly there is pulmonary hypertension in these diseases. Unclear mechanism. So the diseases included are sickle cell disease, very rare diseases, sarcoidosis. Another rare disease, pulmonary Langerhans histiocytosis. Pulmonary Langerhans histiocytosis. So accumulation of histiocytes in the lung, pulmonary Langerhans histiocytosis. All these are very rare diseases. So we don't know the precise mechanisms of pulmonary hypertension in these diseases. So we have 5 groups. Group 1, direct involvement of pulmonary artery. Group 2, cardiac disease. Group 3, primary respiratory disease. Group 4, chronic thromboembolic events. Group 5, miscellaneous or unclear mechanism. Miscellaneous or unclear mechanism. Now this is the first classification of pulmonary hypertension, and this was given by WHO. This is WHO classification. There is a next classification, hemodynamic classification. So this is based on whether the pulmonary hypertension is having a cardiac origin, yes or no. So based on the hemodynamics of the pulmonary hypertension, it can be classified into two forms: cardiac origin, non-cardiac origin. Cardiac origin, non-cardiac origin. So cardiac origin, which group comes under cardiac origin? Only group 2. Non-cardiac origin, group 1, group 3, group 4, group 5. Group 1, group 3, group 4, group 5. Okay. So write down hemodynamic classification for cardiac origin. So the pulmonary hypertension based on the cardiac involvement, it is divided into two forms. So those not having cardiac involvement, non-cardiac origin. So cardiac origin. So non-cardiac origin, so generally group 2. Cardiac origin, group 1, group 3, group 4, group 5. So these are considered as non-cardiac causes of pulmonary hypertension, whereas group 2 is considered as cardiac cause of pulmonary hypertension. Now what are the features? So in both of this, mean pulmonary arterial pressure will be more than 20 mmHg. So here also mean pulmonary arterial pressure, because there is pulmonary hypertension, more than 20 mmHg. But in cardiac origin, what happens is PCWP will be higher. Here the reference value is taken as 15 mmHg. Whereas in non-cardiac, because there is no involvement of left heart, PCWP will be less than 15 mmHg. So this in ARDS, the reference value was taken as 18. So this classification was given by different group of people. So they have taken reference value of 15. So generally, few different group of scientists take different reference values. See, normal value is 8 to 12. So in ARDS, they have taken a higher value of 18. Here they have taken reference value as 15. So here PCWP less than 15 mmHg in non-cardiac cause, PCWP more than 15 mmHg in cardiac cause. Now coming to the anatomical level, so let this be the alveolus. So to the alveolus, what will bring blood generally? Your pulmonary artery. So this is pulmonary artery brings blood to the alveoli, and this pulmonary artery gives multiple branches at the level of alveoli. These are called as pulmonary capillaries. So once the gas exchange is done, these pulmonary capillaries will merge into a structure called as pulmonary vein, and this pulmonary vein will open into the left atrium. Now any event happening before the pulmonary capillaries, it is called as a pre-capillary phenomena. An event happening after the pulmonary capillaries, it is called as post-capillary phenomena. So very simple, any event happening before the pulmonary capillaries, it is called as pre-capillary. Anything happening after the pulmonary capillaries, it is called as post-capillary. Now most important thing here is, so those belonging to cardiac origin, group 2, the majority of pathophysiology is happening in the post-capillary part, because in cardiac etiology, there will be problem in the left heart that will reflect pressure into pulmonary vein. So then pulmonary capillaries, then pulmonary artery. Because majority of pathology is happening in the post-capillary portion, This cardiac origin is also called as post-capillary pulmonary hypertension. So this is the new name. So new name for cardiac origin is post-capillary pulmonary hypertension. Whereas in non-cardiac origin, group 1, group 3, group 4, group 5. So this post-capillary part is not at all involved. So everything happens before the pulmonary capillaries. So this was just called as pre-capillary pulmonary hypertension, because post-capillary portion is not getting involved. It is just called as pre-capillary hypertension. So non-cardiac origin, it is given a special name recently, pre-capillary hypertension. Pre-capillary hypertension. So pre-capillary hypertension. So this is what you should know. So cardiac origin, all these are synonyms. They can be asked as one-liners. So cardiac origin. So cardiac origin, group 2, post-capillary hypertension nearly means the same. So they mean the same. Whereas non-cardiac origin, group 1, group 3, group 4, group 5, these are clubbed together as pre-capillary hypertension. So why PCWP does not increase? See, PCWP will increase only when there is a left heart disease. So left heart disease will cause back pressure resulting in PCWP. So here left heart disease is not there in 1, 3, 4, 5. 1, 3, 4, 5. So whenever there is left heart disease, PCWP will increase. That was discussed in ARDS, that was discussed in cardiogenic pulmonary edema. So mean pulmonary arterial pressure. So mean pulmonary arterial pressure means you are seeing within the pulmonary artery. So PCWP means you are seeing the pressure of left atrium. So if there is a cardiac disease, then PCWP will be elevated. Left heart disease. There is no left heart disease, so PCWP will not be elevated. So out of this, group 2 is more common. Yes. Now coming to the treatment. Treatment of pulmonary hypertension. So first will be treat underlying cause. So if at all pulmonary hypertension is due to a left heart disease, so treat that left heart disease adequately. That will control the pulmonary arterial pressures. If it is due to COPD, if it is due to bronchiectasis, treat that lung disease adequately. It will control the pulmonary arterial pressures. So if at all there is a cause responsible for pulmonary hypertension, first treat that underlying cause. So if not improving, if the patient is not improving even after treating the underlying cause, now you should give direct drug therapy which act on the pulmonary circulation. So what are the drug therapies that act on the pulmonary circulation? First is calcium channel blockers. So we have nifedipine. So previously it was used, now because of side effects, now not used frequently. So because of side effects, now not used frequently. Next is, what are the drugs frequently used in treatment of pulmonary hypertension? So first is endothelin receptor antagonist. Endothelin receptor antagonist. So we have bosentan, ambrisentan. Then next important drug is PDE5 inhibitors. PDE5 inhibitors. Sildenafil, tadalafil. Then we have prostacyclin analogs. Prostacyclins. Iloprost. So Iloprost is available as inhaled form. Next is ipoprostenol. Ipoprostenol is available as IV form. Then we have a new drug called as prostacyclin agonist. So this prostacyclin agonist is a potential question, selexibak. And other new drug is guanyl cyclase stimulator. Each and every drug is a potential question because these are new drugs. Prostacyclin agonist, selexibak, guanyl cyclase stimulator, riociguat. Guanyl cyclase stimulator, riociguat. Now let us see, if there is a pulmonary hypertension patient reaching my clinic who is requiring direct drug therapy, how will I design the regimen? So drug regimen. So initially I give combination of endothelin receptor antagonist plus PDE5 inhibitor. So this endothelin receptor antagonist, so these drugs are written as ETRAs. So I generally start with bosentan, ETRA bosentan. Along with that PDE5 inhibitor. So PDE5 inhibitor sildenafil. So this is generally a cheap combination and very affordable to the patient. Cheap combination and very affordable to the patient. So drug regimen, initially we give combination of endothelin receptor antagonist such as bosentan. So I will underline it so that you can understand better. Endothelin receptor antagonist bosentan. PDE5 inhibitor sildenafil. So even after giving this, if patient not improving, so if patient not improving, so we can add a prostacyclin. So we can add prostacyclin. If patient is not improving, we can add a prostacyclin. So this is the general drug regimen for pulmonary hypertension. First we try with the classical drugs, that is bosentan, sildenafil. If patient is not improving with these drugs, we add prostacyclins. Now if they ask you drug of choice for emergency situation, so if there is an emergency due to pulmonary hypertension, right ventricular dysfunction, of all this, so drug of choice for emergency situation. So whenever there is an emergency situation, which will work better, tablets or injections? See, majority of these drugs are available in tablet forms. Only one drug is available in injectable form, that is nothing but ipoprostenol. So drug of choice is IV ipoprostenol. So drug of choice for emergency situations is IV ipoprostenol. So these are the important concepts that you should remember in pulmonary hypertension. So whenever there is an underlying disease, treat that underlying disease first. So if not improving, you can go for drug therapy. So in that drug therapy, classically we use endothelin receptor antagonist with PDE5 inhibitors. If not improving, we add prostacyclins. So if they mention drug of choice for emergency situations, we give IV ipoprostenol. Now coming to the next disease. Here patient is inhaling a microorganism and he develops fever, cough and some respiratory symptoms. So what is this disease? Yes, what is this disease? Yes, what is this disease? This is pneumonia. So write down, pneumonia is acute respiratory illness. acute respiratory illness. So when do you call it as acute respiratory illness? So whenever patient is having combination of any of this: fever, shortness of breath, cough, chest pain. So acute respiratory illness with radiological pulmonary shadowing. Acute respiratory illness with radiological pulmonary shadowing. So this patient will have some respiratory symptoms, and if you take a chest x-ray, there will be some infiltrates. This combination is called as pneumonia. Now let us see the classification of pneumonia. So the classification of pneumonia. So the first classification is this dependent on site of occurrence, where it is happening. Is it in the hospital, is it in the community, or is it after putting a ventilator? So we have community acquired pneumonia. So community acquired pneumonia, written as CAP. Next is hospital acquired pneumonia. Hospital acquired pneumonia, also written as HAP. Third is ventilator associated pneumonia. Ventilator associated pneumonia, VAP. Let us see one by one. So this is very important flowchart. They'll ask you what causes community acquired pneumonia, what is hospital acquired pneumonia, what causes ventilator associated pneumonia. So community acquired pneumonia, this occurs routinely in communities, and within 48 hours of hospital admission. Within 48 hours of hospital admission. Whereas hospital acquired pneumonia, this occurs after 48 hours of hospital stay. This occurs after 48 hours of hospital stay. So now a simple question. There was a patient admitted with abdominal pain today. There was a patient admitted with abdominal pain today. Tomorrow morning, if he develops pneumonia in the hospital, will you call it as hospital acquired pneumonia or community acquired pneumonia? Very important. So today a patient with abdominal pain admitted in the hospital. Tomorrow morning he has developed pneumonia. So will you call it as hospital acquired pneumonia or community acquired pneumonia? Yes. What will you call it? The answer is community acquired pneumonia, because to call it as a hospital acquired pneumonia, patient should have stayed more than 48 hours in the hospital. So this was also asked in last NEET. So what is the timeline to call it as hospital acquired pneumonia? Your answer, after 48 hours. After 48 hours. Now coming to ventilator associated pneumonia, it occurs after 48 to 72 hours of invasive mechanical ventilations. 48 to 72 hours of invasive mechanical ventilator. Now let us see what are the most commons. Come on, tell me. Most common cause of community acquired pneumonia. So what is the answer? Most common cause of community acquired pneumonia. Yes, it is Streptococcus pneumoniae. Streptococcus pneumoniae. See, admission or stay is the same. So within 48 hours of stay, after 48 hours of stay, say they're just synonyms, no need to worry. So streptococcus pneumoniae. Now if they ask you most common cause of community acquired pneumonia resulting in hospitalization. So he developed a pneumonia in community that resulted in hospitalization. He developed a pneumonia in community that resulted in severe form and ICU admission. So most common cause of community acquired pneumonia resulting in hospitalization, resulting in ICU admission. In all this, when there is community acquired pneumonia in the question, in all these scenarios, the answer is streptococcus pneumonia only. So most common cause of community acquired pneumonia is streptococcus pneumonia. With the hospitalization, streptococcus pneumonia. Resulting in ICU admission, streptococcus pneumonia. Now coming to most common cause of hospital acquired pneumonia. Most common cause of hospital acquired pneumonia. So your answer, if they ask you group of organisms, it is gram-negative bacilli. Gram-negative bacilli. If they ask you single organism, answer will be Staph aureus. Staph aureus. Staph aureus. So Staph aureus. Now coming to ventilator associated pneumonia. So in ventilator associated pneumonia, so we have early VAP. Other is late VAP. So early VAP means which happens within 5 days of invasive mechanical ventilation. Late VAP happens after 5 days of invasive mechanical ventilation. So write down early VAP. The most common here is again streptococcus pneumoniae. Next important organism is H. influenza. So whereas late VAP, the important organisms Pseudomonas, Staph aureus, and their newfound love Acinetobacter. These three are a terrible trio. Pseudomonas, Staph aureus, Acinetobacter. So these three are responsible for late ventilator associated pneumonia. So once again, let us see most important in this table. So if at all they mention community acquired pneumonia, it is streptococcus pneumonia. See, most common cause of community acquired pneumonia resulting in hospitalization means patient developed pneumonia that caused hospitalization. Patient developed pneumonia that caused ICU admission. So what is the organism they are asking? Your answer should be streptococcus pneumonia. Streptococcus pneumonia. Then hospital acquired pneumonia, most common cause will be gram-negative bacilli. If they ask you a group, gram-negative bacilli. If they ask you what is the single organism, Staph aureus. The next important thing, early ventilator associated pneumonia, streptococcus pneumonia. Late ventilator associated pneumonia, most common is Pseudomonas. But if they just ask what is the cause of ventilator associated pneumonia overall, again your answer should be Pseudomonas. Again your answer should be Pseudomonas. So for community acquired pneumonia, streptococcus pneumonia. Hospital acquired gram-negative bacilli. Early VAP, streptococcus pneumonia. Late VAP, Pseudomonas. VAP overall again is Pseudomonas. So this is the first type of classification based on site of occurrence. So where it is happening? In the community, hospital, or after ventilation. Next is based on clinical features, there is a classification. Clinically, pneumonia can be divided into two types. So it can be divided into the routinely happening typical pneumonia, unusually happening atypical pneumonia. So typical pneumonia, atypical pneumonia. So let us see the usual pattern. So consider this is the alveolus. So what happens here is initially bacteria will reach the alveoli. So to fight against this bacteria, your body will send some immune response. So interaction between bacteria and immune response will result in secretions. So this is an infection. So patient will have fever. So because of secretions within the alveoli, this patient will develop cough and these secretions will be expectorated as sputum. So there is fever plus productive cough. Unlike any other infection, there will be predominant neutrophilic leukocytosis. If you see in his blood, neutrophils will be increased. Predominant neutrophilic leukocytosis. And if you collect this sputum and see under microscope, so sputum gram staining. So this sputum is containing organisms. So sputum gram staining reveals organisms. And if you take a chest X-ray, all these secretions will appear as alveolar exudates. You can see a classical consolidatory pattern. So typical pneumonia, this is usual pattern of pneumonia. Patient will come to me and say, doctor, I am having fever and productive cough. And in his blood there will be neutrophilia. Sputum will be showing organisms. And chest X-ray will be showing alveolar exudates. So this is a classical pattern of any pneumonia. Now coming to atypical pneumonia, how is it different is what you need to understand importantly. So consider this is one alveolus and this is another alveolus. So here also the microorganisms reaches the alveoli first, but they are not interested to stay in the alveoli. So they go into the space in between the alveoli called as interstitium. So they go and start proliferating in the interstitium. So to fight against this, your body will send some immune response. So this is also an infection. So there will be fever. Now because of interstitial inflammation, there will be some irritation resulting in cough. Interstitial inflammation, irritation, there will be cough. Now how is this cough different from typical pneumonia? So in typical pneumonia there is inflammation happening in the alveoli, there were secretions. Here inflammation is not happening in the alveoli, it is happening in between the alveoli called as interstitium. So there will be no secretions. So there will be dry cough or very less, scanty sputum. And if you see in the blood, there will be only mild leukocytosis. Mild leukocytosis. So if you collect the secretions and see under microscope, can you find any organism? No. Because organism is not there in the alveolus, it is in the interstitium. Gram staining reveals no organisms. And if you take a chest X-ray, there will be no alveolar exudates. There will be no alveolar exudates. So whatever you see is called as interstitial pattern. So what is this interstitial pattern? I will show you in chest X-ray. So this is how atypical pneumonia is different. So here cough will be dry, only mild leukocytosis. You cannot identify on gram staining. So there will be only interstitial pattern, not alveolar exudates. Now coming to the causes, most common cause of typical pneumonia is again Streptococcus pneumoniae. So other important bacteria responsible: Staph aureus, Klebsiella, Pseudomonas. See, atypical pneumonia is due to infection. ILD is generally not due to infection. So ILD is different. Interstitial lung disease is a separate topic. It is not due to infection. So most common cause of typical pneumonia: Streptococcus pneumonia, Staph aureus, Klebsiella, Pseudomonas. Coming to atypical pneumonia. So what is most common cause of atypical pneumonia? So what is most common cause of atypical pneumonia? So your answer should be mycoplasma. Mycoplasma. Next important is Legionella, Chlamydia, then majority of viral pneumonias. So COVID also initially presents as an atypical pneumonia, majority of viral pneumonias. So if they ask you most common cause of atypical pneumonia, so most common cause of atypical pneumonia, your answer should be mycoplasma. Now if they modify the question like this: most common cause of atypical pneumonia, most common cause of atypical pneumonia resulting in ICU admission. So it means there is an atypical pneumonia, presentation has become severe, resulted in ICU admission. So in this scenario, answer is Legionella. So even though most common cause of atypical pneumonia is mycoplasma, in majority mycoplasma will be mild. So generally it will not result in ICU admission. But an atypical pneumonia is causing ICU admission. In majority, the reason will be Legionella. So most common cause of atypical pneumonia resulting in ICU admission, Legionella. So if they ask you most common cause of atypical pneumonia overall, mycoplasma. Most common cause of typical pneumonia, it is Streptococcus pneumonia. So first we will discuss various typical pneumonias, then we will go into atypical pneumonia. So another important table discussing the vital typical pneumonias. So make a table: Streptococcus, Staphylococcus, Klebsiella. Streptococcus, Staphylococcus, Klebsiella. Yes. Streptococcus, Staphylococcus, Klebsiella. See, COVID still it has not come into the books. It is only in this 1 year when compared to centuries. So most common compared to 2000 years versus most common in 2020, it is difficult to decide. Okay. So Streptococcus, Staph and Klebsiella. So we are going to discuss the important risk factors. So what will be the clinical features? CF means clinical features. What do you see on the chest X-ray? So what will be the treatment? So for Streptococcus, the important risk factor is smoking. And this Streptococcus is actually most common pneumonia. Most common pneumonia in alcoholics and diabetics. Most common pneumonia in alcoholics and diabetics. Most common pneumonia in alcoholics and diabetics. And clinical features, there is a sputum called as red rusty sputum. So sputum can be red, and just like rust it appears, it is called red rusty sputum. And chest X-ray shows an important feature called as lobar consolidation or lobar pneumonia. So what is this lobar consolidation? So consider this is the lung. There will be localized involvement of segment or lobe of the lung. So this is lobar consolidation, localized involvement of segment or lobe of lung. And this lobar consolidation is considered as most common pattern in community acquired pneumonia. So most common pattern in community acquired pneumonia. So treatment will be with beta-lactams. So treatment will be with beta-lactam antibiotics. So coming to staph. So staph pneumonia is also called as IV drug users pneumonia. IV drug users pneumonia. And this staph can occur as fatal pneumonia. So it can occur as fatal pneumonia post viral illness. So if at all they give you a question like this patient recently recovered from viral illness. After 4 weeks, he developed a bacterial pneumonia that resulted in death of the patient. He developed a bacterial pneumonia that results in death of the patient. What might be the bacteria? Your answer should be staph. So staph can occur as fatal pneumonia post-viral illness. And in staph, there will be mucopurulent sputum. So one can expect mucopurulent sputum. And classical chest X-ray finding in staph, it is called as bronchopneumonia. So what is this bronchopneumonia pattern? So consider this is the chest X-ray. There will be bilateral patchy consolidation. So there can be bilateral patchy consolidation. And this bilateral patchy consolidation is considered as most common pattern in community acquired pneumonia. So most common pattern in community acquired pneumonia. So bronchopneumonia is most common pattern in hospital acquired pneumonia. So if they ask you most common pattern in community acquired pneumonia, it is lobar consolidation. You can see there is involvement of a lobe, localized consolidation. Bronchopneumonia, bilateral patchy consolidation. So whenever they mention staph, you should know some specific radiological findings. So there can be pneumatoceles. There can be cavity formation. And there can also be formation of lung abscess. So we will discuss what is pneumatocele, cavity, lung abscess later on. I will show you the chest X-rays and CT scan. You will understand better. So pneumatoceles, cavity, lung abscess. Most common pattern in hospital acquired pneumonia is staph. And apart from bronchopneumonia, other important chest X-ray features pneumatoceles, cavity, lung abscess. Now coming to the treatment, nowadays by the time a patient with staph pneumonia reaches me, he will already be MRSA, methicillin resistant staph aureus. So in this, what is the drug I give? Vancomycin. But recently, even staph is becoming resistant to vancomycin. So what will be the drug in vancomycin resistant staph aureus pneumonia? It is linezolid. It is linezolid. So because recently staph is becoming very resistant even to vancomycin in the beginning itself. So whenever there is staph pneumonia in the question, I can directly go for linezolid also. So whenever there is staph pneumonia, I can directly give linezolid also, no issue. So for MRSA, vancomycin, VRSA, linezolid. See, daptomycin will not work in pneumonias. So daptomycin is a fancy drug. So it cannot get reabsorbed in the lung. Surfactant in the lung can deactivate daptomycin. So don't use daptomycin for staph pneumonia. It can be used for staph infections elsewhere. So ultimate drug for staph pneumonia as of now is linezolid. Okay. Then coming to Klebsiella pneumonia, the risk factors: alcoholism, so malnutrition. See, no doubt alcoholism is a risk factor for development of Klebsiella pneumonia. But if they ask you by number, most common pneumonia in alcoholics is still streptococcus. Then coming to clinical features, there will be red currant jelly sputum. So it will be red and gelatinous, very thick. So this phenomena is called as red currant jelly sputum. So red currant jelly sputum is Klebsiella. Now coming to the chest X-ray feature. So if you see, this is the lung, and let this be the horizontal fissure. Klebsiella will cause dense right upper lobe consolidation, very heavy consolidation. So because of this heavy consolidation, what will happen? The horizontal fissure, which was straight previously, because of the weight of the consolidation, it can slightly bulge down. So the horizontal fissure is straight like this. Because of dense consolidation, it will bulge down like this. So this phenomena is called as right upper lobe consolidation, the classical feature in Klebsiella pneumonia, with bulging fissure sign. So right upper lobe consolidation with bulging fissure sign. And next important is Klebsiella pneumonia can also cause pneumatocysts. It can cause pneumatocysts. It can cause cavity. It can also cause lung abscess. So pneumatocysts, cavity and lung abscess can be seen with Klebsiella pneumonia also. Whereas the treatment, it is combination of beta-lactam with aminoglycoside. So let us have a brief revision. So whenever they mention streptococcal pneumonia, look for lobar consolidation. When they mention staph pneumonia, look for bronchopneumonia pattern. When they mention Klebsiella, look for bulging fissure sign. So look for bulging fissure sign. Okay. So these are the classical presentations of Streptococcus, Staph, Klebsiella. Next important typical pneumonia is Pseudomonas. So write down Pseudomonas. So where is this frequently happening? So this frequently occurs as ventilator associated pneumonia. If they ask you most common cause of pneumonia in bronchiectasis, cystic fibrosis, structural lung diseases. Most common cause of pneumonia in bronchiectasis, cystic fibrosis, structural lung diseases. So if you find any one of this in the question, your answer should be Pseudomonas. Along with Pseudomonas, its best friend can also cause Staph aureus, but it is next. So most common cause of pneumonia in bronchiectasis, cystic fibrosis, structural lung disease is Pseudomonas followed by Staph aureus. Coming to the clinical features, patient will have fever. There will be mucopurulent sputum. Sometimes greenish sputum is also seen. So mucopurulent green colored sputum can be seen. And on the chest X-ray, bilateral infiltrates on chest X-ray. Now treatment, very important. So for Pseudomonas, you should give combination of drugs. So combination of anti-pseudomonal beta-lactam. So a beta-lactam with anti-pseudomonal activity. So this is the most important drug, anti-pseudomonal beta-lactam. So this is Pseudomonas. So same thing, we also use treatment for ventilator associated pneumonia because most common is Pseudomonas. Anti-pseudomonal beta-lactam. So can you give me examples of some beta-lactams with anti-pseudomonal activity? Anti-pseudomonal activity, yes. So piperacillin, tazobactam, cefoperazone, sulbactam, meropenem. So these are frequently used anti-pseudomonal beta-lactam. So in majority of ICUs. So piperacillin, tazobactam, cefoperazone, sulbactam, meropenem. So along with that, we can add a fluoroquinolone or aminoglycoside. So very important for treatment of Pseudomonas, anti-pseudomonal beta-lactam with fluoroquinolone or aminoglycoside. Now next important pneumonia here that I am going to discuss is Acinetobacter. So Acinetobacter also occurs as ventilator associated pneumonia. So also occurs as ventilator associated pneumonia. So if they ask you treatment, which was asked recently, initially for Acinetobacter we start with carbapenems. So if the Acinetobacter becomes resistant to carbapenems, the next drug we give here is colistin. Recently asked question, which of the following is useful in management of Acinetobacter ventilator associated pneumonia? In the options there was colistin. In the options there was colistin. So for treatment of Acinetobacter pneumonia, initially we give carbapenems. So if at all the organism becomes resistant to carbapenems, we go for colistin. So recently asked question, JIPMAR, which of the following is useful in treatment of Acinetobacter? The correct answer was colistin. The correct answer was colistin. Now this is regarding important typical pneumonias. Now let us see important atypical pneumonias. Important atypical pneumonias. So we are going to discuss Legionella mycoplasma. Important atypical pneumonias, Legionella mycoplasma. Let us start with Legionella. So Legionella, most common method of transmission. Most common method of transmission is aspiration followed by aerolization. Aspiration followed by aerolization. Then why is it aspiration and aerolization? Because it is generally spread through contaminated water. Contaminated water. See, why will Legionella pneumonia usually happens? So it happens because of drinking contaminated water. So Legionella spreads through contaminated water. So the patient drinks that contaminated water. Later the organism can get aspirated into the lungs or inhaling aerosols generated from contaminated water. Inhaling aerosols generating from contaminated water. But most common method is aspiration followed by aerolization. So whenever I discuss about Legionella pneumonia, there are some special features. So what are the special features of Legionella pneumonia? Along with pneumonia, these patients can have associated diarrhea, gastrointestinal features. So diarrhea. So there can be some CNS manifestations, headache, confusion, and due to systemic involvement, there can be altered liver function test, altered LFTs. And because of diarrhea, fluid loss, ultimately there can also be hyponatremia. So associated diarrhea, apart from pneumonia, there will be diarrhea, headache, confusion, altered LFTs, and these patients can also have hyponatremia due to fluid loss and other reasons. And second important thing is, this is an atypical pneumonia. If you collect some sputum and see, gram staining reveals no organisms. So gram staining reveals no organisms. And third important thing is, there will be poor response because of some unknown reason. Beta lactams will not work here. So poor response to beta lactams. So routinely for pneumonia we give beta lactams, but here beta lactams will not work in Legionella pneumonia. And this pneumonia occurs more in old age and also immunocompromised. Old age and also immunocompromised. And next important thing is, if you find in the question occurrence of illness, 10 days after discharge from hospital, occurrence of illness 10 days after discharge from hospital. So one suspicion is Legionella. So what is this special feature of occurrence of illness 10 days discharge from hospital? See, these patients when admitted in hospital may be exposed to Legionella from contaminated water. In hospitals there will be contaminated water. So these patients might be exposed to Legionella. So Legionella pneumonia has variable incubation period. So it varies from 7 to 10 days. So today this patient might have inhaled Legionella. After few days he might have discharge. So at home also Legionella can manifest later on because it is having an incubation period of 10 days. So today patient might be exposed. After 5 days he might have discharge, and later at home this pneumonia can also manifest. So patient can get infected in the hospital and later on in the home within 10 days this pneumonia can develop. So that's why occurrence of illness 10 days after discharge from hospital, if you find in the question, one reason is Legionella. Then coming to mycoplasma, as we have discussed, most common atypical pneumonia. Most common atypical pneumonia. So this is also called as walking pneumonia. This is also called as Eaton agent pneumonia. Eaton is the name of the scientist. Eaton agent pneumonia. Now what is this peculiar? I call this as funny also. What is this funny walking pneumonia? What does this mean? See, whenever a patient is having lung disease, because lungs are responsible for oxygen, so when he is having a lung disease, he becomes tired easily. So because oxygenation might be affected, he will be usually taking rest. So he will be usually taking rest. But mycoplasma pneumonia generally causes very mild pneumonias. Very mild pneumonias. So patient might be having pneumonia, but still he will be doing his routine activities like walking. So it means that in spite of pneumonia, because it is a mild disease, patient will be active and walking. So that's why it is called as walking pneumonia. So don't ask which is called as running pneumonia. There is nothing like that. Mycoplasma pneumonia, because it is a mild disease, patient will be active and be doing his routine activities. So it was called as walking pneumonia. So write down, whenever we discuss mycoplasma pneumonia, we should discuss its extrapulmonary features. So these are very, very rare. Extrapulmonary features are very, very rare, but once asked as a question. So within the skin, there can be erythema nodosum. In the CNS, rarely it can cause encephalitis. Rarely mycoplasma pneumonia can result in Guillain-Barré syndrome. So within the blood, one can identify increased cold agglutinins. So this can later on also cause hemolytic anemia. So if at all in a question they mention pneumonia diarrhea combination, answer should be Legionella. Pneumonia hemolytic anemia combination, answer should be mycoplasma. Very important. Pneumonia diarrhea, it is Legionella. Pneumonia hemolytic anemia, it is mycoplasma. And within the heart, it can cause myocarditis, pericarditis, and within the joints, it will cause arthritis. So why altered LFTs in Legionella? See, Legionella can cause systemic involvement. So whenever the liver is involved, there can be altered LFT. So in any infection during sepsis, there will be multi-organ damage. It is a severe pneumonia. Legionella can cause severe pneumonia. So there can be altered LFTs initially. So joints will result in arthritis. And one important thing here is there is no cell wall. There is no cell wall. Now, how does this feature of mycoplasma not having a cell wall influence me in treatment? So, whenever there is no cell wall, a common drug cannot be used here. What is that common drug? Yes, what is that common drug? Yes. So, the common drug is beta-lactam. The common drug is beta-lactam because beta-lactam requires cell wall to exert its function. Because there is no cell wall in mycoplasma organism, so beta-lactams will not work here. So there is something common between Legionella and mycoplasma. Because both are atypical pneumonias, routinely you cannot identify them on gram staining. So in both, beta-lactams will not work. So let us discuss diagnosis and treatment common for both. So complete the table now. So in the table, we are going to discuss diagnosis and treatment common for both of the pneumonias. So for diagnosis, we generally rely on serology. So we look for antigen of the organism or antibodies against the organism, or we can go for PCR. So PCR means polymerase chain reaction. Polymerase chain reaction. So in polymerase chain reaction, we identify the precise genetic material and we can know whether it belongs to Legionella or mycoplasma. Now coming to treatment, for both of the pneumonias, any one of the following drug can be given. Either fluoroquinolones or macrolide or tetracycline. So let it be Legionella or mycoplasma. You can give any one of this drug, any one of this drug. So either fluoroquinolone or macrolide or tetracycline, either fluoroquinolone or macrolide or tetracycline. But if they specifically ask what is best for Legionella, So what is best for Legionella? Your answer should be fluoroquinolone. So fluoroquinolones, the two respiratory fluoroquinolones such as levofloxacin or moxifloxacin. If they ask you what is best for mycoplasma, what is best for mycoplasma, your answer should be macrolide, and preferred macrolide is generally azithromycin. So very, very important. So for treating either of this pneumonia, you can give fluoroquinolone, macrolide or tetracycline. But if they specifically ask for Legionella, it is fluoroquinolone. For mycoplasma, it is macrolide, and preferred macrolide here is azithromycin. Preferred fluoroquinolone, we give levofloxacin or moxifloxacin. Levofloxacin or moxifloxacin. So we will discuss VIP, very important pneumonia, and then we conclude. So coming to VIP of all pneumonias, that is nothing but pneumocystis pneumonia. So whenever I say pneumocystis, what is the first disease that comes into your mind? Whenever I say pneumocystis, what is the first disease that comes into your mind? It is HIV. It is HIV. So write down pneumocystis pneumonia. Interestingly, HIV was only discovered because of pneumocystis pneumonia. So write down this pneumocystis pneumonia is a very, very important pneumonia. So it is a pneumonia in immunocompromised. So pneumonia in immunocompromised. So what does this mean? It means infection can occur in any, but disease only in immunocompromised. It means anybody can inhale pneumocystis and can get infected with pneumocystis. But for the disease to be manifested, patient should be immunocompromised. Anybody can get infected with pneumocystis, but for disease to manifest, that patient should be immunocompromised. And most important immunocompromised condition is HIV. So let us see what is most common opportunistic infection. Most common opportunistic infection in HIV worldwide. So let us see most commons in HIV. Most common pulmonary manifestation. Most common pulmonary manifestation in HIV. So all these are worldwide only. Most common cause of pneumonia in HIV. Most common cause of pleural effusion in HIV. Most common cause of fungal pneumonia in HIV. So these are the important questions. Lot of controversies. Let us solve this with authenticity. So whenever they ask you most common opportunistic infection in HIV worldwide, single best answer right now is tuberculosis. Most common pulmonary manifestation in HIV. So whenever a patient with HIV reaches me with some respiratory symptoms, first thing what I should suspect, some infection in his lung. So what is infection in lung called as pneumonia? And what is the cause of that pneumonia? It is again tuberculosis. Now what is most common cause of pleural effusion in HIV? Again it is tuberculosis. What is most common cause of fungal pneumonia in HIV? So don't forget that pneumocystis is a fungus today. Yesterday it was grouped as a protozoan. Tomorrow what it will be, nobody knows. So till then, if they ask you fungal pneumonia in HIV, your answer should be pneumocystis. Most common opportunistic infection, TB. Pulmonary manifestation in HIV, pneumonia. Most common pneumonia in HIV overall, TB. Most common cause of pleural effusion in HIV is also TB. So this is what we have up to now. In opportunistic infection, TB, pulmonary manifestation, pneumonia, and most common fungal pneumonia in HIV, pneumocystis. So then let us see the risk factors. So what are the risk factors for development of pneumocystis? See, all are worldwide, okay? All are worldwide. So risk factors. So one is CD4 count less than 200 per microliter in HIV patient. Patient who has underwent organ transplant. Patients on long-term immunosuppressive therapy. So patients on long-term immunosuppressive therapy such as chemotherapy. Already patients with some primary immunodeficiency. So patients with some primary immunodeficiencies. So out of this, most important is CD4 count less than 200 per microliter in HIV. Now coming to the clinical features. So these patients will have fever, and pneumocystis presents as an atypical pneumonia. So dry cough, there will be fever, dry cough, and they can have shortness of breath. So fever, dry cough, shortness of breath. Fever, dry cough, and shortness of breath. So pneumonia means not just acute, even chronic pneumonias can also happen. TB is one of the most important cause of chronic pneumonias. So clinical features, fever, dry cough, shortness of breath. Now coming to chest X-ray features. So very important. So consider this is the lung. Initially, the patient's lungs might be having pneumocystis, but the changes may not be visible on chest X-ray. So initially, chest X-ray will be normal. So later on, there will be bilateral perihilar infiltrate. So patient might be having clinical features, fever, dry cough, and shortness of breath. So chest X-ray initially can be normal. So then you can notice bilateral perihilar infiltrates. Bilateral perihilar infiltrates. As disease progresses, there will be bilateral interstitial infiltrates. So that can become bilateral diffuse interstitial infiltrates. Bilateral diffuse interstitial infiltrates. And one more important thing is, in pneumocystis pneumonia, pneumatoceles and pneumothorax can also be seen. These are not that common, can be seen. So common will be bilateral perihilar infiltrates and bilateral diffuse interstitial infiltrates. So these are the important features. Initially chest X-ray is normal. Later there will be bilateral perihilar infiltrates and bilateral diffuse interstitial infiltrates. Previously asked question. A normal chest X-ray in HIV patient can rule out pneumocystis pneumonia. Is it a true statement or false statement? A normal chest X-ray in a patient with HIV can rule out pneumocystis pneumonia. Is it a true statement or false statement? It is a false statement, because initially in pneumocystis pneumonia, chest X-ray will be normal. So patient might be having a disease, but still chest X-ray can be normal. A normal chest X-ray in HIV cannot rule out pneumocystis pneumonia. Now coming to the diagnosis. So for diagnosis of pneumocystis pneumonia, what is the best sample. So sample should be ample. So that ample sample in pneumocystis diagnosis is bronchoalveolar lavage. So when compared to routine sputum. So why is bronchoalveolar lavage very important in diagnosis of pneumocystis? I told you pneumocystis pneumonia is an atypical pneumonia. So you don't find organisms in the sputum. So whenever I put a bronchoscope into the lung, so through that bronchoscope, I will inject some saline. So that saline can go into the alveoli, hit the alveolar walls and bring the organism. So you are forcibly injecting some saline in bronchoalveolar lavage. So that saline will go into the alveoli. So it will bring organisms from the wall. So this is alveoli. Whenever I send the saline, it will go and hit the alveolar walls. From the alveolar walls, if I again withdraw the saline, you can get organism. So for diagnosis of pneumocystis, the ideal sample is bronchoalveolar lavage. The ideal sample is bronchoalveolar lavage. So now I have taken the bronchoalveolar lavage. What I should do? I should visualize this cyst. So I am not sending for culture. I should visualize this cyst with some special stains. So what are those special stains? Right, Giemsa stain, Gomari, methamine silver stain, Gomari methamine silver stain, and recently we are having a new technique called as immunofluorescent staining. Immunofluorescent staining. So I should visualize this cyst with any one of this method, either right Giemsa stain, Gomari methamine silver stain, or immunofluorescent stain. Now I have diagnosed it as pneumocystis. What is the drug of choice in treatment? So what is the drug of choice for treatment? So what is the drug of choice for treatment of pneumocystis? If this is pneumocystis, this is what cotrimoxazole do. Drug of choice for pneumocystis pneumonia is cotrimoxazole. So cotrimoxazole will make pneumocystis run for its life. So drug of choice for treatment of pneumocystis pneumonia is cotrimoxazole. And what is the drug of choice for prophylaxis? In few patients such as HIV, I should give prophylaxis against this disease. Drug of choice for prophylaxis is also cotrimoxazole. Drug of choice for prophylaxis is also cotrimoxazole. Then, if few patients cannot tolerate cotrimoxazole, what are the alternate drugs available? So we have first combination trimethoprim plus dapsone, clindamycin plus primaquine, atavaquone, pentamidine. So these are the alternate drugs apart from cotrimoxazole helpful in treatment. Alternate drugs. So if at all patient is not tolerating cotrimoxazole, they will ask you what are the alternate drugs helpful in management. So we have trimethoprim plus dapsone, clindamycin plus primaquine, or monotherapy with atavaquone, pentamidine. But for all practical purposes, if you find pneumocystis in the question, straightforward answer should be cotrimoxazole. So for both for treatment and prophylaxis, single best answer is always cotrimoxazole. Now next question in this is, what is the role of steroids in pneumocystis pneumonia? What is the role? So we'll complete this concept and we will conclude for today. So what is the role of steroids in pneumocystis pneumonia? So will you routinely give steroids or you should avoid steroids? Will you routinely give steroids or will you avoid steroids? See, pneumocystis is a pneumonia in immunocompromised. So generally I will try to avoid steroids. But in few conditions, especially in severe pneumocystis pneumonia, what happens is there will be huge amount of fungus in the lungs. So severe disease means lot of fungal load in the lungs. So whenever I give cotrimoxazole, this cotrimoxazole suddenly destroys the fungus. So whenever huge amounts of fungus is destroyed, those fungal filaments will be released that results in an inflammatory reaction, hyperinflammatory reaction. So already patient lungs are bad. Now if there is a new inflammatory reaction, his condition will become worse. So to bring down that inflammatory response, a short course of steroids are helpful. So steroids are not used in mild to moderate disease, generally in severe cases where there is huge fungal load. So write down during treatment in severe pneumocystis pneumonia. So during treatment in severe pneumocystis pneumonia, so severe means patient will be having hypoxemia. So oxygen carrying capacity or oxygen transfer capacity will be decreased. So here the cutoff is taken as 70, PaO2 less than 70 mmHg. So in severe PCB, lung will contain huge amounts of pneumocystis. Now if you give cotrimoxazole, suddenly all those pneumocystis will be destroyed. So there will be degradation of large amounts of pneumocystis. So once the fungus is destroyed, the fungal filaments can result in a severe inflammatory response. Already patient's lungs are in a bad situation. Now if there is an inflammatory response, his condition will become worse. So to bring down this inflammatory response, we can give steroids. So steroid therapy can blunt this inflammatory response. So point to remember here, even in severe pneumocystis pneumonia, the drug of choice is still cotrimoxazole. Definitely you should give cotrimoxazole. Along with cotrimoxazole, steroid is an additional therapy. So kindly remember, in severe pneumocystis pneumonia also, cotrimoxazole should be given. Cotrimoxazole will destroy the fungus. Steroid therapy will decrease the inflammatory response because of these fungal filaments. So this is the reason why we use steroids. Are steroids recommended in all cases of pneumocystis pneumonia? No. They are only recommended in severe PCP, PaO2 less than 70. Why? Whenever you give cotrimoxazole, fungus is destroyed. That fungal filaments can cause hyperinflammatory response. So to bring down that inflammatory response, steroid therapy is helpful. So very, very important. Even here also drug of choice is cotrimoxazole. Okay. So we'll conclude for today. So I'll be available for another 10 to 15 minutes. Any doubts up to now, you can get clarified. So slide of typical and atypical. So all these are important tables. I tried to compile respiratory medicine in tables so that it will be very easy for you to revise. So pneumonia means lung should be involved. You are asking sore throat, and sore throat means only your throat is involved. There are no lung symptoms. So sore throat means involvement of your throat. Pneumonia means patient should have either fever, shortness of breath, chest pain, cough. సో తెలుగు డైలాగ్. సో తెలుగులో మాట్లాడమని చాలా మంది అడుగుతున్నారు. Yeah, thank you so much. It was an awesome experience. So sharing with you concepts of respiratory medicine. So tomorrow by 9 o'clock, we'll try to start with the rest of pneumonia, and so many diseases are waiting for you. So we'll make it a worthy experience. సార్ ఒక్కసారి తెలుగులో మాట్లాడండి. సో శుభరాత్రి and good night. So this is the last slide.